Good morning, esteemed guests. I trust that you were able to rest last night. For those of you who were not with us last night, I am Dr. Rogelio Ribas. I'm the Corporate Vice President of Baptist Health International. And before we begin, which is custom for us, my privilege to invite Chaplain Renato Santos, Assistant Vice President of Pastoral Care Services of Baptist Health, to lead us in the invocation. Renato.
Good morning and welcome to everybody. Thank you, Dr. Ribas. Exciting moment. I was surrounded by Salvadorians at breakfast this morning, and happy to, there we go, and happy to see such a wonderful representation from across the Americas. It's quite something to see so much gifting and stellar representation from all over the place in one single room here. As Dr. Ribas mentioned, as it is customary for us at Baptist Health, we begin oftentimes our programs with a moment of reflection. Central to our identity as an institution is our commitment to total person care, which includes concern and attention and care for emotional, psychosocial, and spiritual components of our experience. So in a moment, I'll invite you to, if you would choose, join me in a word of prayer. But the one who creates and imbues us, humans, with intelligence and ingenuity and resourcefulness, also invites us as professionals, as leaders, to be co-creators of change and innovation in care, and as a result, agents of healing and hope for the people entrusted to us. We honor God when we translate our discoveries and we apply our skills in healthcare to level a playing field, to promote access and equity, and to build healthier communities. So today we're blessed to know that we have the resources and we have the means to do so. And our prayer is that as iron sharpens iron, to use that sacred term, you will spur one another on to excellence in healthcare and the world-class medical service and care to people entrusted to you. So in view of this unique opportunity, this conference today, I'd like to invite you to take a moment and pause with me as I lead us in the word of prayer. Eternal God, we thank you for the gift of this day. We pray your blessings upon this conference as knowledge is shared, connections made, relationships forged. We ask that you would multiply efforts to great effect and impact here and beyond. And for you here today, I pray that you may be steadfast as healers, life changers. And may God bestow upon you strength, discernment, and wisdom sufficient for each day. And as you exercise this most noble of professions, and may we all together live compassionate of heart, clear in word, gracious in our awareness of each other, courageous in thought, and generous in love. And may God bless you, and may God protect you and prosper you in all you do. Amen. God bless.
Thank you, Chaplain Renato, for your inspiring words. On behalf of Baptist Health, I want to thank you all for being here today. A special thanks to our presenters for their time and sharing their expertise with us. I want to also express my deepest appreciation to our guests who have traveled from afar. Some made it last night to be with us here and to be able to share knowledge and to be able to see all the new alternatives to care that exist. En nombre de Baptist Health, me gustaría agradecerles a todos por acompañarnos hoy y la bienvenida a nuestros viajantes que vienen de Latinoamérica y el Caribe para también poder intercambiar información, soluciones y tratar de cuidar todos nuestros pacientes. Baptist Health is the largest non-for-profit healthcare system in the region, encompassing 12 hospitals, over 27,000 dedicated employees, 4,000 skilled physicians, and 200 outpatient facilities and physician practices, spanning across 4 counties. Our system consists of internationally renowned institutes specializing in cancer care, brain and spine care, heart and vascular care, orthopedic care, and setting the standard for excellence in healthcare in our area. We are consistently recognized as one of the best companies to work for by Fortune magazine, one of the most ethical organizations in the country, and among the nation's best hospitals as ranked by U.S. News and World Report. This year, Baptist Health, once again, was recognized as the most awarded healthcare system in South Florida, according to the latest U.S. News and World Report survey. All of our institutes received top rankings, with Baptist Health in the top 10 percentile nationally for cancer care, as well as for treating neurology and neurosurgery patients. Additionally, Miami Cancer Institute was named the #1 cancer program in South Florida. Doctors Hospital earned the #1 ranking in South Florida for treating complex orthopedic cases. These achievements reflect our steadfast commitment to excellence in patient care. Miami Cardiac and Vascular Institute, our first institute, has added expert surgeons to support the already globally recognized endovascular care. Nearly 29 years ago, Baptist Health made a strategic investment in developing its international operations. And today we are proud to have one of the largest hospital-based international healthcare programs in the U.S. Prior to the pandemic, we facilitated over 14,000 patient visits each year for more than 100 countries. Thanks to the support from our leaders, our President CEO that you met last night, Mr. Bo Bollinger, the senior leadership team, and with us here today, our leader, Alex Villoch. At Baptist Health International, our dedicated team works tirelessly to uphold our mission, delivering the highest level of care and support to our patients and physician colleagues locally and globally. Our commitment to family-centered care remains unmatched, with a welcoming, multilingual, and culturally diverse team dedicated to delivering first-class, patient-centered experience. We take great pride in welcoming patients to our city and collaborating closely with physicians to ensure their needs and expectations are met. Whether it's an air ambulance transfer or commercial air transfer to arranging accommodations, Baptist Health provides personalized 24-hour services to our international patients. Our organization is a global leader in healthcare and a premier provider in this region. We are committed to compassionate, high-quality care and believe in the relationship model rather than the transactional model. With that, I would like to play a brief video highlighting Baptist Health's work.
Hope when you take that jump, don't feel the fall. Hope when the water is, you built a wall. Hope when the crowd screams out, screaming your name. Hope when the moment comes, you'll say, I did it all. Oh, I did it all. I owned every second this world could give. I saw so many places, the things that I did. There was every broken bone. I swear I live. Hope that you spend your days, but they all add up. When that sun goes down, you raise your cup. Oh, I wish that I could witness all you joy and all your pain. But until my moment comes, Second, this world could give. I saw so many places, the things that I did. There was every broken bone. I swear I live.
Still get excited when I see that video. And now it's my pleasure to introduce Mrs. Alex Villoch, the Chief Executive Officer of Baptist Health Foundation and our leader, to share a few words.
Good morning, everyone. Thank you, Roger. Buenos dias, bon dia. Thank you very much for joining us today. We are so very pleased to welcome you again. Every year, as Roger said, we welcome patients and their families from around the world, right here to Miami, to benefit from our medical expertise. At Baptist Health, our core values, people, belief, compassion, excellence, integrity, transparency, shape the exceptional and extraordinary experience that we offer to everyone, our employees, our physicians, our patients, and the broader community. And for you here, we define our community, not just the 4 counties where we have physical facilities, but really Central America, Latin America, the Caribbean, the world, where we welcome patients to feel the warmth that we say exemplifies our care. We share these values. They unite us, they inspire us, they guide how we work every day, and they align with our pineapple symbol. The pineapple is a universal symbol of hospitality, of open doors, of feeling welcomed. Our people are the heart and soul of Baptist Health, and our values define who we are, setting us apart from other healthcare organizations. These values are more than just ideals. They influence every decision we make, every process we put in place, every program that we have in place, and everyday actions, enabling us to serve each other and our community with excellence. Our success is driven by a culture of quality and dedication that is ingrained in every member of the Baptist Health family. Their generosity, compassion, and unwavering commitment to clinical and service excellence have established us as South Florida's premier healthcare organization. In just 7 years, as an example, Baptist Health Miami Cancer Institute, which many of you had the opportunity to tour last night, and if you haven't toured it, please don't leave without having a tour there, has experienced unprecedented growth, making it one of the nation's most recognized cancer programs. It is on track to becoming the leading destination cancer center in the hemisphere. Baptist Health Cancer Care is recognized as one of the top cancer programs in the nation, ranking in the top 10% for treating the most complex cases. And Baptist Health Miami Cancer Institute was recently named the #1 cancer program in South Florida. I would also say, if you didn't see the construction just behind us, we already put shovels in the ground for the new Women's Cancer Center that will be part of the Miami Cancer Institute, bringing under one roof all the care that women, which are one of our most significant number of volumes that we see at MCI, in a very specialized building that we will open up the doors in 2026. I would also say, Roger mentioned our other institutes. You will be shortly hearing your first panel will be from the Miami Neuroscience Institute. Within 4 short years, that institute is now nationally ranked as 39th in the nation. In just 4 short years, and you're going to hear from the magnificent doctors, 2 of which have taken care of me and operated, one of them that you'll hear from that was my surgeon, that specializes in complex spine care. It is really remarkable what we offer here. We are pioneering medical advancements and the best in technology that we have available. We take immense pride in the work done on our campus here and across our entire system. At Baptist Health, we look towards the future of healthcare in our region with research, training, and education as one of our top strategic priorities. Our expanded partnership and affiliation with Florida International University's Herbert Wertheim College of Medicine strengthens this vital alliance and further supports our commitment to not only research, but education. Through collaboration, along with this partnership with Florida Atlantic University's Charles E. Schmidt College of Medicine up in Palm Beach, we are enhancing our research and educational initiatives. We aim to improve healthcare in our region while training and retaining highly skilled physicians right here in South Florida so that we can continue to provide this incredible service for generations to come. By providing access to the latest in clinical trials, in treatments, we offer patients and their families hope for today and for many years to come. This continuous advance in technology, combining with our unwavering focus on compassion, empowers us to deliver the highest quality of care to you and your patients. We are deeply grateful for the passion and commitment of our physicians, our research teams, and our employees who make it possible to pursue groundbreaking, impactful work every single day. We thank you, le damos las gracias por la confianza que usted pone en traer y mandar a sus pacientes aquí a Baptist Health. We thank you for the trust you place in us for taking care of you, your loved ones, your patients, and sending them here to Baptist. Muchísimas gracias. Que disfruten el día. Thank you so very much. Thank you, Roger.
Thank you, Alex. We're glad you were able to make it. We now will begin the first module of the day featuring experts from the Baptist Health Miami Neuroscience Institute. You saw in the video the leader on a scooter of the MNI, but Dr. Tolchin will guarantee he took away that scooter, right? He's not allowed to use it anymore. So the panel will be moderated by Dr. Ronald Tolchin, Chair of the Non-Surgical Spine Care and Rehabilitation, and the Irma and Coleman Bass Endowed Chair in Pain and Rehabilitative Medicine. Dr. Tolchin will be joined by Dr. Raul Vasquez-Castellanos, Director of Complex Spine Surgery, Dr. Guilherme Dabos, Co-Director of Interventional Neuroradiology and Director of Fellowship Training Program, Dr. Vitaly Seelman, Director of Cerebrovascular Surgery and Epilepsy Surgery and Co-Director of Skull-Base Surgery, Dr. Evan Bander, Director of Endoscopic Skull-Base Surgery and Co-Director of the Pituitary Tumor Program, Dr. Justin Sporer, Director of Functional Neurosurgery, and Dr. Luis Felipe Torres, Director of the Epilepsy Program. Doctor.
Good morning, everyone. It's great to see such a great crowd out here, and welcome to our International Symposium. I am Ron Tolchin. I'm going to be your moderator today. I'll try to keep us on track. And I am just, I've been at Baptist for a little over 12 years. I'm the chair of non-surgical spine and rehabilitation. And I've been so blessed to be around a great group of colleagues of mine, some of whom you're going to meet this morning. As Alex Villoch mentioned, that we are ranked 39th in the nation for neurology and neurosurgery. And it's a great accomplishment under the direction of Dr. Michael McDermott, who you did see on a scooter. After breaking both wrists, he learned very quickly not to do that anymore. And now he's got a golf cart. So I'm going to move on and introduce our first speaker. You're in for an exciting morning, let me tell you. We have our world-class speakers here. All of them are nationally known in their areas of expertise, and just a pleasure to work with. And you'll see really great lectures from them, and I'm so excited to share that with you. So our first speaker today is, I've known Dr. Vasquez, Raul Vasquez, for the past almost 6 years. He is our Director of Complex Spine Surgery at Baptist Health. He specializes in the surgical treatment of complex spinal disorders, tumors, degenerative spine, scoliosis, and other spinal deformities, revision surgeries, and also some neurotrauma as well. But he came to us from the University of Puerto Rico, where he trained for his medical school and then did his residency in neurosurgery at University of Florida. So he's a Gator. We have a couple Gators here today. And maybe you coming from outside the country don't know what that is, but it's the alligator mascot for the University of Florida. It gets very big down here with University of Miami fans and Florida State fans. It's really very, very controversial. And then from there, he did his postdoctoral training, including 2 fellowships, one a clinical research fellowship at the National Institute of Health, and then a second one in complex spine surgery at Vanderbilt University in Nashville. And before joining us, he worked in Kentucky. So he's been all over the Deep South, finally ending up here in South Florida. We're so happy to have him. He serves as an editorial reviewer for several journals in neurosurgery. And he's nationally known and invited speaker all over the country and even outside the country. And he's part of a number of neurological associations and societies. So it's with great pleasure that I introduce my colleague and friend, Dr. Raul Vasquez.
Good morning. Bienvenidos. So today I'm going to talk a little bit about what we do every day and in terms of in the world of complex spine neurosurgery, scoliosis surgery, and the new paradigm shift that we're doing in what we call the medical decision making. We have reached a good advancement in technology, especially here at Baptist, with neuronavigation, computer, robotic surgery, but we have encountered some challenges when it comes to the medical decision making. I have no disclosures. The objective of this talk is to get an overview of the spine care, understand the pathophysiology of what we do, scoliosis, spinal pathology. I will talk a little bit about scoliosis, what we call post-laminectomy syndrome, patients that had failed back surgery and need a revision surgery. And we're gonna introduce the new concept that if anyone talking about spine in the world right now, in all the meetings, are talking about now biological age, biological resilience, and the impact on duration of symptoms when it comes to determine to do surgery on a patient. So why spine care is the incidence is extremely high. We all, at least at some point, is gonna have an episode of back pain in our lives due to an injury or degeneration. It's very prevalent and the incidence is high and keeps going higher as the population is aging. It costs a lot of money. It's at least number 2 most visit to a doctor after a common cold. And it's one of the main source of disability. And it costs a lot of money. So the spine is a complex 3D mechanical structure, and we can go into the details of the anatomy. Is the core of our stability, our independence, and walking. The biomechanics of the spine is very complex. It's a living component of organ with different forces, muscle that is influenced by the gravity. So the different regional anatomy have different biomechanics, and that's why when we talk about spine, we evaluate patients come, I just have back pain. It's like, why are you checking my neck or my arms? Because it's all interconnected and related. Most likely, if you have severe degeneration in your lumbar spine, there's some pathology undergoing in the cervical, and it's very common. The causes, we know they could be anywhere from trauma, from cancer, or just disc degeneration. The bulk of what we do here at Baptist, and when we come to spine care, it relies on decompressing the nerve, stabilizing the spine, and it is interesting because different from cancer, this is a a quality of life decision most of the time. No one's gonna die from a sciatica pain, but they're not gonna be able to ambulate or walk independently. In the US, the number of spinal fusion has increased dramatically in the last 20 years. Number one because of access to the care, and also because of the technology and the amount of trainees that we have in both orthopedic surgery and neurosurgery. I'm a neurosurgeon, brain and spine by training, but I also, part of my fellowship included some orthopedic training. So we have reached now that combination of both specialties, and it comes to the part of like treating the spine by decompressing the nerve and stabilizing the spines with rods and screws and fixation. In order to understand this spinal pathology, we need to understand the physiologic processes, the structural, biomechanical components, and that way we can understand what the patient is feeling, like how they're feeling in terms of the pain, the disability. Understanding the disability that a patient is undergoing could be more important than just understanding the images. So it requires a complex understanding of this organ that we call the spine, and this is a representation. The specific problems, like I mentioned, is most common degeneration of the disc that leads to a radiculopathy, to a stenosis, both lumbar, cervical, thoracic, tumor, and even emergencies. I like to put this representation here on the screen because it's kind of like, aging is not a disease. I mean, we're all aging, sorry to tell you, and this is all gonna happen to us. I mean, it's, and my talk is gonna be both about complex spine, but we're gonna talk about aging. And because that's what leads to the pathologies in the spine most of the time. The classic radiculopathy, the sciatica, and coming from someone that had once a herniated disc in the neck is very disabling. Even the amount of pain, not able to sleep, I mean, it's a big source of disability. Then as we keep aging, then we have the nature of the stenosis and the classic shopping cart sign, right? Like we call it neurogenic claudication that leads from the lumbar stenosis. So how we go from the left to the right, so there's a patient that had like two surgeries before. She persisted with pain, a lot of sciatica, disability, inability to walk, and then we go and do a definitive correction. The patient selection, I mean, we see anywhere from 30 to 45, 50 patients a week in consultation. I see a lot of international patients. Somehow I became the Casa de Campo neurosurgeon. I'm Dominican, but I grew up in Puerto Rico, so. And we see these every day. So how that happened, how to decide you are a suitable candidate for surgery or not. So when it comes to adult spinal deformity, the risk assessment tools is something that kind of like you grab to it, you hold on to you get anything that you can to help you make that decision, because it's not uncommon, right? Like we see that every day from a thyroid disease to a surgery, the patient that you do exactly the same, one do well and the other doesn't. So how we select this patient and how we determine that a patient is candidate or not for these kind of operations. We have different assessment tools. The more classic one is the ASA, is the American Society of Anesthesiologists score. There is another comorbidity index, the Charlson. And then we have got now to the point of developing predictive models based on quantifying complication risk and spine-specific outcomes that can predict pseudoarthrosis, proximal junctional kyphosis. Pseudoarthrosis is when we put all these rods and screws and the spine doesn't fuse together and they become loose. So we can predict that using different modalities, so checking the bone density scan, checking your vitamins, your bone health, and your biomechanics. Then that has not been enough. We go to determine what we call a frailty score. So we determine the ability of that patient to withstand a big surgery or any surgery based on their physiological reserve. The challenges that we have encountered with this is these all depends on a chronological age. And then how we explain that not every 70, 65, or 60-year-old person is the same. How we explain that beyond just the chronological age. We see that every day, right? The 80-year-old that is running a marathon and the 50 that can't. So how we explain the reserve and just beyond that chronological age. So those questions are becoming more demanding in the setting of an aging population. And age became more than just a number. So that comes to us, and this is the main message of this talk is we have to rely on the genetics. Telomere is the tail end of our DNA. We have gone into significant research, especially coming from UCSF and Stanford. The association of that genetic material, the telomere, with the risk of complication in adult spinal deformity surgery. Based on the length of that telomere, we can now extrapolate not only your chronological age, but your biological age. This is something that we do with PCR, DNA testing, and we can predict, besides your comorbidities, besides even sometimes the way you look, right? Like some people come in and they are 70 and they really look way younger. Then you have a 65 that look really, really older than the 65. And then we have been able to establish a little bit something more objective that is called the telomere. This study of these are pilot studies, right? Because these are new concepts, and people are actually went recently a couple months ago to a spine conference, and people are using and citing these things to patients about introducing to them the concept of biological resilience and biological age, because that helps you. Like they mentioned before, Baptists and the best healthcare in the world, they focus on the patient, and they wanted to make sure that expectations are aligned with the patient and as well as with the outcomes. And those are things that help us predict complication and determine how aggressive we can do with a deformity correction, with a surgery. Can you undergo a 7-8 hour surgery versus we have to try something less invasive and aggressive. So with that first pilot study, then it came in now we're talking about the concept of biological resilience, and this study implemented in artificial intelligence, now with predicted models, the importance of the biological dimensions using that telomere length. And they were able to predict patients with shorter telomere that they would not do as well. They wouldn't have the resilience. And when it comes to resilience, it's not only survive the surgery, is how long it's going to take you to recover from the surgery. One of the main questions that we get every day, any one of us that are treating patients every day, doing surgery, what is the recovery? What is the recovery? How long it's going to take me to recover from this, even if everything goes perfect. And we see that every day, right? We see a 10, 15-year-old break a leg, and they are fused and heal in 3 weeks, right? And then you have a 75 that break a wrist, and it might never heal, or it takes forever. So that is the concept of biological resilience, and that changes beyond the chronological age. They are patients that could be a chronological age of 70, and their resilience could be of a person that is 10 years younger. So that's something that we are trying to do the analytics with artificial intelligence. This study is from UCSF. The data is very new, and these are all pilot study of like 43, 50. I don't think they have one more than 100 patients. Because remember, they have to enroll to this, they have to do PCR, they have to do all the genetics before and after, and do the outcome measures. We are limited still by the measurements, by the outcome that we can measure as well. Because most of them, they still have to be validated, and they have a source of error. So going back to what we're doing here at Baptist, so we're taking this patient had a total of 11 surgeries before. I'm not kidding. And that's what he resulted on the left, and we did a more definitive correction that you can see it on the right. That surgery took about probably 7-8 hours, and you have to do pedicle subtraction osteotomy. So how you decide that this patient is a candidate for a more aggressive correction than the other, we've been relying on all those risk assessment tools, but it'll be ideal that now we can apply some genetics to be more truthful to our patients in terms of expectation, recovery, and ultimately outcome. These are other examples, and so in conclusion, the use of physical exam is still key. We're still doctors. It's surprising how patients come to us, any of my colleagues here, my team, and the feedback is like, oh my God, I've never been examined this well. You know, I'm a spine surgeon, and I do cranial nerves. You know, I'm checking for hearing, and we have to do that because the patient is not just one organ, you know, right? It's all interconnected. We have to look at the red flags. There are things that on examination we encounter and that are very, very significant. It could be a tumor, it could be an infection, not just a pinched nerve. Manage symptoms for pain, and more importantly, educate and understand the complex medical decision process that can predict outcome and prevent complications in what we do every day. Thank you very much.
Thank you, Dr. Vasquez. Great presentation. Next up is, I'm very proud to introduce Dr. Guillermo Debus. Dr. Debus is our co-director of interventional neuroradiology and director of Baptist Health Miami Neuroscience Institute Fellowship Training Program in Neurointerventional Radiology. He's a clinical professor at FIU, Herbert Wertheim College of Medicine. And before joining us, he also served as assistant professor of radiology and neurological surgery at the Feinberg School of Medicine in Northwestern University in Chicago, and the director of the neuroendocrine program there, and neuroendocrine vascular program, and also neuroangiography there. He's a native of Brazil. I understand he plays a mean guitar, but we haven't been able to pin him down for that yet. I'm looking forward to jamming with him. He has many, many accolades, actually. He did his residency in Brazil at the University of Campinas. Am I pronouncing that correctly? Campinas. He did two fellowships, a neuroradiology fellowship at Northwestern University in Chicago, and then a interventional neuroradiology, neurointerventional surgery fellowship at McEnroe Institute and at part of University of Washington, WashU in St. Louis. At Mass General, he did another fellowship, part of Boston. Harvard in Boston. So he comes with exceptional skills. He has well over 100 publications. He's been editors and guest editors for different journals in vascular and interventional radiology, acute ischemic stroke edition, et cetera. The American Journal of Neuroradiology, special collection, vascular lesions of the head and neck, among many others. He's an expert in the treatment of brain aneurysms, stroke, and vascular malformations. And he's an active lecturer both nationally and internationally. You're really going to be pleased by what you're hearing from him today, talking about transforming carotid artery stenosis treatment and the future of angioplasty and stenting. So it's with great pleasure that I introduce Dr. DeBoos.
Ron, thank you very much. I promise I'll simplify my CV next time. Very good. So first of all, it's a great pleasure to be here and be able to give this presentation to you. It's great to see old friends, people that I haven't seen in a while. So I think, we're going to go for basically a ride on what is going on in terms of like carotid treatment, particularly on the arena of carotid angioplasty and stenting. These are my disclosures, nothing that is very relevant to this presentation. First of all, I'd like to say that, carotid disease treatment is truly a team effort. So we count with great vascular surgeons, cardiologists, neurosurgeons, neurologists, really coming to IR partners that really come together to really provide what's the best and really state-of-the-art for treatment for this patient. So keep that in mind. I'm very pleased with the team that we have. Again, I cannot thank them enough to really put together this amazing group to treat these patients, because those patients can be quite complex. The decision-making sometimes is quite complex, although it has been simplified more recently, but still there's a lot of debate on what's the best technique for each patient. So basically the idea of carotid disease treatment is very simple. You have this nasty carotid plaque. You can see here an example of like a pathological example. You have a ruptured plaque with lipid core exposed. Of course, it creates like inside loop thrombosis. It creates like distal embolization. So really what you're trying to prevent with any kind of treatment, medical treatment, carotid endarterectomy, carotid angioplasty and stenting, TCAR, is really to prevent the end result with the disease, which a lot of times is a stroke that could be quite devastating. It's important to understand how did we get here, and some of the seminal work that really like prove carotid treatment to be really the right way to manage these patients compared to medical management. And the first study is really the NASCET study. And the NASCET study was critical. This is a study from the 90s comparing medical management of carotid disease to carotid endarterectomy. Of course, in the 90s, the medical management for carotid disease was pretty much nothing more than an aspirin. Very different the concept that we have nowadays. But the study clearly showed a big benefit in terms of preventing from future stroke from the patients that were treated with carotid endarterectomy compared to medical management. And this is basically on the patients that were symptomatic with stenosis from 70 to 99%. Now, NASCET-2 also showed that even if you have a lower degree of stenosis, 50 to 69, you still benefit of treatment or endarterectomy for treatment of carotid disease, although this benefit is much smaller than compared to the highest degree of stenosis. So I think that's important because we're going to re-explore this in the future later on this presentation. Now, when the investigators also looked into like timing for treatment and basically different in outcomes by gender, they actually showed some very interesting numbers. One is that the timing of surgery for the symptomatic carotid stenosis wasn't really influenced by the gender. So in terms of patients, symptomatic patients, there were males, there was no really different when did you operate those patients, as long as those patients were operated in a long time frame. But when they looked into women, for some reason that we cannot explain, actually the woman benefited from having the surgery early on in the first 2 weeks compared to like later on, as you can actually see here. And actually that's true for both symptomatic and asymptomatic. And although, it's even early on for the asymptomatic patient, again, not really clear to how to explain this, but it's something that actually the NASCET data set actually demonstrated as well. Now, regarding carotid angioplasty and stenting, this is probably one of the procedures that has been highest studies probably in the whole history of medicine. I mean, we've been doing registries and trials since the early 2000s. And what we can see here very clearly, and something that we learned, and it's not only for carotid angioplasty and stenting, but actually for all types of procedures, is that patient or operator experience, patient selection, and the technology had really evolved throughout all the years to really make the procedure as safe as possible. So you can actually see here in this graph here, the decline in terms of complication rate and positive outcomes that we see on those patients with more experienced operators, with better patient selection, and better devices to treat those patients. So that's something that, again, it's really something that we're evolved tremendously. And again, we have now data from thousands and thousands, over 5,000 patients entering registries, independently core-adjudicated labs, independently adjudicated results, showing that the procedure is actually very safe and as effective as endarterectomy nowadays. Now, there was still a lot of question, and one of the main questions that still is around, although there's less question, I guess, nowadays, because there's more data and more data actually helps to make those decisions. But the question was, which procedure is better for the carotid angioplasty, for carotid stenosis, endarterectomy versus stent? And this was evaluated in the CREST study, which compared symptomatic patients that were allocated to either randomized to either endarterectomy versus carotid angioplasty and stenting. And basically what the study showed is that in terms of the overall composite outcome of death, MI, and stroke, there was no statistically significant difference between the two groups. So both groups were very equivalent. Now, when you look very specific, there was a slightly higher chance of minor stroke in the carotid angioplasty and stenting arm, and a slightly higher chance of MI in the endarterectomy arm. So this turned out to become a different debate now. What is better for the patient, have a minor stroke or an MI? So that actually is taken into account. So one of the one of the factors that consider patient high risk for endarterectomy is coronary artery disease. But this was also looked into in the CREST subset. And actually what the investigators demonstrated is that it's worse for you to have an MI than having a minor stroke. Most of the patients recover from a minor stroke with really no significant deficits and no consequence to their life. But an MI during endarterectomy is associated with mortality in the long term for those patients. So this kind of answer a little bit that question that probably it's better to have a minor stroke in a procedure than really an MI during the procedure. Now, the other thing that CREST demonstrated is that interesting, different than some of the concepts that we have, because for many years, the older patients were being sent to carotid angioplasty and stenting instead of carotid endarterectomy because they're considered high risk. But actually what the CREST data set showed is actually the opposite. It's safer for an older patient to undergo endarterectomy and a younger patient to undergo carotid angioplasty and stenting. And for us that perform these procedures almost daily, we understand that because the older patients have more difficult arch, they have more calcified vessels, their anatomy is more difficult. So of course, if you're doing something endovascular, the risk of a problem there is higher than if you're treating a 50, 45-year-old gentleman with pretty straight vessels and just a carotid plaque. Now, when it comes to asymptomatic patients, that's another discussion that has been going on. And that actually, it's the real question that we still have. Nowadays, there's no question that a symptomatic carotid stenosis should be treated. But there's still question if an asymptomatic carotid stenosis should be treated. And this has been addressed by many studies. The ACST, the ACAS study actually demonstrated that patients, when they were allocated to medical management versus endarterectomy, again, this is an endarterectomy study, did show a slightly higher benefit of the patients that were treated with endarterectomy compared to medical management. Now, again, those studies are quite old, and the medical management at that time are different than what we do nowadays. So there's some people that still didn't really believe that, and that actually what led to a larger study, which is still undergoing, which is the CREST-2 study. But when you go down and look into some other studies that were done, this is the ACST2, which compared for asymptomatic patients, carotid endarterectomy versus carotid angioplasty and stenting, did show similar to CREST, so similar to symptomatic patients, asymptomatic patients, there's really no difference in the composite outcome between carotid endarterectomy and carotid angioplasty and stenting. As you can actually see here, Now, similar again, there is a slightly higher number of minor strokes on the carotid angioplasty and stenting arm compared to the endarterectomy arm, although, as you can see here in this graph, none of them really reach statistical significance. So there's no statistical significance between results, but there is a slightly higher, more incidence of minor stroke in the angioplasty and stenting arm, as you can actually see here. However, when you exclude any kind of procedural death or any fatal or disabling stroke or any non-procedural fatal or disabling stroke, there's really no difference. The graphs are exactly the same. So if you exclude minor stroke, the results between endarterectomy and angioplasty and stenting are pretty much exactly the same. So again, demonstrating a very safe and effective procedures both ways. Now, when we talk about asymptomatic carotid stenosis, again, there's a lot of discussion that comes in and still tell us, okay, do we believe in the ACST and ACUS trial, older trials, older medical management? But what is the really current evidence when you're really now treating patients with antiplatelet agents, high dose statin, really blood pressure control, glucose control, telling patients to stop smoking, exercising? And this is a very interesting study. This is usually what I quote for my patients with asymptomatic carotid disease because that's the best data that we have more recently. And this is like a study called the OXVASC study. Basically, they look into patients with asymptomatic carotid stenosis and they stratify them according to their stenosis. And basically what the study showed is that if you have an asymptomatic carotid stenosis that is less than 70%, the risk of you having a stroke is very close to zero. Nothing is zero in medicine, but this showed is very close to zero. However, if your stenosis starts to get higher than 70%, particularly higher than 80%, you may have a yearly rate of stroke that can reach somewhere close to 3 to 5 to 4%. So that's not an insignificant risk. 3% risk of stroke accumulating like 15, 20% in 5 years is a pretty significant risk compared to a procedure that will pose you like 2 to 3% risk of having a minor stroke mostly. So again, I do tell this to the patients. I don't know what's the best answer because actually the real study that will tell you if you should or not treat asymptomatic patients that's going to show us the best clue for that is really the CREST-2, which is just finished enrollment. So I feel that probably in the next few years, we're going to have results. I'm part of the interventional management committee for it. So we look forward to the results. And the CREST-2, basically the patients are randomized to medical management versus either carotid angioplasty and stenting or endarterectomy. So it's really comparing medical management to any form of treatment, which is depending on the center, would choose which treatment to do. So when we have the result, then we're going to be able to tell for sure that asymptomatic patients should or should not be treated either with endarterectomy or carotid angioplasty and stenting. So again, as I mentioned, carotid angioplasty and stenting, very straightforward procedure, okay, for us. We can treat very nasty plaques like this picture on your left side there. The procedure is most of the time straightforward and the patient has selected the correct patients with good anatomy, patients that are straightforward. We usually use this little filters. It looks like a basket. So when you're doing angioplasty and put in stent, if something breaks off, you get caught on those nets. And then the risk of having a problem, it's much smaller because that actually can filter pretty significant sized particles. Tiny ones will probably go through, but the bigger ones are caught. So that's probably why when you have something, it's usually a minor stroke. So again, over 5,000 patient studies. It's very comfortable for the patient. It's a procedure that takes usually about 45 minutes to be skin to skin, as you call, like from the start, from the puncture to the closure of the groin, and can be done femoral, can be done radial nowadays. I still prefer to do most of my cases femoral, although radial is a good approach, and I've done several cases like that. I think the patients a lot of times like the radial approach more because they don't need to be laying down flat, but still it can be a little bit challenging sometimes. Now I'm going to show just some quick cases. This is a patient, a 47-year-old who presented with symptomatic carotid stenosis, has a tiny stroke on the left hemisphere, and this patient actually then comes back in, had a carotid ultrasound actually that you can actually see here. That's how a lot of times we look. This is the first screening tool for carotid stenosis, this carotid ultrasound. And you can actually see here a very, very high velocity, peak systolic velocity of 570 centimeters per second, and diastolic velocity of greater than 280 centimeters per second. That really tells you that this patient has a very severe stenosis, greater than 80%. And then, of course, symptomatic greater than 80%, this patient should be treated. Unfortunately, in the meantime, this patient actually occluded at carotid and presented here to Baptist with, as an acute stroke, what we call like a tendon occlusion with distal embolization. So I was able to go there, do a thrombectomy, angioplasty of the neck, and then do a thrombectomy intracranial. The patient actually had a very good recovery. So we brought this patient back 1 week later to just finish the job. And you can actually see here the residual carotid stenosis there. And then very straight vessels. This is a perfect case for carotid angioplasty and stenting. You just pass your filter. You can actually see the filter. I don't know if this is a pointer here, but okay. Either way. So you have the filter placed distally in distal cervical carotid artery, and then basically you just do the angioplasty, put the stent, and you can actually see here the final result. Really recanalization of the vessel. We always measure the diameter of the vessel based on the NASCET criteria, which means you measure not at the bulb, but you measure the area where you put the stent to the distal cervical area, straight segment. And really, with this, you really usually have no, in this case, what we call no significant residual stenosis. And this is basically the carotid ultrasound. The next day, you can see here the velocities start to normalize, and 4 months later, the velocities couldn't be better than this, 60 over 21 in the peak systolic and diastolic velocities. This is another case. And again, the other technique that we use a lot, carotid ultrasound, we always do, but we also do a lot of CTA. CTA is very interesting. I mean, you can see big details of the plaque there. You see the calcification. You see the soft component of the plaque. You see this very irregular, nasty plaque with a big ulceration and reentries. And you can understand, I mean, why these patients become symptomatic. I mean, you can form clot there, but there's also in situ thrombosis that happen because most of those plaques are ruptured, and you expose the lipid core, and basically becomes an in situ nidus for thrombosis. And as you see here in the angiogram, we can do 3D angiograms. You see the big plaque ulceration. You go there, and again, you do the angioplasty and stenting. This is a cone beam CT demonstrating the stent. Some of these plaques, they're very calcified. They never expand totally. And you don't want that to happen because that increases the risk of distal embolization on a cheese grating kind of effect type of deal. So you don't need to have the full perfect result. You just need to open the vessel enough that it matches somewhat the distal caliber of the carotid artery. Now, the other option that we have that is very similar to carotid angioplasty and stenting is an angioplasty and stenting, but is instead of doing through a femoral approach or to a direct percutaneous approach, it's done through a carotid exposure. It's called TCAR, transcarotid artery vascularization. We do a lot of these cases sometimes in conjunction with our vascular surgeons. And it's a very, very good procedure. It's a procedure that gained a lot of momentum in the last few years, particularly because of reimbursement issues with carotid angioplasty and stenting, which kind of had been resolved by now. But it's a very, very good procedure as well. And the idea of TCAR is that if you have patients like this with very bad aortic arches, very tortuous common carotid arteries, or very tortuous internal carotid arteries, this may be a better option because you have a direct cut down, you get access to the common carotid artery, so you bypass all the arch and all the calcification, all the risks that you have through going through that. So the idea of TCAR is basically do a carotid cut down, you put a big catheter directly into the carotid, which is exposure. It's ligated by the vascular surgeon, and you create a shunt because you ligate the carotid proximally. Then what you do is basically connect the catheter that is in the carotid and the common carotid artery to the femoral vein line that you have, which is through a big sheath, and that immediately reverses the flow because the carotid system is a high resistance system compared to the venous side, so the flow directly gets reversed. And actually, it's a very, very robust way to protect carotid from distal embolism because the flow gets reversed immediately. And after the catheter is deployed, like we can actually see here, the shunt is performed, the carotid is ligated. Then it's very easy because you don't need to use a filter because you have a flow reversal for protection. You do the angioplasty, you put the stent. You see here and then there's a filter that connects the carotid to the venous, to the femoral vein. And you can actually open the filter in the end, and you see all the debris that got caught on that filter. So, this is something that potentially would all go to the brain and embolize. And we had some cases that we had done MRIs after these procedures, and actually they're pretty clean, which a lot of times you may see little things, but in this case, it's actually just proving that it's a very robust way to protect the brains with this flow reversal. So I think the key things here, to take home and to really understand, is that we have great ways to treat carotid disease, okay? Even the medical management has progressed a lot, and now with statin and high-dose statin, antiplatelets, blood pressure control, diabetes control, smoking cessation, those are very powerful way to control the disease. However, if you do have a symptomatic carotid, that needs to be treated. There's no question about it. The question still remains for asymptomatic, although there's, not through a randomized trial, there's evidence that if you have greater degree of stenosis in asymptomatic patients, these patients probably still should be treated. So in the end, really, carotid angioplasty and stenting, TCAR, are very effective and safe carotid disease treatment, similar to what is endarterectomy. So we have three great options. The main thing here is to really use your multidisciplinary team approach to decide what's the best way to treat a patient and really provide those patients the best chance of a good outcome. Thank you very much for your attention. I'm happy to entertain any question.
I really look so short compared to him, don't I? Actually, I'm the shortest guy at the table. Well, maybe Dr. Vasquez and I could fight it out. That was an outstanding lecture. Thank you so much, Dr. DeBoos. Our next speaker, Dr. Vitaly Siomin, I've known for 12 years that I've been here at Baptist, and he actually preceded me as one of the first neurosurgeons to join the Baptist Health Medical Group. When I first came here, he was my go-to neurosurgeon for spine and everything. And as we grew in the Miami Neuroscience Institute up to over 42 doctors now, we've expanded, and you're seeing a lot of our specialists are subspecialized. And Dr. Siomin does more of the cerebrovascular and brain tumor surgery. So he is the director of cerebrovascular and epilepsy surgery and the co-director of our skull-based surgery program at Baptist Health. He has broad experience in open cerebrovascular, skull-based surgery, brain tumor surgery, and other types of cranial surgeries, and performs complex spine procedures, spinal instrumentation, suboccipital decompressions for Chiari type 1 malformations, and he's certified by the American Board of Neurological Surgery, as are all of our neurosurgeons. What I did not know as well is, well, first, I don't know whether he plays an instrument. He is one of the most humble people that I've met, and one of the most brilliant physicians I've ever met. And but I didn't realize he actually did 4 fellowships. He graduated from IM Sekhanov, first Moscow Medical Academy in Russia, then completed, follow me on this, okay? He completed residencies at Burdenko Neurosurgical Institute in Moscow, and then again a neurosurgical residency at Cleveland Clinic Foundation in Ohio. Then he completed a fellowship in pediatric neurosurgery at Tel Aviv Sourasky Medical Center in Israel, followed by a neurosurgery neuro-oncology fellowship at Toronto Western Hospital, University of Toronto in Canada, and then a brain tumor fellowship at the Cleveland Clinic Foundation. So 4 fellowships. He's participated in clinical and basic research on brain cancer. He's published in several medical journals, including the Journal of Neurosurgery, Neuro-Oncology, Neuroplasia, Pediatric Neurosurgery. He's done almost everything. And as I said, he's just an all-around great person, humble human being, but a brilliant man. So it's my pleasure to introduce Dr. Siomin.
Thank you, Ron. I appreciate this kind introduction and the multiple fellowships. This is a path of a foreign medical graduate to an American medical system. So if you don't know, probably many of you know that. But in any case, all right, so we'll talk today about treatment, microsurgical treatment of brain aneurysms. So aneurysms are common. 1 to 6% of the population would be diagnosed with an aneurysm, either incidentally or after a clinical presentation. And there's only minimal evidence to suggest that the aneurysms are inherited, and most likely etiology is typically hemodynamic injuries, stress to the walls, especially in the areas of the bifurcation. But they might be associated with different conditions such as connective tissue disorders, Marfan, Ehlers-Danlos, FMD, polycystic kidney disease, and coarctation of the aorta. There might be multiple in up to a third of the patients, especially if other vasculopathies are present. 75% of the patients would have 2 aneurysms. They become symptomatic in patients who are 40 to 60-year-olds. And the majority of the aneurysms occur in the anterior circulation. 30% of them are in ACOM, PCOM, followed by MCA, and pericallosal artery would be probably the least common. Most typical clinical presentation with subarachnoid hemorrhage. And obviously, it's the worst headache of a patient's life. We use Hun-Hess scale to measure the clinical severity. We utilize the Fisher gradient scale to correlate the amount of blood and correlate that with occurrence of vasospasm and outcome. About 20 to 30% of the patients never even make it to the hospital. They just die in the scene. And out of those who make it to the hospital, about 50, 70% remain very disabled and in need for prolonged assistance and even major assistance for the rest of their days. The natural history, it depends on the size of the aneurysm. It's sort of like it's been moving target. Initially, we thought that aneurysms that are larger than 10 millimeters would be dangerous and you have to treat them. Then it turned out that those that are larger than 7 millimeters, and now, in fact, the majority of the aneurysms, there's a growing body of evidence to suggest the majority of the aneurysms that actually rupture are about 5 to 6 millimeters in diameter. So whenever you see an aneurysm of that magnitude, you know, something probably needs to be done. There are risk factors, and typically they involve cigarette smoking, cocaine abuse, use of different substances, which could lead to vasculitis and intimal injury. Female sex is another risk factor. Family history of aneurysm, presence of different conditions that might be associated with aneurysms, such as polycystic kidney disease, SLE. Hypertension is a risk factor, and aneurysm shape. When there's Murphy's excrescencies and irregular dome, that would be one of the risk factors for rupture. What are the treatment options for unruptured aneurysms? We can follow them if they're small and the patients don't have risk factors, or we can proceed to treatment if they are larger in size and there are risk factors. Treatment may involve clipping, and I'm a surgeon, that's something that I do, bypass with clipping, wrapping of the aneurysm, some historical treatment options such as Hunterian ligation. Coiling is a type of treatment that endovascular colleagues provide. Stent-assisted coiling and flow diversion is another more recent option. Treatment options for ruptured aneurysm are essentially the same, but we obviously cannot follow them. We utilize different medical aspects of aneurysm care, so we admit those patients to the ICU. We have, I believe, 4 and probably even more now fellowship-trained neurointensivists at Baptist, and we communicate with them, and just they're very good quality people. Patients are typically lined up. We need to control their blood pressure. Nimodipine is given for 21 days to prevent vasospasm. Seizure prophylaxis is an important part of this. So we don't prophylax for the whole duration, but usually 5-7 days is typically sufficient to minimize the risk of seizures. Vasospasm incidence is highest between starting on day 3. Initially, the patients have honeymoon, no vasospasm, but day 3 to up to 3 weeks, the incidence of vasospasm is highest. And that's when it's important to do serial TCDs and sometimes provide even medical treatments such as hypertension, hypervolemia, calcium channel blockers. And another aspect of medical treatment is the patient have mycotic aneurysm. We treat them with antibiotics. It's important to continue antibiotics to secure the aneurysm. The goal of treatment would be to achieve complete obliteration, whether you do when you treat the aneurysm endovascularly or you treat it surgically. The multidisciplinary approach is very important, and when we get together, typically angiography is done, patient is evaluated clinically, and then we decide which aneurysm would be treated best with coiling or surgery. Neurosurgeon is typically involved, interventionalist, intensivist, plus minus neurology, rehab specialist. Very recently, we got what's called the mobility teams. So patients postoperatively need to be mobilized, and it's very difficult. Sometimes on the weekend, patients, nobody would come and see and mobilize them. We created those mobility teams when you just trigger the consult, and patients would be evaluated and pulled out of bed, and therapists would evaluate them. And it's done in conjunction with, between the various, in cooperation with various clinical specialists. Coiling provides better disability outcomes in 1 year based on the results of the ISAT trial. Clipping, if the aneurysm is uncoilable, then we should perform clipping of the aneurysm within 48 to 72 hours before the vasospasm starts developing. And if stenting is performed based on the ISET trial, it might be riskier than either of the options. Coiling is a kind of very straightforward procedure, lower cost, less invasive. The disability and morbidity is lower at least in the short run, based on the ISET trial. The risk of vasospasm is also somewhat lower. The interventional radiologist can also administer intra-arterial vasodilators to treat vasospasm. It's better for posterior fossa aneurysm, probably because of the technical challenges associated with open clipping. Better tolerated by elderly patients and patients in poor neurological grade. And the risk of seizures and cognitive and adverse cognitive events is lower with coiling. So that's what we're competing with as surgeons. Like when you talk about surgery, then you get somebody, head is clamped in a vise, you shave the hair. We actually use the zigzag kind of incision so that if you have a straight incision, the hair parts, you can see it. If you make it like this, so you can't see. But I mean, we try to do different tricks, but it's a big and invasive procedure. You open up the brain, split the fissures, go in there, suck out the clot, manipulate between the cranial vessels. Like this is a case of a clipping of a PCOM aneurysm. You see the brain stem down below, cerebellum pushed up, cranial nerves going to the IAC. It's a big procedure. When patients are presented with these options, obviously it's and the vascular colleagues win. But there are cases that we have to do that, and it's unavoidable. Clipping requires an experienced neurosurgeon. It's typically just one procedure. You don't go back and forth and let's just throw some more coils. Let's just put the stent now. Let's just do this. It's just once you're done, there's a 98% chance you're not going to bring this patient back for any other procedures. Extremely low recurrence rate, as we mentioned. Probably more versatile with various aneurysm shapes, especially if you have an ectasia in some branches coming off of the aneurysm. Then it's obviously clipping. You can just directly visualize and put your clips in such a way that would prevent the occlusion of the vessels. You can evacuate the blood, and it's although controversial, but you may potentially decrease the incidence of vasospasm. Based on the ISET trial, there's no evidence of increased mortality at 5 years, like in the long run. Clipping involves various adjuncts. We utilize CSF drainage, early identification of the basal cisterns, draining the CSF. We ask anesthesia to provide induced hypotension in the most critical parts of the procedure. We utilize mannitol to relax the brain, hyperventilation, minimal brain retraction, preserve the veins. As you see, this is a Sylvian fissure split, and the clips are placed on the MCA bifurcation aneurysm. The dissection has to be performed in a very gentle way. Basically, I don't use retraction system, except for dynamic retraction with the tips of the instruments over the cottonoid patties and rubber glove sliders. Only the most critical part, when you have everything exposed, we put the retractors to maintain the field, but not really so much to retract per se. Circulatory arrest used very sparingly, but once it saved me and the patient, because the bleeding was from the ruptured aneurysm was extremely uncontrolled, and the anesthesia had to give adenosine to get the circulatory arrest for a few seconds when we were able to put the clips to control the bleeding. The risk of recurrence with clipped aneurysm is very low, and like in this series, the de novo aneurysm formation was detected in up to 8% of the patients. That's why it's important to follow up. Even if you think that clipping is good, secured, put the clips, everything is good, there's no dog ears, no recurrence, it's still important to ensure long-term follow-up and do another angiogram, maybe about 5 years, 9 years, 10 years, something like this, because there's still about a small percentage of patients that would require treatment for either recurrent aneurysm or de novo aneurysm. Well, we will not go over the details. I just wanted to pick up this study because it's large, it's randomized, and it was done at a major, very credible institution, Barrow Neurological Institute. So they analyzed 725 patients. They compared coiling and clipping, and it's important. They made the conclusions immediately after the study, And then they did the 6-year results. And it showed that statistically, they came up with a criticism that the study was underpowered to detect small differences because the differences between the technique were relatively small. 6-year results suggested little difference in outcome between coil and clipping for the anterior circulation aneurysm. But for posterior circulation aneurysm, the difference was very significant. And coiling has very clear advantage. Obliteration rates in Brett's study were significantly lower and retreatment rates significantly higher in the endovascular treatment patients. And despite higher retreatment rates after coiling, there's no recurrent hemorrhages in the endovascular group as long as for this whole duration of follow-up for 6 years. So it's the difference probably is going to be very minimal, but we still should have both options available and select them sparingly for different patients depending on the criteria that we mentioned before. So which aneurysm should be clipped? Young patients, it would be probably the preferred method of treatment because it provides the low recurrence rate in the foreseeable future and even the long-term future, in the extended long lifespan. They may have recurrence, and it's important to secure them once and for all. In older patients with significant vessel kinkiness, although the endovascular procedure is typically better tolerated by elderly patients, but sometimes you just can't navigate there. If you have like very advanced atherosclerosis, it might be hard for the endovascular operator to advance the catheters there and manipulate. So some of these patients end up being clipped. Ruptured aneurysm with ICH, mass effect, when you really need to decompress the brain in addition to secure the aneurysm. The aneurysms with wide necks, especially MCA bifurcation aneurysm, which are very difficult. Sometimes the blood vessels take off and you need to remodel the entire bifurcation with clips, which is much easier to do it with clips. Distal aneurysms, which are typically small, and aneurysms smaller than 2-3 millimeters are difficult to coil endovascularly. As we mentioned, when distal branches originate from the aneurysm and after endovascular treatment failure, when we have a lot of coils in the aneurysm that keeps recurring, especially giant, large aneurysms and ruptured previously coiled aneurysms. So these are the typical candidates for clipping. We utilize temporary clipping for about 15 minutes, careful monitoring, burst suppression, induced hypertension. Be careful with neck calcifications, aneurysm thrombosis, atherosclerotic plaque are all little mines that you have to navigate around. Sometimes you have to spare the STA for bypass, consider neck exposure, have the neck ready for aneurysm, especially some periophthalmic aneurysms when it would be difficult to control intraoperatively. And intra-op angio is utilized very, essentially in almost all cases. Sometimes temporary clipping can be very long. So like in this case we just did recently with Dr. Wicks, it was just a giant previously coiled MCA bifurcation aneurysm. So we had to open up, expose the entire aneurysm, open it up, excise it, remove all the coil mass. And obviously it's a very lengthy, tedious process. So the temporary clips were in place for 40 minutes. Like really nothing happened somehow. It's just sometimes be better lucky than good in these cases. Clipping strategy involves clipping of the aneurysm and evacuation of the hematoma. You have to utilize 3D thinking. It's very important. I'll give you a couple of examples, especially in MCA bifurcation aneurysms. So sometimes the aneurysms are very irregularly shaped. Sometimes the branches can be continuation of the body of the aneurysm. The whole bifurcation is diseased. And you have to utilize different angulation clips, fenestrated clips to recreate the bifurcation and preserve the natural, the normal vessels. Sometimes we use cotton because sometimes you can't really, provide that perfect clip application, and there's still some thinning out of the blood vessel wall, even the normal part of the normal vessel. So sometimes we apply the cotton to induce scarring and maybe enhance the wall of the normal vasculature to prevent the recurrence. This is a case when we utilize the IC green angiography. So this is how you have to dance around the normal vessels and atherosclerotic plaques and calcifications in a patient with fusiform MCA bifurcation with atherosclerosis. Ophthalmic artery aneurysm is also sometimes we clip them, and have to mobilize the optic nerve to be able to see the aneurysm and approach the neck. It requires the clinoidectomy. This is it's one of the typical cases. Then once the clip is placed, sometimes you can't really maneuver the clip in such a way that would be that the clip mechanism would be away from the optic nerve. And what can happen is that it can push, like you see on that left illustration, that it's sort of like right up against, immediately adjacent to the optic nerve, and sometimes it can cause optic neuropathy. Sometimes you have to utilize microsurgical skills to suture the clip away to the dural remnant and move it away from the optic nerve to achieve that gap and prevent the optic neuropathy. We actually published on that. So this is a case of a ruptured ACOM aneurysm. And these aneurysms are challenging because you need to, the vision is obscured. You have to resect a little bit of a gyrus rectus to get a good visualization. Attention to the parent vessels is critical, and the perforators. There's a bunch of perforators there. Depending on the angulation of the aneurysm, you have to be very careful with them and clearly visualize them. This is a case of a giant MCA bifurcation aneurysm, 67-year-old patient. They tried to put the stand. It was unsuccessful. And we have to move away from flow diverter to now direct clipping. The high flow bypass had to be done because it's a very large caliber vessel that would have to be done. And I just quoted here from Dr. Shaker, who's a very known authority in this area. So he calls it temporary. He calls it the creation of the bypass as a higher level of technical skill is needed, and is an operation with 1,000 steps, all of which have to be executed properly. So this patient underwent craniotomy, and at the same time, the vascular surgery team worked on harvesting the radial artery graft. You can see the steps of the arteriotomy in the external carotid artery. Then we sew in the radial artery graft. Then the graft is tunneled to the cranial exposure, and the bypass is created. After that, you have to somehow anastomose the two branches, because they were before you actually clip the aneurysm, so that there would be a blood flow established between the superior and inferior division. Then we create an in situ bypass between the superior and inferior division, check the patency with IC green angiography, and then the patient is brought back to the endovascular suite, where the endovascular team would perform the coiling. So it's sort of like multi-step complex procedure. It's not done every day. These are just nerve-wracking kind of challenging cases. We started utilizing the exoscope. It gives you a 3D perception. Everybody in the operating room wears goggles, and we can see things in 3D. And it's, the key is just to bring it closer to you so that you can just completely immersed into surgery. It's actually very cool. I absolutely enjoy these cases myself, and I like that everybody else in the operating room, techs, medical students, everybody is kind of like watching it in 3D when you have a vessel which is normally at 2-3 millimeters that is just magnified to a size of a huge pipe, and then you can just see the microanatomy in all of its beauty. That's a case of clipping of the aneurysm using an endoscope. I'll just skip on. So intraoperative angiography is important, and the conclusion of one of the series is that up to 20+% of the patients may need to be brought back to the operating room after intraoperative angiography to reposition the clips, because the parent vessels can be clipped, and for that optimal clipping. Catheter angiography is probably very similar in the extent of visualization and as far as the outcomes are concerned to the IC green angiography, but we're still kind of hesitant. We usually utilize both. The complications of clipping, not very high, but they're not zero either. So the morbidity is 2.3%, is size dependent for aneurysms that are smaller than 5 millimeters, 7% for 6 to 15 millimeters, 14% for 16 to 25 millimeters. There's a 10% chance of intraoperative rupture. I can test that's the same thing in my personal experience. There's a risk of stroke, venous infarct, seizure, and obviously craniotomy-related complications, infection, wound healing, bleeding, seizures, temporalis muscle atrophy, etc. In conclusion, surgical clipping is a very well-established treatment option. It should be preserved, even though the endovascular options are making advances, and there's a lot for them to progress, whereas the neurosurgeons sort of reach the plateau. This option should exist for selected patients. It will remain an option for patients in most institutions. Microsurgery should be strongly considered for younger patients with aneurysms in the anterior circulation, especially MCA bifurcation aneurysms, for giant aneurysms, for aneurysms with wide necks, in older patients with tortuous vessels, and when coiling failed, and there's really no other options for these patients. Multidisciplinary approach is essential, and also in aneurysm surgery, you got to be prepared for everything, to utilize your skull-based skills, to utilize microsuturing techniques, and all other general neurosurgical techniques. So it's an interesting, the picture you can see, this is one of my patients after aneurysm clipping. So she had staples, we removed the staples, and she took them and used that to make this little necklace after surgery, just put like this power, love, hope, and all of that stuff. So, I'm glad that we were able to help. And thank you all very much for your attention. It was a privilege. Nice to see you all here. Welcome to Miami. And thank you very much again.
That was wonderful. Thank you. I want to remind everybody that there will be a question and answer session following the end of our morning speakers, and our speakers will all be up front for that Q&A session. So please make sure as you come up with questions during this that you write them down and prepare them for later. To prepare to be a moderator today, I watched a roast. Some of you may know what I'm talking about, others may not, but I watched a roast of Dean Martin and a whole group of comedians on Frank Sinatra, a roast for Frank Sinatra. It was held in the early 70s, but I can't remember any of the jokes from it, so I'm not sharing any of them with you today. So I didn't do a good job on that preparation. All right, so our next speaker, Dr. Evan Bander, when you see him up here, you'll understand what I'm about to say. He looks like he's right out of high school, but he's really not. He is the director of endoscopic skull-based surgery and pituitary tumor program here at Baptist. He's our most recent neurosurgeon to join the Miami Neuroscience Institute. He's only been here just a couple of months, and so he treats both benign and malignant brain tumors. He earned his degree from Cornell University in New York, and then went on to do his residency at the New York Presbyterian Hospital in conjunction with Weill Cornell Medical College and Memorial Sloan Kettering Cancer Center in New York as well, and completed a neurosurgical residency and served as chief resident, and also went on to receive the Leon Levy Neuroscience Research Fellowship and Minimally Invasive Skull-Based Surgery Fellowship in New York. So he really comes with great training. He then went on to do a neurosurgical oncology fellowship at MD Anderson, famous cancer institute in Houston, Texas. And he's extensively published already. So early in his career, he's had numerous awards and accomplishments, and I'm just looking forward to seeing what he does later in his career. So it's with great pleasure that I introduce Dr. Bander, who will be speaking to you today on the role of neurological oncology in managing brain mets.
Thank you. It's an honor to be here and to speak to all of you. So thank you to Baptist Health International for organizing this. As you heard, I'm one of the newer members of M&I, and I've only been here for 3 months, so I'm honored to be joining you today. So as you heard, I wanted to give a little bit of background on where I came from since I've only been here for 3 months. So I trained and grew up in New York City and trained at Memorial Sloan Kettering and Weill Cornell Medical College in New York, and then did a fellowship in neurosurgical oncology at MD Anderson, which is what I'll be focusing on today. And then I joined here at Baptist Health. So as a neurosurgical oncologist, brain metastases really make up a majority of our practice because these tumors present as the most common brain tumor found in adults. Epidemiological studies have demonstrated that about 8 to 10% of patients with systemic cancer present or eventually are found to have brain metastases. The most common pathologies to occur in the brain are lung metastases, breast cancer, as well as melanoma, which is followed subsequently by renal and GI malignancies. Now, local therapy with surgery and/or radiation are really the mainstays of treatment for brain metastases. And really, it's the combination of multidisciplinary care between neurosurgeons, oncologists, and radiation oncologists that's vital to determine the best treatment for these patients, which is why a place like Baptist Health and Miami Cancer Institute with Miami Neuroscience Institute collaboration is so important. So, historically speaking, the prognosis of patients with brain metastases has been considered dismal and a very poor prognosis. But thankfully, however, that is changing, and the paradigms are shifting in brain metastases because we're seeing significant improvements since the age of molecular targeted treatments and immunotherapies have been introduced. We've seen a huge number of drugs developed over the past decade, which have really changed the landscape of brain metastasis treatment and treatment of systemic cancers in general. So these timelines just show that over the last decade, we've seen both in melanoma and non-small cell lung cancer. Since 2010, we've seen a huge number of drugs that have been introduced into the treatment paradigms for these systemic cancers. And what's important to note is that the introduction of these treatments have actually made a big difference in the prognosis of patients with brain metastases as well. So we evaluated over 200 patients treated with melanoma at Memorial Sloan Kettering while I was there. And what we found was that since 2015, compared to patients treated before in 2010 to 2014, we saw a doubling of the patient survival. Overall survival went up from 7 months after diagnosis to up to 13 months after diagnosis for patients with melanoma, just since the introduction of immunotherapies and targeted molecular therapies. We're also seeing in other publications similar improvements in survival in patients with breast metastases as well as lung metastases. So it's not just that the systemic treatments are improving systemic control of disease, but we're also seeing that these new molecular therapies and immunotherapies are actually having direct effects through the blood-brain barrier on the brain metastases themselves, where we're seeing patients treated with antibody-drug conjugates, such as in breast cancer through the DEBRA trial, showing objective response rates in the brain metastases themselves. So with all of these advancements in brain metastases and systemic therapies, we've seen survival improving, which really makes the importance of local control within the CNS and within the brain even more important. So I'm a neurosurgeon, I'm not an oncologist, so I've told you about all the advancements that oncologists have made, but where do neurosurgeons fall into this? So the role of a neurosurgeon was really cemented back in 1990 with randomized controlled trials led by Roy Patchell, which showed that surgical resection of solitary brain metastases when combined with radiation therapy led to improved local control, as well as improved overall survival and prolonged functional independence of patients treated with surgery plus radiation compared to radiation alone. In 1998, he also showed that surgery combined with radiation was of benefit rather than surgery alone because local control was significantly improved when you combined surgery with radiation. So really this cemented the role of multidisciplinary care in treatment of brain metastases. So after the Patchell trial, traditional indications for surgical resection have usually focused on solitary or oligometastatic disease, primarily patients treated for local control of dominant large tumors. Usually a cutoff of 3 centimeters is quoted in the literature for large tumors, and then patients who have symptoms, who require palliation of symptoms, is another major indication for surgical resection prior to radiation. In addition to that, there are patients that may need histologic or pathologic diagnosis, so surgical resection can provide that. And they may also have been treated previously with radiation and may have a question of whether they have recurrence versus radiation necrosis and may require resection for that reason as well. Now, in general, hemorrhage is also a common presentation within brain metastases. It's not always an indication for surgery, but in some cases, especially in patients who require anticoagulation, surgical resection of hemorrhagic brain metastases can be indicated to allow them to get back onto anticoagulation in a more quick manner. So those are some of the traditional indications for surgery, but as we've seen improvements in medical therapy and as also we've seen improvements in radiation therapy with the introduction of stereotactic radiosurgery, we've seen that local control rates for stereotactic radiation alone are actually very excellent in small brain metastases. But a recent study that was published from MD Anderson evaluated the effect of stereotactic radiosurgery alone as an upfront treatment. And what they found was that the size of the tumor, as well as the primary histology, were very important in determining the control rates. And what they found was that even patients who had tumors that are less than 3 centimeters, there was still a steep fall off in the local control for patients who had tumors even above 1.5 centimeters. So surgical resection may actually be indicated in some of these patients depending on their histology and our ability to predict their local control with stereotactic radiosurgery alone. The role of surgery may be expanding beyond just patients with tumors greater than 3 centimeters. In addition to that, there's been some interesting evidence out of MGH with Dr. Castellanos' group, who evaluated the genetic mutations of brain metastases that had been resected and compared them to the primary metastases or the primary tumors resected, and found that in brain metastases, there were actually 50% of patients that had systemic targetable molecular alterations found within the brain metastases that were not present in the primary tumor. So this could, as we develop even more targeted therapies, become relevant as we may need to get pathologic diagnosis from the brain metastasis, as opposed to just relying on the pathology from the primary tumor itself. So now that I've talked about sort of some of the indications for surgery, are there things that we can do as a neurosurgeon to improve our local control? So number of studies from MD Anderson have demonstrated that the actual technique used during surgery can affect the local control rates. So en-bloc resection, or taking out the tumor as one piece as opposed to taking it out in small pieces in a piecemeal manner, can actually improve local control after surgery. In addition to that, en-bloc resection has been shown, especially in eloquent areas of the brain, to decrease complication rates for en-bloc resection compared to piecemeal resection. And particularly in patients with posterior fossa metastases or in the cerebellum, en-bloc resection can lower the rates of postoperative leptomeningeal metastases compared to a piecemeal resection. So how we resect these tumors really does matter. As I mentioned, stereotactic radiosurgery has really become the most common form of external beam radiation therapy we use for brain metastasis treatment. But what we found was that after surgery, the time from surgical resection to stereotactic radiosurgery can vary very widely in patients that were treated at Memorial Sloan Kettering. We found ranges from 14 days to up to 90 days. So we evaluated what is the role of timing of stereotactic radiosurgery for adjuvant treatment in brain metastasis, in resected brain metastasis. What we found was that while overall we were having excellent local control rates for surgically resected and adjuvantly radiated brain metastasis with recurrence rates of only about 14% all the way out to 5 years, we found that the timing of that stereotactic radiosurgery significantly correlated with the local control rates. A cutoff of about 34 days was statistically significant for recurrence rates in that population. And what we saw was if we treated patients after resection with stereotactic radiosurgery within 1 month, we were having local control rates with recurrence as low as 6% at a year. But if we treated patients up to 2 months after surgery with stereotactic radiosurgery, their recurrence rates were almost as high as 27%. So that was really significant in determining, these patients can't just be surgically resected and then assume that radiation is going to happen in a timely manner. It has to be organized in a multidisciplinary manner and done very meaningfully. So we took that actually a step further at MSK while I was there and evaluated a prospective cohort of patients who we delivered radiation within 14 days after surgery to evaluate whether we had better results with that. What we found was that within 14 days, we did have excellent local control rates, but they weren't actually significantly better than patients delivered stereotactic radiosurgery between 15 and 22 days or 21 to 30 days. But we actually found that there were higher rates of adverse radiation treatment effects if we treated them within 14 days of surgery. So what we actually found was that the optimal timing for treatment after surgical resection with radiation is around 20 to 30 days after surgery. So again, this timing and coordination of care is really important in the treatment of these brain metastasis patients. Now, in addition to stereotactic radiosurgery as a form of adjuvant treatment. Brachytherapy is actually becoming a very popular field within the neurosurgical oncology community. Now, brachytherapy is actually delivery of the radiation source into the tumor bed or resection bed at the time of surgery. So instead of having this time between surgery and radiation treatment, you actually deliver the radiation immediately. And it was used as far back as the 1900s, but it really fell out of favor due to side effects. And only recently has the brachytherapy treatment become more popular again because of introduction of new forms of radiation using cesium as a source of radiation, which has a better safety profile compared to prior forms. And so we evaluated, while I was at Cornell, a population of 80 patients that we treated with brain metastases with resection, treated with cesium brachytherapy at the time of surgery. And what we found was we had very good local control rates, especially in patients with non-small cell lung cancer and patients who were treated as a first surgery as opposed to a reoperation, with control rates of about 91% at a year. We also found relatively low radiation necrosis rates in this population, about 10%. And one of the advantages of brachytherapy is that, one, you're delivering local therapy at the time of surgery. So again, there's no interval period between surgical resection and radiation. So patients who may be lost to follow-up or who may not be reliable to follow up for radiation, you can treat them at one time with one surgery. In addition to that, radiosurgery, really one of the pitfalls of radiosurgery is that for large cavities or for large resection beds with irregular margins, it can be hard to design conformal treatment. Brachytherapy, as you deliver it directly into the resection bed, avoids that pitfall and difficulty with designing stereotactic radiosurgery treatment. So in addition to upfront treatment, brachytherapy is also being increasingly used for salvage surgery for treatment of patients with brain metastases who had previously been treated with stereotactic radiosurgery and have failed and progressed since that treatment. And then we go back in, do a re-resection of that recurrent tumor, and place the brachytherapy seeds at that time. And the literature is showing that in this salvage population, we're seeing pretty good control rates of 75 to 90% at 1 year, again, with relatively low rates of radiation necrosis at about 10%. And we're also seeing that that compares favorably to alternatives such as resection alone, salvage resection alone, or salvage resection plus external beam radiation therapy. So brachytherapy is really becoming an expanding field within neurosurgical oncology at this time. And because of that, we're seeing a lot of clinical trials, a number of which we're running here at Miami Cancer Institute, evaluating brachytherapy as an upfront or as a salvage treatment for brain metastases. Now, another technology that's recently become increasingly popular is the introduction of laser interstitial thermal therapy, which is a minimally invasive technique where we can stereotactically drill a burr hole in the skull and introduce a laser probe into a lesion, whether it's deep in the brain or superficial, and using thermal ablation, ablate either a recurrent tumor or radiation necrosis, which is probably one of the most common indications for laser interstitial thermal therapy at this point. This is just sort of a treatment that we did while I was at MD Anderson, treating a recurrent tumor using laser interstitial thermal therapy, again, heating the tumor from within through a minimally invasive procedure. Now, probably the most common indication at the moment for LIT is to use it for controlling radiation necrosis. Many patients who have had radiation may have symptomatic radiation necrosis requiring long-term steroid treatment. Now, long-term steroids, as many of you know, have a multitude of side effects. And so LIT is being used as a potential treatment to decrease the length of time patients require steroid use. And this publication coming out of the Fecci group found that with just a hospitalization time of about 32 hours, a patient can have come off steroid use with a median of about 17 days compared to a much longer time if they weren't treated with LIT. And in addition to that, we're seeing that LIT can actually be beneficial for seizure control in patients with brain metastases and seizures preoperatively. So when you compare LIT treatment to alternative options such as medical management alone, patients in the literature have shown that with LIT, they can come off steroids within 37 days compared to over 200 days of steroid treatment with typical conservative medical management. In addition to that, if you compare it to bevacizumab or Avastin treatment, which is the other sort of standard of care for radiation necrosis, we see similar rates of improvement and weaning of steroids with actually somewhat improved survival in the lit population compared to the Avastin group. Now, the last sort of surgical indication that I want to share and talk about for brain metastases is actually the treatment of leptomeningeal disease. So leptomeningeal disease occurs in about 3 to 5% of patients with solid malignancies, and it's basically the end stage of patients with brain metastases. It's when the tumor begins to spread within the CSF or cerebrospinal fluid spaces, and many of these patients can present with debilitating intracranial hypertension, with severe headaches, lethargy, nausea, and vomiting, and this can really prevent them from going on to any other treatment or even sometimes getting out of the hospital. So one of the treatments that has become more common is the use of CSF diversion or ventricular peritoneal shunts for patients who are presenting with symptomatic hydrocephalus due to leptomeningeal disease. Now, we evaluated a population of almost 200 patients who we treated with VP shunting at Memorial Sloan Kettering and found that survival is very limited in this population. Average survival after shunting was only about 2.5 months. But if you selected a population of patients who had a KPS greater than 60 or who had fewer than 8 brain metastases, we did find improved overall survival in that population. And 83% of patients did have symptomatic improvement after this treatment. And so with that symptomatic improvement, these patients were able to be discharged home in 70% of the population, and that allowed 50% of them to go on to get further systemic treatments. Now, as we improve our systemic treatment options, and especially as we introduce new treatment options for leptomeningeal disease, the idea of getting these patients out of the hospital and allowing them to get to another treatment becomes actually very important. So I've covered a wide swath of topics, and I sort of just hope that there are two main topics, or 2 main points that you can take away. One is that the prognosis of patients with brain metastases is improving, and that means that neurosurgeons, radiation oncologists, and oncologists alike have to come up with better treatment and local therapy options and salvage treatment options for these patients as they live longer. And we're seeing a growing number of opportunities within neurosurgical oncology to treat and help this patient population. So that's it, and thank you.
Okay, so thanks for everyone's attention. I'm sure you all agree it's been a real stimulating morning so far. The speakers have been excellent in every aspect. That goes without saying for our next speaker, Dr. Justin Sporer, who I have known for the past 11 years here at Baptist. I didn't realize it was that long. He's actually been entertaining me here for 11 years. For what I lack in the ability to tell a joke, he will make up for it, I'm sure, on this stage, I hope. Dr. Sporer is the Director of Functional Neurosurgery at Baptist Health Miami Neuroscience Institute. He received his medical training at the University of Florida College of Medicine in Gainesville. He's also a Gator, like I mentioned with Dr. Vasquez, and he completed his internship and residency there in neurosurgery as well. During his residency, he received the Charles Shank Award in Neurosurgical Excellence and Resident Teacher Award. He's a great teacher and a great lecturer, and was chief resident as well. He has special interest in deep brain stimulation, which is how he ended up doing our functional medicine program, which he's going to talk about today. And he's he'll talk about specifically high-intensity focused ultrasound and transforming treatment for essential tremors, which he's been doing a lot of great work here with HIFU. So really pleased to bring on our next speaker, Dr. Justin Sporer.
Thank you, Ron. And thanks for making fun of me that my CV was the shortest of all the neurosurgeons. And also, the last time I presented here during a photo op, I fell off the back of the stage, which don't ask how that happened, but I'm okay. Today, we're going to be talking about high-intensity focused ultrasound. And if you get nothing else out of it, we can cure somebody's tremor in 45 minutes with no surgery.
And functional neurosurgery is changing somebody's circuitry in their brain to improve the quality of their life, to improve the function of their brain. And so people with tremor, with Parkinson's disease, with dystonia, these various movement disorders, their brains aren't functioning properly. The neurons are not communicating properly, and it's our job, or my job, to make sure that they start communicating properly to improve their quality of life. No disclosures. So tremor. The most common diagnoses for tremor are actually essential tremor. There's 10 million people in the United States who have essential tremor. Compare that to 1 million people with Parkinson's disease, which I think gets a lot more press. But we all know somebody, probably our grandparents or even people younger than that, who have some shake, and you think, well, that's just a normal part of getting older. Another key point for today is not necessarily a normal part of getting older. It's something that is at least worth addressing. The other types are physiologic tremor, which everybody in the room has to a certain extent or another. And even the neurosurgeons, when you're under the microscope, everybody sees that their hands shake a little bit. We're just very good at accounting for it and adapting to it. Other causes would be multiple sclerosis, trauma, and stroke. The most common treatments are medication, medication, medication. I mean, that's where we should start. Even though I started by saying that we can cure it with no surgery, et cetera, I think it's worthwhile to start with medication. And in essential tremor, it's in the class of drugs of like neural depressants, okay, propranolol, primidone. There are other options though. Ultrasound. So, you know, everybody's familiar with the technology of ultrasounds, existed for decades, both diagnostically and therapeutically. But at high intensity, the energy at a focal point, if you're aiming ultrasonic beams at one spot, the energy, the kinetic energy at that spot will actually increase such that the molecules will be vibrating and the temperature will raise, and then you can ablate tissues. And they've used that for decades to kill tumors of the liver and uterus. But in those cases, there wasn't much between the ultrasonic transducer and the tumor. We have a problem, though, with the skull as being in the way for treating problems of the brain. And so the big question during this time was, how do we maintain that energy and focus that energy to a very specific point in the brain? We're aiming at things that are 2-3 millimeters in diameter, while, you know, and able to actually affect a change. And so, you know, the skull absorbs energy, it also reflects energy, and it also refracts energy. And so every time that an ultrasonic wave, just kind of like a light wave, goes through from one medium to another, you're going to lose some of that energy, or it's going to be redirected into a different place. And so you can see here that the skull is made of 3 layers: an outer cortical, harder layer, a softer kind of medullary layer or bone marrow layer, and then an inner layer. And you can imagine each time that the energy passes through each of those layers, some of it's going to be absorbed, some of it's going to be refracted. It's kind of like yelling through a double pane window, glass, air, glass. And so it was a really a complex physics problem that I don't claim to have fixed, but some very smart engineers and physicists figured that out. And so here's the other brain problem. Let's say we figure out how to get ultrasound into the brain. Well, how do we know that the energy that we're introducing is causing a change in temperature at a very specific location in the brain? And it turns out that the answer is MRI thermometry, where I'm still amazed by this every time I do it. Every 3 seconds, an MRI machine can take a picture of your brain and know what's the temperature at every location in the brain every 3 seconds. And so it's like looking at a turkey in the oven and without a thermometer, just taking kind of a heat map of it and saying, okay, it's 176 degrees there, it's 200 degrees here. And so we're able to get real-time accuracy of knowing what is the temperature of every point in the brain. So we use an ultrasound machine to determine the energy that's being input. The MRI knows the temperature of every point. Okay, so now we know this point in the brain is 57 degrees Celsius. How do we know that that is enough to cause an ablation? Well, we use math and physics to determine that 57 degrees for 1 second is hot enough to cause a permanent ablation or burning of those neurons. And 54 degrees for 3 seconds is just like cooking. And so you can either do high heat for a small amount of time or lower for a longer period of time. And then once an ablation has occurred, how do we know if that's in the correct location or if that's having a clinical effect? Well, that's where we come in. The neurosurgeon can check for an effect by testing for tremor or testing for a lack of tremor, which is what we're aiming for. And so magnetic resonance guided focused ultrasound, or MIRGFUS, but it's much easier to say HIFU, which is high intensity focused ultrasound. And so you'll hear people talking about HIFU, and I really want to stress that we have an international audience here today. Even in Miami, it's hard to educate the general public and educate even the neurologists that this exists. And so I see patients all the time who come to me, they self-referred because their neurologist didn't know that this existed. And so it's such a wonderful option for people with essential tremor, particularly those who are not candidates for some of the other treatments. They can't get the medications because of their heart rate. They can't get deep brain stimulation because they're 92 years old and on blood thinners. So this is quite an amazing option for those patients. And so we're able to get the magnetic resonance guided part of it is the part where we're able to get a heat map of the target area and allows us to choose a very specific target. All right, so the target is the ventralis intermedius of the thalamus. I'm sure everybody is up to date with their neuroanatomy knowledge of the various subnuclei of the thalamus. But I think of it as like a small egg-shaped structure right in the center of the brain as a relay station. Remember in the old-timey movies where the operator had all the wires that were connecting one person to another on the telephone? Everything that you think, feel, do, say, move has to go through the thalamus at one point or another. And so the part of your brain that moves your arm, for example, that message has to go through the thalamus before it goes somewhere else. And so it's the relay station of the brain, which is interesting because then if you make an ablation at that subnucleus of the thalamus, you can have a big effect with a small ablation. All right, so I think of essential tremor as the perfect HIFU disease, all right? And the reason is because there's very few symptoms besides the tremor. Parkinson's, for example, is much more complex. A person's got not only tremor, but rigidity, slow movements, problems with sleep, problems with smell, problems with their GI system, problems with walking. I mean, it's a complex set of symptoms. Essential tremor is just tremor. We know, and we've known for almost 100 years now, that the target in the brain is the VIM. And in fact, the idea of burning those cells is not new. I tell this to patients all the time. That's not new. We've been doing it. But in the past, you had to open up someone's skull in order to achieve that. So what's new is being able to do that same thing with no surgery. And tremor itself is a very testable symptom so that you can look for an immediate effect and, if necessary, make an adjustment. I believe, and I hope to be involved in, using this technology to cause ablations to help things like obsessive compulsive disorder, depression, various other neurologic maladies. The problem is, or one of the problems that we need to solve is, how will we be able to test for that immediately? Do you feel happy now? It's something that is kind of a longer term thing. Whereas the tremor, it's there one moment and literally 30 seconds after the ablation, the tremor's gone. And so we're able to see exactly what we need to improve. You can see on the left, there is a sagittal view of someone's brain, and then on the right, I don't know if I can, is there a laser on here? There we go. Maybe not. Anyway, you can see there is a black dot right in the middle of the thalamus. The thalamus is basically in the center of the brain. So that's the ablation. It's just that big. And it is able to stop and kill those neurons which are adding this extra message to every movement that you do. So I want to move my finger to my nose. Well, those tremor cells, they're literally called tremor cells, are adding this extra rhythm to that movement. If you kill those, so I use the word ablate with patients. Kill has a negative connotation, of course, but I'm very open with them. We're killing those neurons. They're not doing you any favors, okay? And so that's the post-op MRI. What I really like is that it allows you to do a test drive. And so you can introduce the ultrasound at a lower dose and heat up those cells. Remember, I mentioned 57 degrees. Well, it turns out if you raise the temperature to 51 degrees or 52 degrees, the neurons are stunned. They stop working, and the tremor goes away, but they're not dead yet. And it's just like if you put ice on your hand, it'll go numb. But as soon as you take the ice away, the neurons heat back up and they start working again. Well, it works in the opposite direction too. If you heat up a neuron and it can't function anymore, then you see, well, what did that neuron do? So we'll introduce the ultrasound, we'll raise it to 51 degrees, and I'll go in and examine the patient over and over again. If their tremor is getting better, well, what does that tell me? I know I'm in the right location. Then I feel confident to go back out to the machine and turn up the energy to cause a permanent ablation. On the other hand, if I raise it to 51 degrees and the person says, "Doc, I feel some tingling in my mouth and my speech is a little bit off," which happens, then I say, okay, and I use my knowledge to say, well, I think we're about 2 millimeters behind the target that we want to be. And so I just change it, and nothing permanent has happened yet, so it's a test drive. So somebody had this idea, what if we kill these neurons with radiation in the past, with stereotactic radiosurgery? Great treatment, except once you've delivered that radiation, that's it. There's no going back, and you won't even know if you were right or wrong for weeks or months by the time the radiation effect kicks in. And so I like this better because you are able to test drive it right there, see what the effect is going to be, and that's it. And so I'll have the patient drink from a glass, draw a spiral, write their name, finger to nose. So this is, I have the patient try to start at that center dot with a marker and stay in between those lines. And that's the effect. Can you imagine somebody trying to shave their face with that kind of tremor? Or use a mouse? This is another one that is kind of a more modern example. People say, I'm buying things left and right on Amazon that I didn't intend on buying because they're clicking the wrong thing. And I've seen people, they put their arms up against the wall to shave their face. They just move their head because they can't possibly move their hand to do such a fine motor task. Women with putting on mascara, forget about that. But the number one complaint is embarrassment when I'm at a restaurant. And so, I think of all of my colleagues, probably embarrassment is not the number one complaint that they're operating on complex aneurysms or brain tumors, et cetera, but it's my number one symptom. And, because it's so safe, that's a reasonable reason to do a procedure. And so I think that once we've done the procedure here, this is their spiral 45 seconds later. So it's just so satisfying. It's really satisfying because the patient's like laughing or crying and we're like high-fiving, et cetera. And then they go home. They go home that day. So it's a really fulfilling procedure. The advantages, it's non-invasive. There's no surgery. You take blood thinners, that's okay. You're 95 years old, that's okay. You have breathing problems, that's okay. It's not a surgery. So if you can undergo I wouldn't even take colonoscopy because that has some level of anesthesia. If you can get a cyst removed from your arm, then you can do this. No hardware to worry about. And I mention that because I also do deep brain stimulation, which I think is a wonderful procedure for people with Parkinson's and a lot of people with essential tremor too. But for whatever reason, people really don't want this piece of hardware in their body. And the batteries need to be replaced, et cetera. The test drivability, we talked about that, and it's super effective, and 45 minutes to an hour later, the tremor's gone. Drawbacks, you do have to shave your head. I see some people in the room that are already ready for the procedure. It's not an easy alternative. So some people say, I don't want brain surgery, I want HIFU. I say, listen, those 45 minutes where we do have to put a head ring on them, we have to shave your head. During the procedure, you can have a feeling that you're like falling backwards. It can be an odd experience, but people tolerate it fine. I guess that's more of an endorsement of the deep brain stimulation, which is also not that big of a deal compared to what people think it's going to be. And then temporary numbness of the face and hand, temporary imbalance, those would be the top two side effects. Remember, we're making an ablation in this relay station that controls everything. So the analogy that I use is that if I put a cigarette out on your skin, I promise I won't, but it's gonna look like just the tip of that cigarette. But if I look at it the next day or 2 days afterwards, it's going to be all red and swollen all around there. And the same thing happens in the brain. I'm making about that size ablation in the brain. The day after and the day after that, there's some swelling, which causes some dysfunction of those neurons. But I tell them, hey, listen, if these things show up on day 1 and day 2 after, then I'm very confident it's the result of swelling. And as the swelling recedes, the tides go back out, those neurons will come back to normal. So I strategically have the patients follow up about 2 to 4 weeks after the procedure so that all their negative feelings towards me are gone and their side effects are gone, and it's just the tremor suppression that they're left with. This is just, for a long time, people say, well, okay, well, what's the long-term result? This is the 3-year results, and we now have actually 5-year results. I need to update the presentation. It's still 76% improvement in tremor on average, and that includes some rare people who don't get benefit. I would say the people that don't get benefit, it's because we're never able to achieve that temperature. It's not that it didn't work, it's that for whatever reason their skull did not want to allow that ultrasound in. Well, if you don't actually achieve what you set out to achieve, it's not going to have the effect that you want to affect. But on average, 75, 76% improvement in tremor, which can make a huge difference in those, restaurant type situations or makeup situations, or how about eating and drinking at home even. So it has a lasting benefit. This is a video of a gentleman on the left before and after. Lady before and after. And the difference between those two things could be, like I said, about 45 minutes. You can see she's got a shaved head, though. I'll go back and play it again so you can. So I think the marketing group got together and they always give our patients a lunch afterwards with soup, with like these ultra full glasses of water, the game operation. So, just to show exactly how much better it is instantaneously after the procedure. So the final points. Tremor is not just a part of normal aging. So if you know somebody who's got a tremor, whether that's in your family or in your practice, et cetera, I think it's worth at least addressing. And that's either with a movement disorders neurologist, or if they've already got a diagnosis, then with the neurosurgeon. It can be treated first with medication, but HIFU, high intensity focused ultrasound, it's safe, it's FDA approved, it's very effective, it's covered by most insurances at this point. And more recently, we've used it for things like Parkinson's disease, and there's research being conducted for, now the second side has been approved, other movement disorders, and even psychiatric conditions. Thank you. And that's my email.
That was exciting research, not research, exciting knowledge, and what we're doing here at MNI and with Dr. Sporer is great. We used to call Dr. Sporer the king of kyphoplasty, or king of kypho, and he still is, but now he's also the king of tremors. So, and if you ever see him socially, you might see he can also be the king of the dance floor. So thanks for a great presentation. Our next and our last speaker for the morning before our question and answer panel is Dr. Luis Felipe Tornes, who's also one of our newer physicians in the group under neurology. Dr. Tornes is our director of the epilepsy program at Baptist Health, Miami Neuroscience Institute, and he earned his medical degree from Florida International University, Herbert Wertheim College of Medicine, so he's a Panther initially. And then he completed his neurology residency and a clinical neurophysiology fellowship at the University of Miami Miller School of Medicine. So he's also a Kane. So I'm not sure where his allegiance is right now. I'll have to ask him that. He has presented at national conferences in his field and specialty in American Academy of Neurology and the American Epilepsy Society. He's passionate about comprehensive care and holistic care. He's also our residency director in neurology, so we're very pleased to have our first neurology residency starting here in conjunction with FIU and Baptist, and they're currently interviewing for 4 spots in neurology now. So it's with great pleasure that I bring up Dr. Tornos, who'll talk to you on epilepsy, the new era of diagnostic and therapeutic intervention. Dr. Tornos.
So thank you all for having me today. Thank you for Baptist International for setting this up. I will say I'm probably a little bit more of a Cane just because the Canes are a little bit better than FIU. And also the Canes played FSU and UF this year and we won both of those games. Season didn't end up that well, didn't make the playoffs it looks like, but otherwise it was a good season for us. So I'm going to be speaking to you today about basically management of epilepsy patients. In particular, more medical management. I'm a neurologist, not a neurosurgeon. So let's see. So I have no disclosures. So today we're just going to be talking about epilepsy statistics overview. We're also going to be going over the definition of what drug-resistant epilepsy is. We're also going to be just quickly touching on epilepsy surgery. And then really the majority of the talk is going to be on cenobamate, medical management of drug-resistant epilepsy, going over the mechanisms of actions of the medication, also kind of what are the adverse events that you should be expecting when you start patients on this medication, the more common ones and the ones that you really should be worried about, and also how do you use this in your daily practice. Really the point I want to get across in today's lecture is in epilepsy and in medicine in general, there's always new medications coming out, and it's kind of introducing this new medication into your practice. How do you use it? So that's kind of really what I want to get across today and why we should be using it. So for statistics. So within the United States, from the last census in 2020, there's around 331 million people. For the CDC, around 1.2% of the population in the United States has epilepsy. So that's a little less than 4 million patients with epilepsy in the United States. So it's a pretty large percentage of patients. It's something that we see pretty commonly both in the inpatient side and also in the neurology clinic. So I like to show this slide, and maybe some of you have seen it before, but just kind of going over all the medications there are in epilepsy and how much there's been in terms of growth of medications in epilepsy. So as you can see on the slide, and I'm sure none of you have probably ever used this medication, bromide was the first one that was ever used in the 1800s. But if you look at the next medication, phenobarbital, I'm sure some of you have used that medication before. That was kind of really the first one that was created in the 20th century. And then you could just see the exponential growth after that. All these new medications going through that first generation, the second generation, the third generation of anti-epileptics, and really more and more that continue to come out. But despite all these new advancements and kind of options that we have in these anti-seizure meds, there still remains a portion of your patients with epilepsy who have drug-resistant epilepsy and will continue to have seizures despite this. So what exactly is drug-resistant epilepsy when you hear that term? And it sometimes could be phrased in another manner. It might be referred to as refractory epilepsy, intractable epilepsy. Really, it's all the same. And what it means is, per the International League Against Epilepsy, which I think is one of the best names in medicine, that's a great name, they define drug-resistant epilepsy as someone who has failed to become seizure-free after being adequately trialed on 2 separate anti-seizure medications. So if you have a patient been tried on 2 appropriately dosed medications for seizures and they continue to have seizures, that's defined as drug-resistant epilepsy. So this is another chart that probably some of you have seen if you're familiar with epilepsy. It's one that I really like because it kind of breaks down what's the chance of your patient having drug-resistant epilepsy, or what's the chance of your patient responding to medications when you start them on it. So as you can see on the graph and the pie graph, when you start someone on the first anti-seizure medication that's coming into your office for epilepsy, you've determined that you have epilepsy, you need to be started on a medication. When you give them that first medication, there's only around a 50% chance that they're going to remain seizure-free from that first medication. If you were to add a second medication, you see that's a 13% increase. So now you got yourself a little bit higher. So here in this chart, you'd have yourself around 60%. If you add a third medication, now you have yourself maybe at 64% of the population is going to be seizure-free. That still leaves you with 36% of your patients who are going to continue to have seizures despite being on 3 medications. And as you add more and more medications, that percent of seizure freedom gets lower and lower. So why is it so important to really discuss this? Why is drug-resistant epilepsy important? Why is it important to get seizure freedom? Well, the reason is because there are complications for your patients if they have drug-resistant epilepsy. And having seizures it really is something that can have a detrimental effect on the person's life. So each year, around 1 in 1,000 patients with epilepsy will die from sudden unexpected death in epilepsy, SUDEP. And that's the risk of that is increased in patients who have poorly controlled seizures. So people who are having multiple seizures, more so in generalized epilepsy, but people or focal to secondary generalized epilepsy, you want to have your patient well controlled, because if they're not, they can increase the risk. Also, having uncontrolled epilepsy has a higher risk of death and overall mortality secondary to seizures and suicide. It also reduces your quality of life, cognitive functioning down the road, anxiety, depression. All of these factors are associated with poorly controlled epilepsy. So it's something that you really should be working with your patient. Just for example, in Miami, it's really hard to get around Miami without being able to drive. And in the state of Florida, if you have a seizure for these patients, they can't drive for 6 months. So that can be really detrimental for someone and can really have a huge impact, just that alone, outside of all these other things I just mentioned. So it is really important to achieve seizure freedom for these patients. It can really make an impact in their life. So what do we do with these patients? So someone comes to you, they're on 2 medications, maybe 3 medications, they continue to have seizures. What are our options? Do we continue to add meds? Do we change the meds that they're currently on to try different options? Do we refer them to surgery at that point? Or do we do nothing at all? Do we just say, well, there's nothing really you can do. You've already tried a couple meds. The % chance of seizure freedom is low. You have all these side effects. We're just going to kind of be happy with where we're at. So I would say that the best thing to do for these cases is surgery. And that's still the gold standard. That's still what you should always be aiming for. For people with drug-resistant epilepsy, surgery is going to be their best option to have seizure freedom. So the study's kind of looking at this, and in seizures in general, for surgery, the best case is a temporal lobe epilepsy. Non-dominant would be ideal. And in those, in terms of resections, not necessarily because I know they had spoken about earlier, and that is something we do a lot, laser ablation, but specifically in resective surgeries, there's around a 70% seizure freedom following a resection from a epilepsy secondary to a temporal etiology. That's a really high percent. So again, if you kind of look back at that chart, you think back at that chart what we discussed, where someone comes in on 2 medications, if you're going to add a 3rd medication, you only have around a 4% chance of seizure freedom. Here is 70%. So that's a huge difference. And that can make a huge impact, because not only, let's say if you were to add that 3rd medication and they fall into that 4% that, okay, now they're seizure free, but they're on 3 meds and they're going to have all the side effects from those meds. So being able to get them surgery, you might be able to eventually get them on monotherapy, maybe even get them off of all their meds. So that's still the best option. For people who have non-temporal etiology epilepsy, it's still a high chance. It's still 62%, which is still much better than that 4%. So this should still be the gold standard. All your drug-resistant epilepsy patients should be referred to surgery. The issue is that what if your patient can't get surgery? They're not a candidate for surgery. Either their seizures are coming from an eloquent cortex, something you can't resect, or they have multifocal epilepsy, so you can't really resect the multiple areas of the brain. You have neurostimulation is another option. So you have the deep brain stimulator that was mentioned. We also use that in epilepsy. Responsive neurostimulation. We have the vagal nerve stimulator. But again, those are more palliative options. You're not going to get seizure freedom with those, but they're options that still you can use if patients aren't a candidate for surgery. But what if they're not a candidate for surgery, they're maybe not a candidate for neuromodulation, or in some areas, there's just not an option for surgery? There are some places where you can't refer someone to a neurosurgeon. A lot of times, the epilepsy workups have to be done in a large center with an epilepsy department, a neurosurgical department. They need an EMU. It's sometimes now, especially in the world of epilepsy, there's phase 2 trials where you're putting in depth electrodes to really localize where the seizures, and a lot of places aren't able to do this. So what do you do for these patients that, well, I can't do surgery on you, or maybe, again, just due to the lack of care, even if you're able to do it, it might be a year before the evaluation is completed. What do you do between that time where the patient's having all these seizures or they can't get surgery? And that's where I think cenobamate comes in. And I think it's something that's kind of changed now how we're starting to practice a bit in the world of epilepsy. So what exactly is cenobamate? So it's a medication that was FDA approved in 2019 for focal seizures in adults. It's a voltage-gated sodium channel blocker. And I know for you familiar with epilepsy medications, the vast majority of them are voltage-gated or sodium channel blockers. But this one's a little different because it, in particular, inhibits the persistent sodium currents. So most of the other ones don't inhibit that part in particular in the sodium channel. So that's what makes it a little bit different. And also, it's a positive allosteric modulator of GABA A as well. So it's most protein binding of around 60%, so it's not too protein bound compared to some of the other medications. It has a half-life of around 50 to 60 hours, so you can dose it once a day for the patients, which is nice. It's convenient for them. With regards to the adverse effects, it does have similar adverse effects to most of the other sodium channel blockers that we use. So lightheadedness, dizziness is going to be a common complaint. Fatigue, which you kind of see across all anti-seizure medications. Another one that you have to be kind of keep in mind is it can shorten QT intervals. So people with familial short QT syndrome, something to keep in mind that could be dangerous. And then the one that I think people really think about in terms of adverse effects and the one that kind of scares you as a doctor is the drug reaction with eosinophilia and systemic symptoms, so DRESS. This was something that was seen on the initial trials when cenobamate was being introduced. And there was even one patient in the trials with a fatal case of eosinophilic myocarditis. When they went back and looked at the trials and saw kind of why was this going on, they realized that it was probably due to the fact that they were starting these doses at the medication, the cenobamate, at probably too high of a dose. So now cenobamate is recommended on a slow titration, kind of similar to what you would do if your patients with lamotrigine to prevent Stevens-Johnson's. So they recommend the same thing. And when you do that, when you do this slow titration, it really has a low risk of DRESS. And there haven't really been any cases when they went back with the slow titration of fatal eosinophilic myocarditis. So while yes, it is something that doesn't completely eliminate it, doing the slow titration, it isn't something you should be too concerned about, but still you always have to discuss this with your patient and let them know that it is a potential side effect. The other one that really is also important is really the interactions with the other medications. And that really comes to how we use this in our clinic, how we're using it in practice. Again, this is a patient who has drug-resistant epilepsy. They're going to be on 2 medications, maybe 3, maybe 4, maybe 5. I have patients 6 medications, and you're starting a new medication, cenobamate, on them. It's going to interact with a lot of these meds. So you have to be familiar with the interactions and how you have to kind of go about handling that. And so why am I talking about cenobamate? Because I've just told you all this kind of, well, you should do surgery. The chance of seizure freedom is really low. There's no point in medications. And yes, you should still do surgery on all your patients. Surgery is always the best option for drug-resistant epilepsy. But this is why I think this medication in particular is so interesting in the world of epilepsy and kind of has changed how we approach some of these cases. So if you look here, and this chart here is showing the efficacy of the medication, so kind of what the reduction in seizures were in the initial trials of cenobamate. And if you look all the way to the end of the chart at the 100% response rate, that means that that person was seizure-free. If you look at the group that was on 400 milligrams, so that kind of pinkish color one, it was 21% of patients. So 21% of patients that were started on that medication, drug-resistant epilepsy, were seizure-free. So if you compare that to that 4% I showed you earlier, that's a big difference. So this is the first medication that's really started to kind of buck the trend of what we used to see where you introduce a new medication on these patients who have been on 3, 4, 5 meds. It's has a much higher rate of seizure freedom in these patients. Again, nowhere near what it was for surgery. I already showed you that 70%, still much lower. But this is still a great option for these patients who maybe can't get surgery or are in the process of getting surgery and it's just taking time. A lot of places, it's not easy to get the surgery workup. You have to come in for your EMU admission. You got to get your MRI, neuropsychology testing, PET scan. You might have to get a MEG. You might have to come back for a phase 2 with the depth electrodes. By the point that's all done, it might have been a year already by that time. So being able to put these patients on this medication in between could be something that you can consider. And then this one here, just kind of looking at the efficacy onset. So again, you can see here that in the first 4 weeks there, it's already showing efficacy. So you should already be expecting a response pretty quickly with this medication. It's not something that takes particularly long. The only thing I will say that here, again, in this chart is showing at 100 milligrams. And once you're already on 100 and then 4 weeks after that, in general, you're not going to be starting your patients. Do not start your patients on 100 milligrams of cenobamate. You're going to be starting them on 12.5 and going up on that slow titration. But once you have them on a therapeutic dose, the response should be pretty quick. So then kind of more sort of the practice, how are we using this? And this is the one that I like to focus on because it's the one where if you're starting someone on this medication, what you should be really considering. So unfortunately, the medication does have a lot of interactions with other anti-seizure meds, which makes it sometimes a little bit difficult to introduce for patients. So the ones that you should be keeping in mind, it is an inducer of the CYP3A4 and CYP2B6. So for those two in particular, it's going to be decreasing the concentration in the serum of lamotrigine and carbamazepine. The one thing about that is it actually might be beneficial for your patient because, again, those are both sodium channel blockers. Cenobamate is a sodium channel blocker. Your patient's probably going to have a lot of side effects from sodium channel blockade. they're going to be complaining of lightheadedness and the dizziness. So the medication decreasing the levels of those two might be beneficial in decreasing the amount of symptoms that your patient has. The one that's a little bit more important that you should be thinking of is the CYP2C19, which it's going to inhibit that. So it's going to increase the levels of phenobarbital, phenytoin, and clobazam. So your patients, when you start them on cenobamate, the levels of those medications are going to go up. So they might become toxic. They might start having side effects from those medications. So it's something you have to keep in mind. And while there's no pharmacodynamic or pharmacokinetic interactions with lacosamide, there are pharmacodynamic interactions. So basically, the lacosamide level isn't going to really change by introducing the cenobamate into your patient's regimen, but they're going to have a lot of side effects from the lacosamide. It intensifies those side effects. So if you have a patient on lacosamide and you start them on cenobamate, the level of lacosamide isn't necessarily really changing, but they're going to be complaining a lot of sodium channel kind of blockade side effects, that the lightheadedness and dizziness is very commonly experienced. So because of all of these interactions that this medication has, they actually went about, this is actually really nice. It's a little basically pocket guide. And that little dash in the middle there that you see I cut it out, but it says fold here because it's basically like intended for you to carry it with you. So what they did was they had basically they got a group of 7 epileptologists to come up with how should neurologists use this in practice? What should they do? So here what you can see is basically they broke it down and they've made it as easy as possible to what should you be doing with these medications that the patient is on when you're introducing cenobamate. So there's 2 ways you can go about it. You can be proactive or you can be reactive. And just to take, for example, the clobazam, so if you have a patient on 40 milligrams or less per day, you can be proactive and go ahead and start to decrease by 5 to 10 milligrams per day at the start of cenobamate, 12.5 milligrams a day. So, and then you can see kind of the proactive, it continues. You can go down again by 5 to 10 milligrams a day when you hit 50 and then again, or you can be reactive. And what they mean by that is basically you don't touch the clobazam, you don't touch some of the meds, and you just wait to see what happens. You start the person on cenobamate. If they're coming back to you and saying, I'm really drowsy, I'm really sleepy, well, maybe you start to come down on that clobazam. Because again, clobazam, while it's not as sedating as other benzodiazepines, it's still pretty sedating compared to most anti-seizure medications. So you can kind of be that reactive. The same for lacosamide. Here they recommend, and I'm sure most patients, if you look here, most of your patients are probably going to be on 400 milligrams a day, which is 200 BID. In this case, they tell you to be reactive, so only really make adjustments if your patient's complaining of symptoms. Similar to phenytoin and phenobarbital, you can kind of see they have it all broken down on what you should be doing as you're going up if you're being proactive, or what you should be doing if you're being reactive, and just making adjustments as the patient starts to explain that they're having those particular symptoms. I will say in general, I do like to be proactive. I think it's nice to just kind of get ahead of the side effects because as a lot of you may know, if you treat epilepsy patients, one of the biggest concerns for a lot of medications in general is how compliant the patient's going to be. A lot of times a year down the road, they might not be taking their medication anymore, not because they're having seizures, but because they're having a lot of side effects. So if you start them on cenobamate and they stop it because, well, they're dizzy, they're lightheaded, they're sleepy, you've kind of maybe prevented them from having a fair chance of being put on a therapeutic dose, because again, you have to go through that slow titration, but right off the start, you might start to have side effects, and they might never get up to that dose which is usually 200 milligrams a day is what they recommend to kind of start a patient or target to. So then you might have the patient stop the med before then, and you don't give them the chance of really seeing if cenobamate was beneficial for them. So this is really nice. It's easily available. I definitely recommend anyone who's going to be using cenobamate to grab this chart and use that, because again, a lot of these patients, they're going to be on 3, 4, 5 meds when you're introducing it. And then just quickly to mention, so while it's not FDA approved, there is use of cenobamate for generalized epilepsy as well. There have been some trials looking at does it help, and some of the initial trials have shown that it does help for generalized epilepsy, and a lot of patients who have focal and generalized epilepsy. So if you just want to be really strict by the guidelines and you say, I want to just use cenobamate for FDA approval, I'm going to use it to treat your focal epilepsy, but you also happen to have generalized epilepsy, studies have also shown that it's not going to worsen the person's generalized epilepsy. It's not going to be like a carbamazepine. You start patient that has both, and then their generalized epilepsy gets worse even though you're treating the focal epilepsy. So in summary, around 1/3 of your patients will have drug-resistant epilepsy. Surgery is always the go-to option. It's still the gold standard. They should all get a surgical evaluation if they have drug-resistant epilepsy. If surgery is impossible, or maybe the workup is taking too long, that's where you should be considering maybe cenobamate as an option as well. It's FDA approved for focal epilepsy. I'll mention it again, non-FDA off-label use for generalized epilepsy, and it has been shown to, seems to help. Around 21% seizure freedom, so that's much higher than what we've seen with prior anti-seizure medications. It does have a lot of interactions with meds, so just keep that in mind. That chart, use it. Your patient's gonna have side effects, so go ahead and start making like lowering the other meds to make them comfortable. And then just the slow titration. The packaging is done very easy. It kind of comes in the titration schedule, so it's very straightforward for the patient, and that really lowers the risk of DRESS or other of these severe complications. These are my references, and thank you. Oh, yeah.
Thank you, Dr. Tornes. Great job. And I would like to now invite all of the speakers from this morning up on stage in these white cushy seats. All of them, but Dr. Vasquez had to go to surgery, so he won't be joining us. So if there are questions for him, we can certainly hold those questions, give them to him, and get contacts from you and get you those answers, or one of the other surgeons can chime in. Also, I should mention that Dr. Sporer has to go to surgery shortly.
It's okay.
It's okay? All
We
right.
can wait.
All right, so we're going to open up the question and answer session by, and we have people going around the room with microphones, and we'll come to you to answer your question. We have a gentleman in the front with a question. The microphone's coming to you now. And I want to compliment all the speakers today for such a fabulous job. I think you'd all agree.
I am Luis Bracamonte from Lima, Peru. I'm cardiovascular surgeon. Dr. Dabus, can you explain a little more about your last treatment, the conduit between carotid and femoral vein, and where are the indications for this type of procedure?
Perfect. Absolutely. So basically your question is, indications and how the TCAR, which is transcarotid artery revascularization, works. So first of all, indication. So if you look into the Roadster 1 and Roadster 2 studies, those are the studies that were done as a registry to look into the safety and the effectiveness of the procedure. So the procedure actually was remarkably effective and remarkably safe. Actually, their numbers, which are adjudicated independently, are actually probably better than a lot of the other studies from comparative techniques. But of course, it's very hard to make a distinction between TCAR and carotid enterectomy or carotid transfemoral angioplasty stenting, because those were never really like randomized studies against each other. But right now, actually, most of the patients that are candidates for revascularization are candidates for TCAR. Some of the contraindications for it would be similar to a transfemoral carotid stent, for example, a patient that for whatever reason cannot be on dual antiplatelet agents, because that's required when you put a stent, independent if you're doing transfemorally or through the transcarotid. Sometimes, if the patient has very tortuous common carotid, very short neck, it may be a little bit difficult. Exactly. I mean, there are ways to do it, and a lot of people with more experience now are doing pretty much for a lot of the patients. If you look into, even if you look at our numbers here, TCAR took a lot of the volume from endarterectomy. A lot of actually the younger vascular surgeons are preferring to do TCARs. It's a little bit less invasive. The patients are doing very well from it. It's very simple, the technique. So the technique is basically a carotid exposure, a little ligature in the proximal common carotid. You put a 9 French sheath, which is a specific sheath from a company that makes the device. And so you connect the sheath, you kind of basically suture the sheath in place in the chest really quick. And then you get a 9 French femoral vein sheath that you put in the femoral. You basically connect the cable. The cable has a little filter in between. And basically, when you're ready to do the procedure, you basically ligate the common carotid just proximally, so you have true flow arrest, and then basically reversal flow. And then the procedure, literally, like the angioplasty stenting part, it's really the easiest part of the procedure. I mean, it literally takes like 5 minutes. Put the balloon, inflate, put the stent, and you're done. You wait about a couple minutes with flow reversal. You untie the ligature of the common carotid, suture the orifice in the common carotid, the puncture site, and that's pretty much it. And the procedure is done. It literally takes less than an hour to do it. So again, the indications of it are pretty much all the patients, as long as they have good anatomy to do it, they would be a good candidate. Of course, there's always questions about, oh, if you have a very calcified lesion, usually those are not very good for any kind of angioplasty and stenting. Maybe, it would still be preferred to do an endarterectomy. But other than that, it's really any patient is a candidate for that. And we do that in conjunction with the vascular surgeons for many years here. It's a very good procedure. Nowadays, actually, a lot of the procedure done just by the vascular surgeons. It's very straightforward. And it literally, the patients like it. A lot of times given like, TCAR, transfemoral carotid stent, if the patient has a very bad arch or very tortuous proximal carotid, or sometimes a very tortuous common internal carotid artery, because when we do it transfemoral, we need to put a filter there. And if the patient has a very tortuous, very loopy internal carotid artery, it's usually not a good idea to try to navigate the filter through it because the filter is fairly stiff. So TCAR would be a great option for that as well.
Thank you. Next question.
Hello, I'm Dr. Abad from Quito, Ecuador. I run the epilepsy center over there. Just want to make a quick question to Dr. Tornes. What's your experience using deep brain electrodes versus cortical grids in successful rates in surgery?
Yeah, so for the phase 2 grids versus depth electrodes, I will say that my experience is much more so now in depth electrodes, and I do think it is something that most places in the United States, most of the larger surgical centers have started to move towards. I do think they both have their pros and cons. I do think for the actual localization, depending, especially on the deeper structures, the grids are not as good, in my opinion, as the depth electrodes. Also, the depth electrodes are less invasive than placing a grid. So I think now for most places, they've started to move away from grids, and most cases are being done purely with depth electrodes, with the very rare case including a grid if necessary. Because you can even use the depth electrodes for mapping as well. You can stimulate the electrodes. There are also other uses of electrodes that's starting now to be used in the United States, where kind of in Europe you were seeing thermal coagulation with the electrodes as well, the depth electrodes, which now a few centers are starting to do that within the United States. So if you do a phase 2, you plant the depth electrodes, you have an area where you think the seizures are coming from, you can actually right there before you remove the electrodes, thermal coagulate the area, remove them, and then see before they come back in for their resection or what you were planning on doing, well, did we cure them of their seizures? So I think the depth electrodes are probably the better option. I know in a lot of other places outside of the United States, especially in Europe, it's something they've been doing. And I know in France and Italy in particular, they have a lot of experience with depth electrodes, way more than we do here in the United States. They've been doing it since the 70s, I believe. So I do think that seems to be kind of the future now, is moving away from the grid and more towards depth electrodes.
Thank you. Another question. Yes, sir. Front.
To Dr. Dobus. It's about the stenosis of the carotid artery. The prevalence of coronary arterial disease in this patient is higher. Do you study the coronary's anatomy before the procedure? And what do you do when what are the kind of lesions in the coronary arterial tree that you decided to treat before to treat the carotid stenosis?
So thank you very much for your question. I think that's a very interesting question. Basically, depends a lot on the patients. A lot of our patients here, particularly when we're consulted in-house, they do get evaluation by cardiology to make sure. And the reason for that is that for many, many years, we were basically splitting those patients if they were high risk or not cardiac-wise. And why is that important? Because of the smaller increase in risk of MI during the arterectomy. So a lot of those patients would be basically evaluated by cardiology to define if they would be considered high risk or low risk for endarterectomy. So if they were like low risk, this patient would go all to endarterectomy. And if they were high risk, they would be referred for either angioplasty and stenting through transfemoral or transcarotid route. But a lot of this, unless the patient has a strong cardiac history, then maybe they would require, like a stress test and see or even like sometimes a coronary angiography to see if they need to have anything done before those type of procedures. A lot of it is just based on also on the risk factors and risk profile. And they would be enough, for example, if the EKG is normal, the patient doesn't have any symptom, they would just consider this patient a low risk because it's kind of a low risk profile. So yes, I mean, it's always an interesting question, but if the patient was considered high risk from the cardiac perspective, it's not that he would necessarily intervene ahead of time unless there was like symptomatic, of course, asymptomatic not. And then the patient would be referred for angioplasty and stenting. Now, the reason why a lot of this was done is because until last year, the healthcare system here in the United States was only reimbursing either carotid angioplasty and stenting and TCAR if the patient was high risk for endarterectomy, was the main, and symptomatic. So now these things change. So a lot of the patients are just not necessarily going to the endarterectomy because there are other options that they may be going forward. But we still always get clearance from cardiology to make sure this patient is not high risk, or if it is high risk, if there's any other precaution that needs to be taken.
Thank you.
Dr. Thoms, as far as localizing where the source of the focus of epilepsy is PET scan, where's the place for PET scan versus MRI, or are both complementary?
Yeah, that's a good question. So I think they're both useful. They both have their places. And especially now where you're seeing a lot of more cases of these drug-resistant epilepsy patients who are coming in and they're not the textbook mesiotemporal sclerosis on MRI, which everyone loves to see because it's a super easy case. I think a lot of patients now are coming in and they're what we're calling non-lesional epilepsy. So PET scans play a role because you can have decreased uptake in an area where maybe on the MRI, it showed nothing. So I think most cases, and kind of from what I do and what I've seen a lot of people do, is you use both. Both of them could be helpful. They can give you different information, and that's in conjunction with all the rest of the workup you're getting in your phase 1. So does the PET scan match up with the semiology? Semiology, well, yeah, we have a lot of fancy studies now with the PET. We have MRI, we have depth electrodes, we have MEGs. Semiology is still keen. So does your semiology match up with what you're seeing on your MRI? Does it match up with what you're seeing on your PET scan, on your MEG, on your scalp EEG, on your depth electrodes? So I think it always plays a role and could always add additional information to your workup. So it's something that if possible, I like to have all my patients get a PET scan in addition to their MRI.
Thank you. Next question. Okay.
Dr. Ina Miller from Honduras. Dr. Dabus, I'm curious about your asymptomatic pool of patients. What is the usual workup for that patient to arrive to that diagnosis and for you to consider treatment?
Perfect. So, we live in an era that a lot of the patients come in with any kind of neurological symptom that may not be even related to anything like dizziness or headache and all this kind of stuff. They come to the ED or they go to their primary care physician, and it's almost, a lot of them get ordered neuroimaging like CTA, MRAs, and things like that. So a lot of those are found like that, are incidental findings, right? Because they're asymptomatic. They're not having symptom related to the carotid. A lot of those patients are also referred from basically their primary care offices or cardiology offices where they do like annual screening with carotid ultrasound, and they pick it up, and then you start a workup. Now, again, the workup is, a lot of times you get a patient with a carotid ultrasound, then you go to a little bit more detailed imaging, usually non-invasive first, either an MRA or a CTA. And then you need to have a discussion about the patient, well, first of all, you need to understand what's the degree of stenosis that you're dealing with. And then, expose really both options of the coin to the patient. There's really no clear data that tells you that you need to be treated if you have like a 70% stenosis, for example, although there's no randomized data that clearly tell you that medical management or treatment with either surgery, TCAR, or angioplasty and stenting should be done preferred against the other method. However, we always explain that there's some new data, some new evidence that the degree of stenosis will actually potentially impact the risk of stroke, even if they're asymptomatic now. So it's a very open discussion because there's no randomized trial that tells us exactly what needs to happen. However, when the patients are put that way and the patient has an 80% stenosis, for example, that is asymptomatic, and they understand that the risk of them having a stroke is about 3 to 4% per year, a lot of them prefers to get treated. So it's almost like a discussion, and it's really a combined decision. Now, of course, if the patient has 75% stenosis, very elderly, asymptomatic, multiple comorbidities, you know, that takes into account if you're going to do an invasive procedure in a patient like that, because that's going to be potentially some extra risks involved. So it really depends on the whole scenario, because there's still, we don't have the clear data that probably will come with CREST-2 that will be really the decisive data tell us, oh yeah, this patient needs to be treated this way or that way. And we look forward to that, to those results.
Thank you. For some of the other panelists, Dr. Sioman, when would a non-neurosurgeon or non-neurologist send you a case when, for example, a primary care physician does an MRI on a patient for headaches or dizziness and finds an aneurysm? Would you want them to come directly to you, or would you want them to have a particular workup before they see you for an aneurysm?
Well, there's really no particular workup. It's you're talking about somebody who was incidentally
Incidental
diagnosed.
finding, yeah.
And it really, you know, I would like to see this patient so that we could capture them, so that we could direct them in further treatment. Because it would be best for them to be evaluated by specialists, and you know, then, you know, if they come to me, I would, you know, evaluate the size of the aneurysm, the location, anterior circulation, posterior circulation. If it's a truly incidental headache, because sometimes headaches can be a manifestation of an instability of the vessel wall, like somebody who never had headaches and now has a very irregularly shaped aneurysm, and with risk factors, high blood pressure and family history, then this patient might be a candidate for, you know, some kind of treatment, and then we can triage it from there. And generally, we have a very close communication. We just, you know, I would just call the endovascular colleague if the patient comes to me, and the vascular colleague will call, you know, us. And, you know, we have a luxury that they've already would perform the angiography, and then we come with the 3D images, and then this is a surgical candidate. But if it, you know, the patient comes to me, I will have to call the endovascular colleague. But it's regardless, it would be best to send them directly to the specialized, you know, physician who could just take it from there.
Perfect. Thank you. Dr. Sporer, for those patients referred to you by tremors, let's say from primary care office, how many of those people do you see that really maybe have Parkinson's and weren't worked up or evaluated for that? And then what do you do?
I see a lot of patients, like I said in the talk, that self-refer for the procedure. I try to do a pre-screening, actually. So we'll call them before their appointment, and I'll ask a few quick questions. Essential tremor is pretty easy to diagnose, in my opinion. That's why I don't need a movement disorders neurologist involved in that. And that's a long history, a strong family history. It's 50% inherited, and it gets better with alcohol, and the tremor is worse with activity, not with rest. And so there's exceptions to all of those things, but if they say yes to all of those things, then it's essential tremor, and I'm happy to see them, and we can discuss the various treatment options. If somebody says, well, actually it's a resting tremor, and my voice has changed, and my handwriting's really small and moving slower, then, you know, that's obviously suspicious for Parkinson's disease. I see those patients too, but they would be best served by seeing a movement disorders neurologist first. And luckily, we now have, you know, a bevy of them here, 3 different movement disorders neurologists who can do the much more complex workup of those patients. The thing is, for Parkinson's patients, they're often not referred to neurosurgery because the drugs for Parkinson's have gotten so good that they're often managed medically. But for a subset of them who have good benefit but have frequent motor fluctuations and have to take the medications often, they're good candidates for deep brain stimulation, and in some cases, even the high-intensity focused ultrasound.
Thank you. And for Dr. Bander, on the neuroblade technique, how accurate is it for protecting the surrounding tissues? You're doing that.
Yeah, so similarly to what Dr. Sporer was mentioning for HIFU, we're accurately measuring the temperature throughout the brain at the same time as we're ablating the tissue using MR thermography. So it's very similar to HIFU, except for the fact that we have to use a laser that's placed inside the brain to achieve the ablation.
And so side effects are
Side effects are minimal. Again, we can see similar swelling issues immediately after the surgery, but over time we see that decrease.
But you don't have that dry run that he has.
No, but these patients already have a tumor, so it's the indication is a little bit clearer.
It's a little different
necessarily.
Right. A little different, right? Questions from the audience? Yes, sir.
Dr. Tolchin, thank you so much, team, for the presentation. And Dr. Dabus, we worked together before there was an M&I, and many here don't know that we were the first Joint Commission accredited comprehensive stroke program in Miami. And
That's
so
correct.
coming from that, I would like to lead on to, you've seen the whole picture, not that we're older. But if each one of you can talk about how important it was, or what is the difference between working solo. I remember when Dr. Sporer came on board also, and Dr. Seelman, and there wasn't this whole, even though we worked as a team, everybody always worked like a team, but the whole team approach that you now have at M&I, if you can start with stroke, how that helped us as an organization.
Yeah, no, it's a great point to make, Dr. Ribas. So basically, yeah, we're the first comprehensive strokes, JACO accredited comprehensive stroke center in Miami. We got our accreditation in 2014. We're actually the second place in Florida to get comprehensive stroke center accreditation. The first one was Mayo Clinic in Jacksonville. And you know, like well, I think I'm the oldest one here at Baptist on the presenter. I've been here for like 15 years. And, you know, throughout my whole like career here, as part of MCVI and MNI, which is really the intersection of both, you know, we really were able to create the stroke program. And of course, we started getting more organized after Dr. De Los Rios, who's the stroke director, actually came on board, and really like pushed the envelope to create a pretty well-oiled machine. I mean, I think we're all very proud of our stroke program. Our stroke program, I'm clear, I mean, I'm the president-elect of my national society. I mean, I interact with people in Washington, in here in Tallahassee for policy questions. And I can tell you our stroke program is second to none in the country. I mean, I think we're so efficient and we really provide what is the best treatment options for patients in a very quick way. And I think our results prove that. And I think, you know, it's something that we're very proud of. And, you know, it's something that we're glad to continue to grow. I mean, our stroke program continues to grow. There's a lot of people joining us. There's more stroke neurologists now doing that work. And that also create a lot of, it's very important to have this collaborative approach because the stroke is truly not a single man show. It's really, you require like a system of care that's extremely efficient and very, very well connected to make sure those patients receive the best treatment available.
What about other programs in MNI?
Well, for movement disorders, obviously, it's super important that we have a movement disorders neurologist, a whole army of nurse practitioners who are doing this intense workup and management of the patients, including inpatient evaluations of patients, and then the correct referrals to neurosurgery. And then just, you know, I don't only do this, I do general neurosurgery as well. And I can tell you that everybody on stage, we are constantly in communication. And so even if I don't have the solution, I can find that solution in one of my partners or colleagues in 2 minutes. And I don't know if that exists everywhere, but certainly there is a level of collegiality here that I haven't seen in other institutions. So it's just a very pleasant working atmosphere, but it happens to benefit our patients as well.
I couldn't agree with that more. Having been here 12 years and having been in practice for 30, these 12 years of a team approach that we have here at Baptist have been second to none. I can call up any of these gentlemen on stage at any instant and ask a question. I can call up neuroradiology and ask a question. I could call my ER colleagues and send someone quickly. We have a team approach here. And with MNI, our Neuroscience Institute, it's grown to the point where we have 42 physicians who work so well together. I don't know if it's something in the pineapple juice or what, but this is a very unique institution in so many ways. And it's the camaraderie and the level of expertise that you've seen here this morning is just beyond comparison. And I'm so thankful for it. I know that the others on the stage, my colleagues, my partners are as well. There's just nothing that I've seen that compares to it down in Southeast Florida or in the region. Thank you all.
So ladies and gentlemen, we're going to take a quick 10-minute coffee break and we'll meet back here. Thank you so much. Okay. Moving along, and if we can get those that are outside, hopefully we can get them inside. Give it 2 minutes. We are running a little bit behind. We apologize, but I think the information has been worth it, and we'll make it up along the way. So to tell you a story, before we get into what I'm supposed to say, and my team loves it when I go off topic. Baptist Health, it's easy to see this now as a system and how it's already created. But actually, Baptist Health started, as I said before, with MCVI as their first center of excellence, which now we call institutes. But the story is this: when folks were coming for cardiac and vascular care, then they started asking, do you have an orthopedics program? And so that's how Baptist then later on, through the work of Dr. Uribe, the work of Dr. Heckman, Villoch, and then all the leaders that they brought in, it made all the difference after. So our second center of excellence, which is our second institute, was actually orthopedics. And it is really pretty cool when you're watching. I'm a football fan. Miami Dolphins are not doing too well, but we're still there. But when you're watching your team, right? You're watching your team on the field taking care of those $1 million athletes. It's pretty cool. And they take, like they said before, taking care of the Miami Heat, the Florida Panthers that won the Stanley Cup, and everything from the Miami Tennis Open to the ballet. So we have an amazing team, and they were able to modify things from just being general to getting down to specifics. So with that, we're now going to begin our session, continuous session with our experts from the Baptist Health Orthopedic Institute. The moderator for this module is Dr. Charles Jordan. He's the Medical Director of Orthopedic Trauma Surgery. Dr. Jordan will be joined by Dr. I'm going to get this right, Dr. Alexander Alirov. I got it right. Orthopedic Sports Medicine Surgery, Dr. Juan Suarez, Orthopedic Hip and Knee Surgeon, Dr. Elizabeth Olette, Medical Director of Orthopedic Hand Surgery, Dr. Carrie Chapman, Medical Director of Orthopedic Foot and Ankle Surgery, and Dr. James Ross, Orthopedic Surgeon and Director of Joint Preservation Surgery at Boca Raton Regional Hospital. And with that, Dr. Jordan.
Okay, thank you, everybody. Hope everybody was able to get some coffee. I'm Charles Jordan. I'm one of the orthopedic surgeons at the Baptist Health Orthopedic Institute. My focus is on orthopedic trauma and reconstruction after post-traumatic injuries. I think that what you'll see from the speakers today is the breadth of injuries that we cover, the state of the art that we try to stay on top of, and what I call the greatest boon in being able to be part of this group, which is that, we have physicians and colleagues that every single one of us would send our friends and family to, and have, and continue to. So the first thing that we'll do is we'll start the presentations. And so I believe that Dr. Alirov is the first one, right? Are you the first one coming up? Dr. Alirov has joined us recently after having been a fellow with us with Dr. Uribe and Heckman and Villoch and the rest of the sports medicine group. We're very lucky to have him. We're very lucky to have lured him back. And so without further ado, here's Dr. Alex Alirov.
Thank you, everybody. Thank you to Baptist Health International for putting this together. I was sitting in the back learning about what our MNI partners are doing. So hopefully we can teach you a little bit about what we're doing at the Orthopedic Institute. So my topic today is going to be talking about meniscus tears and kind of the current concepts surrounding the subject. And really, there's been a paradigm shift in how we think about meniscus tears. I was on social media a couple months ago, and there was a hashtag, a trending topic, hashtag save the meniscus. So if you remember nothing else, hashtag try to save the meniscus. So I've got no disclosures relevant to this talk or any talks. So we're going to start with a little background. We'll start with a little bit of anatomy. So the menisci are these unique bundles of collagen. They sit between our femoral condyle and our tibia. And historically, we thought of them as these non-functional remnants. And we later learned, of course, they're important in both knee stability and in our force distribution. And so The medial meniscus tends to be a little more C-shaped, our lateral meniscus a little more U or O-shaped configuration. And the lateral meniscus tends to have a little more variability in its shape and its size, like we see with a discoid meniscus, and tends to be a little more mobile. So we've got multiple anatomic studies that looked at the interplay of the menisci with other structures in the knee. And so the stability of the knee is affected by many of these structures, including the root attachments, the intermeniscal ligaments, the MCL. And more recently, we've identified some important meniscofemoral and meniscotibial ligaments, which can relate as it relates to extrusion. So the orientation of our collagen fiber also is important, and how they play a critical role in the function of the meniscus. And the orientation is ideal in transferring the compressive loads of our body into these circumferential hoop stresses and distributing that load appropriately. So the meniscus tear disrupts this orientation, and they can make the menisci function poorly or completely non-functional. And so, as I mentioned, they play a huge role in load bearing and in shock absorption. So multiple studies have shown that tears or even partial meniscectomies, like we used to do a lot of back in the day, decrease the contact area and can increase stresses across our femorotibial joint by up to 235%. This can allow for increased anterior translation of the femur on the tibia and the compressive forces, which then can lead to arthritic changes in our knee. The blood supply is also critical as it relates to the meniscus. And so it's supplied by the perimeniscal capillary plexus, which originates from the capsule and the periphery of the meniscus and then goes centrally. And so this leads to this gradient of vascularity with a highly vascular peripheral zone, also known as the red zone, and a more central avascular zone, which is our white zone. And so this really affects how our tears heal. And so really have to think about that as we progress in this talk. And so the prevalence of meniscus tears is highly prevalent. So it's one of the most common things I see in my office. Up to 20% of, 10 to 20% of all orthopedic surgeries in the US involve some sort of meniscal tear. Historically, like I mentioned, they were considered functionless and they were just taken out. Of course, this led to significant degeneration. Newer biomechanical studies suggest almost always repairing a meniscus. But again, these biomechanical studies, they don't take into consideration the actual host, the patient, right? So you have to consider factors like continued pain, healing potential, or costs associated with reoperations if you have a failed repair. So we have to think about which ones to repair, and we have to consider healing potential, which can include multiple factors. So one of them being the location of the tear, along with its vascularity, the tear pattern, the chronicity, and the mechanism of the tear, whether it's a degenerative or traumatic type tear. One of the other things that's important is think about whether it's an isolated meniscus tear or there's some other ligamentous injury, right? So we've learned that meniscus tears heal significantly better when there's a repair, when it's done in association with a ligamentous reconstruction like an ACL. And so how can we use that to improve our current healing? Of course, there's also discussions of normal mechanical alignment and whether we need to do like a adjacent HTO at the same time, tibial osteotomy. So as we consider which patients may benefit from a repair, we also got to consider which factors allow for improved healing. And the first one we have to talk about is improving biology. And so, as I mentioned, we looked at those studies that showed meniscal healing is significantly higher in those patients who have ACL or PCL reconstruction done at the same time. And in some studies, that was about a 90% healing rate compared to only 50% when they're isolated. And so we theorized that this was due to the release of multiple growth factors and pluripotent cells when drilling those tunnels. So if you can see in this picture here, that big giant tunnel that we drill, imagine all the marrow elements coming out of it, which can help our meniscus healing. And so how do we get a similar biologic environment when we're dealing with an isolated meniscus tear? And so one way is to do what's known as mechanical abrasion, right? We use a rasp or a shaver. We go in between. This is like a horizontal type tear with a leaflet on the top and the bottom. And we can abrade the periphery, which is, as I mentioned, is where we have all of our blood vessels, to get a little bit of bleeding in those growth factors coming out of our blood vessels inside the tear. Some studies demonstrated that even just trephination, using a needle to poke holes in that area, can increase our results by 90% good to excellent results. marrow venting or notchplasty. So replicating what we do with an ACL, we use these awls to poke holes in the non-weight-bearing intra-articular notch, replicating what's done with ACL reconstruction, getting that marrow elements coming out. And so studies have shown that results can be equivalent to what we see with concurrent ACL reconstructions. Platelet-rich plasma, so of course one of the hot topics in orthopedics. We try to use it for everything we can. The data isn't as clear for this one. There's some studies that do show that there's a improvement in pain and function outcomes at 1 year, but when we actually look at the MRI studies or the second look arthroscopies, healing rates appear to be the same. All right, so the next thing we have to consider after biology is improving our techniques. And so one of the first things I learned was the ABCs, right? And so in meniscus repair, that stands for anatomic reduction, biologic augmentation, and circumferential compression of your repairs. And so this philosophy kind of gives you the best chance of success, but how do we actually apply that? And so as we transitioned from an open to an arthroscopic repair technique, we started to have to figure out how do we best repair these menisci. The gold standard became the inside-out repair, where we passed needles through from the inside the knee out, and we tied it on the outside of the capsule. And then we started to develop outside-in techniques, all-inside techniques, transtibial repair techniques, and then using a hybrid or a combination of all of the above. And so newer studies show that when done correctly, there's no difference between using the new all-inside second-generation techniques compared to the inside-out, which is, again, our gold standard. So here's an example of what an inside-out technique would look like. So that's a sagittal MRI showing the bucket handle type tear with, you can see a double meniscus kind of in the back of the knee there. In that coronal image, you see, again, a little piece of meniscus or a big piece of meniscus stuck in the center of the notch. So this is the intra-articular arthroscopy. And again, you see that big flap of meniscus sitting right in the notch. And when we go to the medial compartment, you can see the entire plateau with the meniscus being in the notch. And so as we reduce the meniscus, you pass needles through these metal cannulas and you tie them through a separate incision on the outside of the knee. Now, this technique, again, although the gold standard, has some negatives. One, you have to make separate incisions. Two, you need multiple hands, right? Somebody has to throw the needle, somebody has to catch the needles, and there's always the risk of needle sticks with that. So we started to develop other techniques. And so outside-in techniques are also really great, but they really only work for our anterior horn or body tears, where we pass needles from the outside through the skin. And then we pass the suture through the needle, and again, it's tied through a separate incision. But again, the negatives being it's only can be utilized on the anterior horn of the body and has to be a separate incision has to be made. So we've started to develop these all inside. Multiple companies have them now, but there's been multiple iterations where the first iteration we used these darts or these tacks and they failed terribly. And so we've mostly abandoned those. But now these newer implants utilize a device that will pass these anchors, whether they're PEEK or newer ones that are all suture, to across the tear into the back of the knee or the back of the capsule. And then they anchor it, and they have a self-tensioning type device. There's other ones that, like this one, for example, is a knotless type mechanism, and it self-tensions, but there's other ones that you can tie knots with as well. The benefit being I don't have to make a separate incision. I can pretty much do it by myself without any additional help. So we're going to talk about how these different techniques can be utilized in different tear patterns. So vertical tear patterns generally have a very high healing potential. They're very generally often peripheral and vascular and can often heal very well. But we can oftentimes miss these, and these can progress to a big bucket handle tear like I showed earlier. And also they've been shown in people who where we've missed these vertical tears, and we've had to do, for example, an ACL reconstruction, they've had higher failure rates of our ligamentous reconstruction in those patients, which really shows the importance of the meniscus to the stability of our overall knee and not just what we thought about as in terms of shock absorption. And so again, historically, these were treated very well with an inside-out type repair, like you can see there in panel A. So we would pass the needles and we would tie it over the back of the capsule. But what you can see here in panel B, now we can have the same type of construct using these all inside type techniques. Now, what's important, again, the first thing remember I mentioned is the ABCs, the anatomic reduction. You know, in panel B, it looks great, but you can see there's a little gap on the bottom. And so it's really important that you have to do a separate, put a separate anchor on the bottom of it to really close that gap down where you're recreating what you see in panel A. Panel C there shows another type of all inside type repair, but in this case, we would tie a knot on the top of our meniscus again to close that down. And so this is what I mentioned earlier, one of those new implants that uses all suture, so there's no plastic or that peak that I mentioned, potentially if it fails, floating around in the knee. It's all suture, which is much softer to the cartilage. Horizontal tears, you know, they're slightly more complicated because they pass from our avascular to our vascular zone. And historically, what we would do is we would just take out one bottom leaflet or the top leaflet, whichever one was smaller, and we would say that's good enough. But what we've learned in multiple biomechanical studies is that just taking out one leaflet increases our contact forces by up to 60%, which, again, in biomechanical studies, is essentially like you're taking out the entire leaflet, or both leaflets. And so we've started to look at how repair can bring down those contact forces. And again, in biomechanical studies, you can bring it back down almost to normal. Now, what's important in these types of repairs is again, the host. So these are often seen in degenerative type tears in the older population. And so again, we have to figure out ways, potentially with biological augmentation, to really get these to heal. And so one of the important things to consider is really getting good compression across your repair site so you don't get any synovium leaking in and causing failure of your repair. So again, I showed this picture earlier, but it really highlights this. So that horizontal tear on the left, you get really good circumferential, what we call these hay bale stitches around the entire meniscus, compressing across your repair site. And so again, either using that abrasion of the back of the knee or fiber and clot would be really good in this case to augment our repair. And so again, this is one of the new type of devices that have been developed where you can tie these hay bale type stitches in an all inside type repair without having to come back out of the knee or without having to make a separate incision. So again, as I mentioned, these have historically had believed to have poor healing rates, but newer studies really show that these healing rates can approach 80%, which is much, much higher than we originally thought. Now, of course, younger patients, acute type tears still do better than the older degenerative type tears. But again, our repairs are healing at a higher rate than we thought before. So you really need good compression across the tear site. And really, this is one time you really want to consider that biologic augmentation. Radial tears are also, again, very common, and they also involve both the vascular and avascular zone. And these were historically fixed with inside-out sutures, which are tied on the outside, as I mentioned earlier. But that creates a horizontal mattress type configuration, which, again, biomechanical studies have looked at, and that's inferior to a vertical mattress type configuration, which we can get with these all-inside, side-to-side type repairs. And so the biomechanical studies show lower displacement, higher load to failure, and greater stiffness when you use these all-inside type devices. So hopefully this video works. There you go. So this is just a quick video looking at one of these radial tears. And again, just to orient you, femur on top, tibia on the bottom. This is the lateral meniscus. You can see the popliteus in the back, and you can see this big oblique type tear going across our entire posterior horn of the meniscus. And so first thing you got to do is see how mobile it is and really figure out where the anatomic reduction is going to fit. And so in this case, we're using that similar type of all inside type repair where we pass, they would pass the suture on one leaflet. And again, not having to come out of the knee to reload this device saves time. It saves you potential damage to the cartilage as you're doing it. And then again, doing it on the other side, and then we tie it over the top. So again, this is your complete, one type of complete reconstruction. Again, utilizing those vertical mattresses, which are known to be much, much stronger. In this case, the authors actually did a second look, which we'll see in a second. So with a vision needle scope, now the quality isn't as good on those vision needle scopes, but it's essentially a camera at the end of a needle. But you can see 8 months later, you have a healed meniscus repair. A lot of people ask what happens to the knots, what happens to the sutures. Usually they just synovialize over and they don't cause any issues to the cartilage. So root tears, again, this is a really, really important topic, something we've neglected for a long time and have really been recognized as more and more important over the last decade. They were first described in 1991, and they're a complete radial tear within 1 centimeter of the attachment, or a bony or soft tissue avulsion. And often these were missed, but we noted that failure to recognize them led to really, really rapid deterioration of the knee. And biomechanical studies show that this is essentially equivalent to taking out the entire meniscectomy. And so we often saw this entity we called SONC, right? Spontaneous osteonecrosis of the knee. When we looked back at a lot of those cases, approximately 80% of those cases, we missed a posterior root tear. And that's what led to these spontaneous AVN of the knee. And so in other studies, it was shown that non-operative treatment of these tears led to total knee arthroplasty in up to 30% of the patients. So this is a depiction of what the contact pressures look like in a knee, again, in a biomechanical study in a normal meniscus compared to what it is in the middle section, which is a total meniscectomy, versus the right panel, which is a root tear. And you can see those really high blue ones where you have really, really high contact forces, which look very similar between the total meniscectomy and a root tear. So what do we see on MRI? So again, this is a coronal image here, and you can see that complete radial tear right at the root attachment. Here in the central picture, it's what we call, just to orient you again, to the left would be the front of the knee, this would be the back here. So you can see a normal anterior horn of the meniscus, but in the back you got nothing. So we call that the ghost sign. So there's completely nothing there. And then one of the other entities that we've been seeing and recognizing more of, which I'll talk about in a bit, is this extrusion, right? And so which one comes first? Does the knee extrude that leads to the root tear, or does you get the root tear that leads to the extrusion? And do we really need to do anything about this extrusion or not? So this is what it looks like in an arthroscopic picture. So you have the complete radial tear right at its posterior attachment. And this is how we fix it. So we drill a transtibial tunnel, which again gives you that really good marrow elements to heal everything. We put some sutures through the end of it, and we dock it down into the tunnel. This just shows you what the guide looks like to drill that tunnel. And this is what just a depiction of the final construct. We either tie it over a button on the front of the knee or dock it into an anchor. Again, another quick video just showing this root tear. In this case, they've already drilled the tunnel and they've passed their suture. But you can see again, that root tear goes all the way to the back. And even though the rest of the meniscus looks completely normal, that's why you really got to check for these, because they're oftentimes very, very hidden. And so they pass these luggage tag, like when you at the airport, you put your name tag on your luggage tag type sutures through the base of the meniscus. Usually we do 2, sometimes 3, with this suture passing device, and then it's brought down and docked into the knee, which we'll show you in a second here. So again, here he's tightening down that luggage tag stitch. He's pulling down the suture coming out of the front of the tibia, and you can see how well it really, really reduces really nicely right there. I want to show you, he's going to come out of the knee, he's going to tie that anterior, tie it on the front of the anterior tibia, and then when he comes back in, a couple things I want you to see here. So here he's coming back into the knee. First, you see all that blood and marrow elements covering our repair site, which is, again, that biological augmentation you really get with this type of transtibial repair. And we're thinking about using these transtibial repairs in other type of meniscus tears because we really like that marrow venting. But again, you can see how stable that meniscus is now. So what are the outcomes with these root type repairs? So they're very promising and generally highly support surgical intervention. One study looking at 91 patients only had 1 conversion to total knee at 7 years. Meta-analysis comparing repair to meniscectomy to non-operative treatment in these root type tears looking at 10 years, 53% of repair patients had progression of their osteoarthritis at 10 years compared to 99.3% in meniscectomy and 95.1% in non-operative treatment. And then looking at conversion to total knees at 10 years, it was 33% in the repair group compared to 51 and 45 in the meniscectomy and the non-operative treatment. And so in this study, they said not only is it clinically superior, but economically more superior. You're going to save money in the long run without having to treat this worsening arthritis and potentially convert to total knees. So the last topic, and I mentioned this briefly before, is meniscal extrusion. And this is something that's kind of, we're looking at new developing in the literature right now. And, it's displacement of our meniscus outside of the margins of the plateau. And again, it's often seen in conjunction with our root tears, but we're not really sure. It's not always seen together. And so we're not really sure, does one lead to the other? Which one comes first? But we do know it's caused by tearing of our meniscotibial ligaments and leads to progression of arthritis. And so this brought about the idea of centralization, where we bring that meniscus back into the compartment, whether you do it in conjunction with a root repair or independently. And so this is just, again, this is new, so I don't really have any arthroscopic pictures to show you, but this is kind of what the idea is. You can dock, this is one method, you dock an anchor right at the proximal tibia, and you repair through an incision that meniscotibial ligament, pushing that meniscus back in the knee. The other way is, again, doing a transtibial type technique where you put some sutures through the center of the meniscus, you pull it back in and you dock it on the anterior tibia. So in summary, meniscus repair leads to improved biomechanics. So whenever you can save the meniscus, it's not always possible, but utilizing, improving biology, improving our techniques, and improving our identification of the type of tears, you can get better outcomes. So thank you very much.
That was a great job. Thank you. So now going onwards in the journey of the patient after we've tried to save their meniscus is a man who's made an entire career out of trying not to save menisci. He's a total joint replacement, adult reconstruction, hip and knee specialist, and my family's total knee surgeon, Dr. Juan Carlos Suarez.
So good morning. That looked like very difficult surgery to do. So I do a little bit simpler surgery. So my job is to replace hip and knees. And I know this is kind of a niche topic, so hopefully I don't bore you too much. So I'm going to try to keep it as simple as possible. So my task today is talk about using robotic surgery to do difficult knees and revision knees. Where do I point? Okay, so these are my disclosures. They're really not relevant to this one. So if you look at the American Joint Replacement Registry, you can see a big spike in the use of technology to do total knee replacement. This doesn't distinguish between navigation or robotics, but you can see that in the United States, it's approaching 15% of all the knees that are done are being used with are being put in with some kind of technology. And if you look at the knee that's most commonly used is the Stryker triathlon knee. And there's no coincidence that the most used robotic system in the country is the Mako system because it's attached or married to that implant. So you can infer from this information that the Mako system, at least in the United States, is gaining a lot of traction. So the Mako is a CT-based system. So the patient needs to get a CT scan before the operation. And the advantages of it in the primary setting is, when the patient has previous hardware, you can avoid the hardware and it can actually help you remove hardware. It gives you real-time information in surgery in terms of soft tissue alignment, soft tissue laxity, alignment, and that kind of stuff. And then you can manipulate your implant position accordingly to kind of get to where you want to land. And then the robot executes it pretty accurately. So basically, you can personalize the operation. In the beginning, there was a lot of reluctance to, is it worth spending the money in these devices, and do they make patients do better? And the reality in the beginning, there was not a lot of literature that would support it, but now there's a lot of literature supporting that potentially with these kind of technology, you can get better pain scores, reduce the length of stay, improve implant positioning, and potentially get better functional outcomes at a year. So there's more of this data coming out now. In terms of revision, so let me backtrack a little bit. So the way we do it, the patient gets a CT scan, and then in surgery, what we do is we register the femur and the tibia. So we get 40 points on the femur, and what you're trying to do is tell the system, hey, this is where the knee is, so that it can marry the CT scan to the surgical field. So you get 40 points on the femur, you get 40 points on the tibia. I don't know if I think they uploaded the wrong talk, the non-revised talk, but I guess I can continue here. But that's not the last talk that I revised. So once you register the femur, then you register the tibia, and you have a pre-made plan. And then once you have that pre-made plan, then you do soft tissue balancing. And you can see, if you look at the video on the screen over there, we're tensing the flexion gap, and it's giving us information in terms of laxity. And by doing that, then you can adjust the implant positioning to satisfy what you think it's a balanced knee. Yeah, there was a bunch of slides that are not here. So what about using this technology for robotics and complex surgery? So it's off-label for revisions. So the company, the company won't support it, but you can do it and get around it. And there's a lot of benefit from it. Number one, removing hardware, getting around hardware, also getting the information in terms of laxity and the anatomy so that you can recreate the knee as it is intended to be recreated. So let me show you just a couple of examples. This is a patient that had a proximal tibial osteotomy and varus, which is something that you really shouldn't be doing, but it was done. So there's two difficulties here, the deformity and the pre-existing hardware. So traditionally, you would try to make a cut that's perpendicular to the anatomic axis, but if you can see on the medial side, you would have a lot of bony defect, and also there's hardware that would be in the middle. But with this system, you can change the angles or adjust the angles of both the femur and the tibia to accommodate for these malformations or deformities. And in this case, if you look at your bottom left, we're cutting the tibia in 4 degrees of varus, then we're cutting the femur in 8 and 4 degrees of valgus to accommodate for that. And then you can balance the knee properly, and then you can see how in this case, we did not have to do a corrective osteotomy, and we selectively remove some of the pre-existing hardware. So again, it allows you to adjust the bony cuts, and then it allows you also to remove hardware and minimize the exposure to remove that hardware. Then there's another case like this. You can see the patient has a pre-existing nail in the femur, and the nail is pretty distal. And anybody that has done this kind of operations knows that taking this hardware is probably the hardest part of this whole operation. But with this, you can actually start adjusting the positioning of the implant to try to avoid removing the implant, right? The nail. So in this case, we distalize the femur as much as possible, and we were able to accommodate the femur without having to remove that nail, which would be very morbid if we would try to do that. Then there's cases like this. This guy also has a proximal tibia deformity from prior osteotomies. He also has a long stem on the femur from a prior surgery of the hip. So there's a lot of variables here that trying to do this with manual instruments is very difficult. You can see this is what he has on the hip side. So in this case, we can accommodate the femur and also the tibia adjusted accordingly to manage that proximal femur deformity and avoid using standard instrumentation. And then you can see how you can, get the implants right where you want it without too much morbidity. This is another example. This is a failed partial knee replacement. If you look at your right-hand side, you can see that the tibial component collapsed, and there's a big femur defect there. When you can register the metal, obviously when you get CT scans, there's a lot of metal scatter, but you can still do the registration and pass the registration as long as you're careful, and sometimes it takes a couple of times, but you can pass it. And then once in the planning phase, you can see that if you look at your right-hand side on the bottom, if you put the implant kind of in the standard position, you still have a huge bone defect there. But with the Mako, you can drop the cut to that level and accommodate a cut to put a metallic augment there. And you can see here, you have a 10 millimeter augment on the medial side, and the Mako allows you to do that pretty easily. And then you can do full revisions. It's a little bit harder because there's so much metal that passing the registration part is not that easy, but you can still do it. You register on the metal and on the bone in 3 planes. And after a couple of tries, you can probably do it. And then again, you adjust the implant positioning to accommodate for the bone loss in the planning phase of the operation. And you can do cases just like this where you have hardware in the middle and you're accommodating for bone loss. So I'm sorry that all my slides are not there. I had a lot of videos to show, but I apologize for that. But in conclusion, robotic and knee replacement is gaining a lot of traction in the United States. I think CT-based robotic systems are much more accurate than non-CT based. I think there's a potential for improved outcomes, and the revision applications appear promising, and there's a lot of us doing it off-label, but it definitely helps with these cases. So thank you so much for your attention.
Thanks for that. It's a talk that's really showing what the state of the art is in total joint replacement, which is pretty fascinating. So coming up next, I believe, is Dr. Chapman, right? Are you next? So Dr. Chapman was a former professor of mine at NYU, and somehow, even though he knew I was here, he still decided to come join us. So this is Dr. Chapman. He's the medical director of foot and ankle surgery and a close friend.
Hi, good afternoon. I guess I'm just waiting for my talk to come up. But I am the medical director for the foot and ankle service at Baptist Health. We do a lot of great things. We're on the forefront of several innovative procedures, one of which we're going to talk about now. And essentially, my talk is about a minimally invasive or less invasive way to do ankle fracture surgery. So essentially, when I was in training and pretty much up until the last few years, I'd say the gold standard for treating an ankle fracture was called open reduction internal fixation, basically using plates and screws to realign and fix the bones. And it's very reliable, it's reproducible, and I would say usually quick and easy. So when you have a procedure like that, why bother changing, you know? It's hard to change your practice patterns when your open procedures are doing fine. I'll put that in quotes. But in orthopedics and like in a lot of other fields, we're making this move to MIS or to go smaller. So you've seen that in the first talk today. They're doing in sports medicine these all inside arthroscopic meniscal repairs. They're doing that for rotator cuff, shoulder instability. You'll see that in hand surgery, endoscopic carpal tunnel releases, elbow arthroscopy, spine surgery. In the last decade or so, they've gone to these minimally invasive fusions and microdiscectomies. And finally, in foot and ankle, we kind of lagged behind a little bit, but there are percutaneous techniques to doing Achilles tendon repairs, ankle arthroscopy, and minimally invasive bunion and lesser toe deformities. And so today we're going to talk about, I should say, less invasive, not minimally invasive ankle fracture fixation. So what we're really talking about is something called a fibular nail. The advantages of using a nail as opposed to a plate is that you have these smaller incisions and you strip away less of the soft tissue. There's less vascular disruption, less swelling, and post-op discomfort. And the nail itself is a load-sharing device. So theoretically, you can have the patients walk on it faster. And when preparing the nail, you're doing something called reaming the canal, and that creates bone grafts. So maybe it lets the bone heal faster as well. So fibular nails have been around for a long time, actually. And if you look back at the history, the results are okay, not great. They tended to have lower wound complications, but there was a higher rate of the implant failing, and mainly because of this loss of, there was no fixation proximally, and the reduction would be lost. Let's see. So these more modern implants have, you can see the picture on the left, almost like a corkscrew, and on the right, there's these little talons that kind of come out. So it holds the fracture proximally. So once again, back to the history of these nails, they really had limited indication. So someone with really poor skin, a vasculopath, diabetic, elderly, someone with renal disease. But when looking at the benefits, why limit these benefits to patients who have poor soft tissue? So it's not just a cosmetic issue. I mean, honestly, if it were me, I'd rather have the incisions on the right than on the left. There are other reasons to have it, and this is once again me explaining that it's not really minimally invasive, it's less invasive. The percutaneous incisions you see on the left are maybe about 5 to 10% of the cases, and most of the cases are what you see on the right, where there's maybe a 2 to 3 centimeter incision. You look back at the literature, comparing fibrillar nails versus standard open reduction internal fixation. There's decreased rates of infection for fibrillar nails. No real differences in patient-reported outcomes in the first study. In the second study, the fibrillar nail group had had a lower rate of infection, but the patients that the fibrillar nails were used on were much older, and they had more comorbidities. There are some other comparative studies. Here's a randomized controlled study comparing fibrillar nails versus plate fixation. There's no difference in terms of the patient-reported outcomes, but significantly less wound infections in the fibrillar nail group. And when looking at the bottom line, it ended up that the fibrillar nail group ended up being less expensive, even though the implant most likely is more expensive compared to a plate. Here's some other studies, no difference in union rates, but this one showed a significant improvement in patient-reported outcomes for the nail. And once again, in terms of complications, there are significantly less complications with the nail compared to the plate. Here's some more studies showing the same thing. I'll just highlight the second one, which was done at Baptist. A colleague of mine had 100 consecutive nails with no infections or other complications. So in terms of how else can we make this a better surgery, when I was a resident, we would just fix them. We would never really look inside the ankle, even though the ankle joint was damaged. So now in many instances, we'll use arthroscopy. So we'll look inside the ankle at the beginning of the case, and this helps us identify and treat cartilage injuries, ligamentous injuries, instability, loose bodies. It can also help you confirm the quality of your reduction afterwards, and also importantly, to document what's going on inside the ankle. So you can tell the patient after, you had this bad injury inside the ankle in addition to your fracture, and that might be a reason why you're lagging behind in your recovery. So there are some studies just confirming the prevalence of these intra-articular injuries, such as on the top, the soft tissue hypertrophy, on the right, loose bodies, and then on the bottom, the chondral injury. Did I just go backwards? Yeah, I did. Here's a study comparing standard open reduction internal fixation versus open reduction internal fixation plus arthroscopy. And the patient-reported outcomes favored using arthroscopy in conjunction with fixing the ankle. And there are other studies showing that the actual fracture hematoma itself, the inflammatory factors in it, are cytotoxic. So arthroscopy actually helps you get those inflammatory factors out of the ankle joint. A little step up in technology. In the last 5 to 7 years, they've come up with these smaller arthroscopes. These were initially designed to be used in the office. So this particular one's called the nanoscope. The setup in the OR is actually, it takes up a very small amount of space. So for the For those of you who don't do any arthroscopy out there, these arthroscopy towers are really big, and when you combine that with the C-arm or the intraoperative X-ray, it just takes up so much space and makes it difficult. And this just makes it a lot easier. So the camera itself is less than 2 millimeters in diameter, and this is just a close-up of it. And this is the screen that it comes with. So once again, the footprint of being able to do this in the OR is a lot less. Here's a little video of fixing. Oh, so essentially, in addition to fixing the ankle, you can't forget about the ligaments there. So this is one where we've already fixed the main connecting ligament between the fibula and the tibia, and there's still some rotational deformity there. So we're going to use those sutures to stabilize that. There's another ligament on the medial side of the ankle called a deltoid ligament, which is often ruptured. And traditional teaching says, well, once you fix the fibula, that should be fine. And that hasn't always panned out. So these are one of these things that you can fix at the same time. And the X-ray on the right is just placing a suture anchor. And can you get this video to play? I just want to see how it plays. Click on it, or is there a way for me to do it? Nope. Oh, there we go. All right, that's the ligament. It's ruptured. So can we start this video? This is just a case, 16-year-old trampolinist. Apparently, this is actually an Olympic event. So she's jumping, and then boom, right there. So you can see on her right ankle is externally rotated, and that causes a fracture. It's not a terrible fracture, but she's a high-level trampolinist, and she wanted to get back to her sport as soon as possible. This is a little stress-free review we did in a CT scan, which shows that the syndesmosis, the connection between the fibula and tibia, really isn't totally right. So this is someone we ended up doing surgery on. And the picture on the right is a piece of cartilage that's essentially flapped off. And can we start the other video on the left? That is the shaver, and I'm pushing it in between the fibula and the tibia intra-articularly, which confirms the fact that it's a syndesmotic injury, or it's an unstable fracture. And this is the case right here. Once again, she had a relatively simple one, so we use these percutaneous clamps to hold everything together. And that's the implant right there. And in terms of indications, I mean, I think you can use this on almost every ankle fracture. And whether or not we should put a arthroscope in there and to check out the inside of the ankle, there are some doctors that think it should be done on everyone. I don't think so. I don't think a 85-year-old needs this. But for me, if it's a teenager or a young adult, or someone super active, or if they have intra-articular fragments seen on a CT scan, I think that's a reasonable patient that you would do this on. In terms of the contraindications, someone who has a really high fibular fracture, like the one on the left. So the longest nail so far that we have is 180 millimeters. So it's got to be more than that. It's got to be shorter than that. And then there are some patients that have this really skinny fibula and very narrow canal on the right. And that one, I thought I can get a nail into, and I just could not get the reamer past it. So it's probably got to be over like a 3 millimeter diameter. In terms of contraindications, there's some other contraindications, relative contraindications, such as a highly comminuted or a fracture that's broken up into a ton of pieces, or a fracture that already requires a big incision for something else. Usually when there's a fracture in the back of the ankle, I have to make a big incision so I can fix the fibula through that incision. Post-op, this is a busy slide. So the long and short of this one is that these fractures, I used to make patients be off their foot for 6 weeks for pretty much all of these fractures. So now there's definitely data showing you they can walk on it from day one. I don't like doing that because I want the skin to heal. So I'll let most of my patients start walking on this at 2 weeks. And by the time they've reached the 6-week mark, they're full weight bearing, and then we're getting them out of the boot. All right, thank you.
Thanks, man. That was a great talk. I will say that in taking care of trauma patients, there are some people in our group that take care of a lot of high-level elite athletes and very young patients, but there's also some of us who take care of the elders. And nailing fibulas has completely transformed my practice with regards to being able to manage soft tissues, especially in elderly people, in diabetic patients, in patients with a lot of comorbidities. It's completely changed the way that I take care of ankle fractures, and it's, I think, something that's going to completely take on and become the standard. So if I could have come up here on my knees to beg for forgiveness, I would have, but my knee kind of hurts. So I accidentally changed the order here, and the next talk was supposed to be by one of our senior most surgeons, who now I have to beg for forgiveness to. She's Dr. Anne Ouellette. She's the director of our hand service. She's the doctor that started and completely built our hand service, and she's really a fantastic, not only a fantastic surgeon, but she always has some incredibly interesting topics to talk about. So without further ado, Dr. Ouellette.
Not to worry. I come from a trauma experience. The universe sends incoming all the time. You have to be prepared to shift. And so I was asked to speak on 4 different topics. So I'm going to really fly through this because it's really an arc of my career. And so now with this cue thing, how do you advance the slides here? Green button. There we go. So first is biomechanics. And biomechanics, for me, was a great way to begin looking at what kind of treatments we were using. And actually, the 2 stimuli for this were Ted Hansen at University of Washington in Seattle, who really began a lot of this open reduction internal fixation because he came back to Seattle with AO techniques from Switzerland back in the 60s. But the other person was Gus Sarmiento, who also began to look at the contribution of soft tissues to fracture fixation. So these folks began me down this journey and interacting with the biomechanical engineers. And so our first thing to look at today is TFCC tears. And that was a big problem back in the 80s and early 90s because we knew that there was something more going on. And you can tell that this is a very complex set of structures here with many different attachments. And it's really, and I did a little video earlier today, much of my understanding of this and discussion of it began in Argentina because we began to go down to Argentina and participate in the orthopedic and hand conferences. I was then able to bring a number of hand people because we had our own research group that we brought down to Argentina and worked with Zeidenberg and Zancolis, et cetera. And it's out of the discussions of TFCC and instability between the ulna and the carpus. It's not just the ulna and the distal radius. It's also the ulna and the carpus. This is a bidirectional joint that I really began to work on this and came up with this model. But it's out of this collaborative experience that this begins to be a solvable problem. So the problem for the TFCC, it's a gliding surface, it's dynamic stability, both pronation and supination. So as you move back and forth, and this arc is responsible for 20% of the upper extremity function. So if you lose it, that's a 20% impairment by workman's comp. It stabilizes the ulnar side of the carpus, and it's a load transfer as well, and it cushions the ulna to the carpal bones. So there's an awful lot of functions here besides just stability. And it has an inherent instability because as you can see, it's sliding up and down in this joint space, and it's got a shallow sigmoid notch to anchor it to. And this is just an example, and I think there's a video, and I don't know quite how to play it from this, that shows you, there it goes, the supination sign. This is actually my research director, Annalena Makowski, but I have one too. So anybody that wants to feel what a TFCC tear feels like, you can come examine my wrist. And so we came up with the modified Herbert sling, and that's also, again, these collaborative things. So I became chief of hand in '92 at UM, and I started a Burkhalter lectureship, and one of my lecturers in the early years was Tim Herbert. We really wanted to talk about scaphoid fractures, but while you're sitting there over a cadaver and looking at all this, we began to discuss ways to stabilize the distal ulna. And he had come up with a way to stabilize one of his implants, but when I heard him speak after hearing the folks in Argentina from Zancoli and Capangi, who had come from France, in addition to listening to Jim Hunter talk about these things, I said, that's it. Tim Herbert has the right idea on this. And so we began to work on how do we make a model of this and how do we study it to demonstrate what it actually does? So this research for us has been going on for 30 years. And our first presentation of it was 1996, back at ASSH. So does disruption of the peripheral TFCC cause ulnar carpal instability? So we looked at 20 fresh frozen specimens with the elbow in 90 degrees and 90 degrees of pronation. And we fixed the carpus and the ulna, and then we cycled it. And we basically picked up on using the Bryan Adams method, which is really to look at the ulna to the radius. And we found that that was not good enough. We needed to make an oblique, so you can see that this is obliquely across the wrist. It is not transversely across it, because that only in that way are you going to pick up the carpal bone instability to the ulna. And this was begun with Chris D. So looking at forces, I won't spend too much time on this, but stiffness is the resistance against a maximal dorsal displacement. So you can see there's this volar translation in the neutral zone. Dorsally, you get stiffness resistance, and volarly, you get it. And the same in the neutral zone displacement range where joint motion produced the minimum resistance. So the neutral zone is inversely correlated to stiffness. And that's the key. We're looking for stiffness. So if you had stiffness, things were intact. And but post-tear, you start to lose that stiffness. And so a lower stiffness indicates less stability. And so only in the ulnar carpal joint evaluated, distal radial ulnar joint instability is well established, but it's underpowered for the neutral zone and looking at this supination sign. And so when we went and looked at repairing, doing a Herbert sling, doing just a suture repair or a suture repair plus a Herbert sling, we found that we were able to actually improve the stiffness and diminish the ulnar translation. So the percent of ulnar variance and how much it's translating, we definitely improved with the suture repair and the Herbert sling. So the two together will get you distal radial ulnar joint stability as well as ulna to carpus stability. And and we will be coming out with a paper looking at the last 10 years of Herbert sling with the fast fix anchor, which is, you saw a little bit of that inside out on the meniscal repairs. We just borrowed it for the TFCC, and they hold. They hold, and people can go back to their sports and compete at high levels. I actually have 2 records out there with that TFCC repair. One is at the arena in Philadelphia, 52 points scored in a single game by a single player, and that record still stands. And the second one is the highest scoring NHL player in that year, and that was after Herbert sling in that player. And so you can get people back to very high levels and higher than what they were before, because now they have stability, because these things are occurring over a long distance of time. Distal radius fractures, looking at that. So one of the things that we found recently, we wanted to look at fall on an outstretched hand. We wanted to look at what kinds of fractures occurred, what kind of torque was necessary. And so we looked at 8 hands with a perpendicular, 8 with radial deviated, and 8 ulnar deviated hands to see what were the difference in the fracture. And this is the initial question. We found a lot of other answers on the way. So these are some of the fractures that we created. And then we had gotten x-rays and MRIs pre and x-rays and MRIs post. In the post evaluation, we found that 25 of the 45 wrists, 56% sustained at least one carpal bone fracture. These are being missed because you don't see them on x-ray. Most of the fractured bone overall were scaphoids with 18 of the 25, but others were 11 lunate, 5 triquetral, 6 capitate, and 3 hamate, which has caused us to rename some of these injuries to ring injuries, but I'm going to go through that in a sec. So, and that's all from the biomechanical lab. So distal radius fractures can be associated with carpal fractures. They're also associated with extension of ligament tears. So looking back in the ligament literature for wrists back into the 60s, into the early 90s, Steve Villegas, 60% of people had TFCC tears. Another 40% had scapholunate interosseous ligament tears. These are all partial. They weren't debilitating, but they're present. And this is looking at cadaver specimens. So we wanted to go and look and say, okay, well, how many of these are linked with the fall on an outstretched wrist? And so we, in going back through all of these MRIs, and we had to go back through them 3 times. So every time you ask a question, you're going to find more answers that you have to ask more questions. So I just tell you, when you start engaging in research, don't get tired of asking questions because more are going to come. And one of the things that we found is that you not only got a distal radius fracture, but you can see this goes across the capitate, the hamate, back across the peripheral TFCC. And that is from somebody who had some of this. They had a peripheral TFCC pre, but then you get more post, and now you really get instability across that wrist. And that's another interesting thing. 2 pro tennis players that I have seen later in their career. One of them was in the top 10 male rated players and lost his career after falling on an outstretched wrist. Nobody could find the fractures. Everybody told him there's nothing wrong, you can go back and play, but he couldn't. And when he finally came into me, somebody said, you know, he should come see you. And when he did, I said, okay, I'm going to tell you what you have before I examine you and before we look at the MRI, because I'm pretty sure I know what happened. And then I'm going to use the exam and the MRI to prove to you what happened. It's not your fault that your career ended. And we went through his exam and the MRI, and sure enough, there was the ring injury. I'd also seen a retired player, but who had been become a teacher and a coach in tennis, and he had fallen in the 74 US Open in Houston and had a similar kind of injury, and that affected the rest of his career, and sure enough, he had a ring injury. And so these are subtle, and you don't see them on the x-ray. You're going to have to get MRIs, and even with the MRIs, even when I just recently diagnosed one in a figure skater, the folks that are following her say, we don't see it. I said, I know you don't see it. Take a look. Take a closer look. It's there. And her exam confirms it. So I will just tell you, have a broader mind about falling on an outstretched wrist. So when you're looking at epidemiology, we've now tagged Annie Weber, who's one of our new attendings down in the Keys, and she's going to be looking at things. So nerve repair. This also is another area of my interest, but difficult to follow, particularly at Jackson, where all these patients were in the drug business. Therefore, not only do they not want to follow up with you, but they didn't give you their right name or phone number. Can't tell you the number of angry fathers of young women who were yelling at us about that ne'er-do-well who we had taken care of and had given us his number. So the bottom line with nerve anatomy, you've got epineurium, intravascular epineurium, you've got endoneurium, Schwann cells, axons, perineurium. All these things play a role in nerve injuries. And so for crushing, penetrating, lacerating, stab injuries, you think of lacerations as a nice clean cut, but really there's a lot of force in that, and it transmits that energy. And severe fractures, both particularly pelvic, humeral, and knee dislocations, gunshot wounds, oncology, iatrogenic nerve injuries. So a lot of different ones. This is a gunshot wound, and this is me showing you decompressing the epineurium and the perineurium around the fascicles in order to decompress that nerve and take the pressure off it and allow the axons to reestablish their blood supply. But this can give you a loss of function, a loss of sensation, pain secondary to intraneural neuromas if you leave that pressure. And so that's another aspect of nerve injuries. Natural healing, if a nerve's transected and not repaired, you're going to get a neuroma. And a neuroma is just a tangle of axons without a bridge to grow across, and so it forms scar tissue. And they can be very painful to the patient as well as disrupting their function. So the nerve injury algorithm is you explore it. If it's contused, you cover it with soft tissue. You know, you can decompress the nerve like I just showed you in a gunshot wound. But if it's transected, you can tag it and then come back in 7 to 10 days to end-to-end repair that nerve. And again, with Jackson, we didn't have time to wait, so we went back in that 7 to 10 days and repaired nerves. You have to bridge the gap and remove permanently the injured part. And so it's always knowing how much of that nerve to remove. So 2 types of direct repair, epineurial or fascicular. Personally, I recommend epidural. The less you manipulate this nerve, the better it's going to heal. And the goal is to repair without tension. Hanno Malesi told you with brachial plexus repairs, leave a 1 to 2 millimeter gap. And that has actually been confirmed by nerve pruning. Goal is the repair without tension. Tension leads to poor outcomes. So if you put tension on this, and this is also Bjorn Radovic and Goran Lundberg demonstrating this in posterior tibial nerves. If you put those nerves on stretch, you're going to diminish the blood supply, and there is a vasovasorum. So you need to be aware of the internal environment of these nerves. At 2 weeks, a matrix with capillaries and fibroblast-like cells are going to start growing, and mononuclear cells between the nerve endings. And so that's going to start bridging the gap. And so initial injury transects a large portion of nerve, and the nerve is not repaired immediately. So you have these scarred or crushed endings, and that gives you failed primary repairs, which is one of the reasons why George Ormore told you to wait 3 months to really be able to see the neuroma. But even that is not sufficient, it turns out. So nerve conduits have really changed a lot of what we do, and it eliminates the donor site morbidity, so you don't have to take a sural nerve graft. It's off the shelf. There's no secondary surgery to harvest an autograft. And so those are lovely. You can easier match the autografts. But the key is the gap can't be greater than 2.5 centimeters. Otherwise, the nerve just penciled down and will not grow across that. And you can take nerve wraps in different situations where you've had damaged nerves and ulnar nerve release in particular, or a flap to stabilize that ulnar nerve. And you know that the muscle and the fibroblasts there lead to a lot of scarring around nerves. So the nerve wrap helps you protect that nerve. If you have a peripheral nerve injury, the axons grow at a rate of 1 millimeter per day, and the nerves need to regrow to the end organ that they stimulate. But it is not a done deal. And I do believe that we're going to find over time that those nerves growing down, you don't have to get them there in 2 years. You just have to get them there. How do we know that? Botulinum toxin. You make new nerve endings, right? You make new, and it occurs. And botulinum toxin, you have to re-inject every 3 months. So from Botox, we've learned that muscles will make their acetylcholine receptors again and again and again. You just have to get the nerve there. So even after the target is reached, the nerves will continue to regain function years after the repair. And I've had people with brachial plexus injuries that we repaired come in 10 years later and say, I just wanted to show you what I have. It's not perfect, but it's function, and they are able to use their hand. So histology of gunshot wounds and laceration. This is another area for us to be looking at. And how much of the nerve is actually permanently damaged? And that study, by the way, will get out sometime this next year as well. Nerve regeneration after gunshot wounds only has a 25% success rate. Why? We don't take enough damaged nerve out. Nerve transection after laceration gets a 40% repair, but that's also, we're not taking enough nerve out because there's an awful lot of crush injury that goes along with this. So looking at our longest specimen in our gunshot series was enough nerve taken. We took out 18 millimeters proximal to the transection and 12 millimeters distal because we could see that that was the swollen, injured area, and the biopsy's taken 7 days post-injury. And the most proximal part of the biopsy only has a few myelin ovoids in it, and the most distal degeneration is in full progress. And this is giving you a perspective on it. So when you look at the 18 millimeters from the transection, you're already seeing Wallerian degeneration. And just proximal to the transection, you can see it's all blasted apart. You can see myelin injected into the axons. And just distal to the transection, you can see there's just a bunch of scar. And 12 millimeters distal, you're seeing the Wallerian degeneration. So the axons are intact, but you're seeing everything degrade, and it's going to have to be, reconstituted. And so the problem for us is, did we take enough of the nerve, and did it come back? And unfortunately, an 18-year-old with a gunshot wound is involved in the drug trade. And in Dade County, the death rate, the age at which these people die, back in the 90s and even today, is 22 years. If you engage in the drug trade, you've already signed your death warrant. And so that's part of the problem with what we're dealing with. And you can't get the follow-up to show you what's going to happen with these people. So we also have some other interesting things going on using connective tissue membrane, liquid paste, which really has 79 growth factors, and we have found that to be tremendously helpful in helping nerves repair. Also using electrical pulse generators, but also I'm going to have to talk to Dr. Sporer about some of his ultrasound and looking at that, as well as structured water. And we're going down some other areas, and it turns out that structured water, which is phase 4 water, and it's at an Orthopedic Research Society meeting that I heard this lecture given by Gerald Pollack from the University of Washington. And you already know the 3 phases, from vapor to liquid to ice. But we keep forgetting there's this 4th phase, which is basically jello. And you can pull water and stretch it like taffy. So any of you who have watched the movie The Abyss and see that column of water that comes out and communicates with Elizabeth Mastrantonio, that's phase 4 water. And James Cameron is always ahead of himself and ahead of us. And it's very interesting. But we have begun to look at that in terms of nerves. This is what quantum computing is done through phase 4 water. And I really do believe we are 95% water, and we're going to find that a lot of this is water. If we can re-energize ourselves, we're going to find that we're going to improve nerve repairs and improve our communication. So the theory across all of this is a traumatic injury to peripheral nerve causes structural damage, and if the damages to the nerve tissue are not removed, you can't get complete healing. So we want to develop some detection methods for permanently scarred issues and how much to remove. That's also going to be in the micro CT, but also in ultrasound. What you really want is to be able to get a histologic section of the living without having to kill them to get that histologic section. And we are very close to that. We've been asking for that for 30 years, and we're truly right around the edge of getting these kinds of things. So that's going to tell you how much of that nerve is irretrievably damaged and that you have to cut that out. And that's going to help us develop new technologies and procedures, as well as remote detection and removal of scar tissue from permanently injured nerves. So they asked me to talk about skin coverage. And so skin coverage, how on earth did I get into that? Well, hand always was skin grafts. But once I learned how to allow wounds to heal secondarily, I never looked back, and I never went back to skin grafting. But there are some things that do require that. So we started using bioengineered skin graft, particularly with epidermolysis bullosa. And so young, active fibroblast and keratinocytes demonstrate persistence of cells in wounds out to about 6 weeks. And it creates a new matrix, fibronectin, vitronectin, proteoglycans, cytokines, and growth factors. So having a skin that is bioengineered and that you take out of a petri dish is amazing what it can do in your wounds. And so the operative technique in epidermolysis bullosa, these are hands that turn into scarred cocoons because every time they touch something, their skin sloughs. They don't have the pegs that hold it to the dermis. And so we started to pull these hands apart and use this skin graft to hold them. And we used Mepitel dressing in a soft bundle. So here's an example of this kind of mitten hand, and then opening it up and putting skin graft across it. And all the patients were able to regain functional use of their hands with no surgical complications. And so we were amazed at this. So doing that for about 5 years, we realized, oh, we could use this for Dupuytren's disease. And so we took it to Dupuytren's. And we started doing fasciectomies. We'd already been doing open Macache, but then we started putting the skin graft on the Dupuytren's cases in an effort to kind of break up the DNA of the scarring of them, because this is the palmar fascia that has the fibroblasts, the myofibroblasts in them that scars and pulls everything down. So we started using these to get new skin growth. And it's been pretty amazing what has happened for us. So, and I've had a number of patients that thought everybody did it this way, so they went to somebody else after they'd had this and had the typical Brunner zigzag and realized, oh my gosh, what did I just do? Come back and we redo it with this and get them far better function. So this is basically a fire break technique, stopping progression or recurrence of contractures and resurfacing the fasciectomy in a smaller area. And so that really helps. And so I've quoted a number of other people, but we also have an ongoing study with this, and that will be coming out as well, hopefully in the next year. And so this is a chance to see if you have to be so aggressive and the recurrence and continuing with fasciectomy and dermatofasciectomy. So the outcomes of Dupuytren's disease following surgical and non-surgical treatments, we really want to try and get people out so their hands function and have reduced recurrence. And that's also going to turn out to be blood supply as well. So there's a number of other things in this as well. But the theory was that using 3 modalities, i.e. a bioengineered skin coverage and looking at the recurrence rate, as well as understanding the treatments of Macash with Aplacraft versus Zeoflex versus conservative silicone sheeting, we've added one more arm to that in this past year, which is nitric oxide. That's the active ingredient in beets, increases your oxygen. And as of this last month, we've had 3 patients come back into clinic that started out with very mild Dupuytren's symptoms, but no contractures. We put them on nitric oxide, and they came back with nothing. They don't have any contracture. They don't have any beginning Dupuytren's now. So we've got a lot of arms to this study now to work on. Psychological support. When did I really start going on that? Jackson in the early 90s. And we decided to look at trauma patients, either orthopedic hand, but multiple trauma and burn patients. And we found that many times, even with just a small injury, people would just fall apart. And why? And in hand, you really need them actively involved with you on your hand therapy unit, as well as with you on rounds and rehabbing themselves. And if they're not actively engaged, you find you don't achieve what you want with hand cases. So we started to ask the question of why? Why were they disengaging and what was going on? How could we measure that? And so in looking at this, we looked at maladaptive coping strategies, which are emotional venting, denial, mental and behavioral disengagement, substance abuse, self-blame, a lot of issues going on with these patients. And so looking at the weak to moderate positive associations, we looked at 5 hypothesized coping strategies and the TSC-40 scores. I won't go into all the details of that, but the psychologists among you understand all of that. And but I'll get down to the sound bites for it. So we showed that behavioral disengagement, emotional venting, and self-blame contributed to the injury and related to distress. And these were very correlative for us. And so then with emotional venting, it temporarily reduces stress, but you can't keep doing that long term and move ahead and engage in the injury and what you have to do. And so it's basically, you constantly deflect. So I'm sure all of you have walked up to the bedside, tried to engage the patient on the rehab they need to do, and they're deflecting you into all the other problems they have. Behavioral disengagement, they just won't even face it. So it's effective in acute settings where you just have to kind of relax and meditate and let the team take care of you, but it leads to increased stress because you're not engaged in being part of the solution. Self-blame, I caused this, or better yet, they also blame others, and we all have to stop with the blame game because again, it's not going to help you move forward. So the intervention, what we came to is helping individuals shift from a maladaptive coping strategy to one of active problem solving, seeking social support, emotional regulation, helping them kind of self-meditate and calm themselves down and reframing the self-blame. And the example that I'll give you is going around on rounds with Kent Burnett, who had just moved to the University of Miami from University of Wisconsin. And he lived across the street from me. So I was like, oh my gosh, God gave me a gift. I need a psychologist. So I brought him on rounds with me with Jackson. And one of the patients that we saw was somebody who was a drug abuser, had an abscess on the back of his left hand. And that abscess was going to lead into the the muscles, the tendons, as well as the metacarpophalangeal joints. And once that starts to happen, you start to lose that finger. And we knew that without psychology intervention, we actually had a higher amputation rate than when we did have a psychologist on the service helping these patients. And we'd already done that study. So I already knew I needed a psychologist, but I needed to prove what we were doing. So with this patient, I start moving his hand because he's not engaged. He's very passive. He's angry. Angry he's got to be with us. And of course, any drug abuser and somebody living on the street is already worried that we're going to report them. That they're going to somehow get interventions from the police, which we never did. But no matter, he doesn't know that. And I start moving his hand saying, sir, you've got to move your hand. And I'm moving his hand and he comes up to punch me. And I have karate, so I batted his hand away and I keep moving his hand. And he comes up again and I bat it away and he comes up again and I bat it away and I look at him, sir, you live on the streets, no judgment on my part. Any of us could land in this spot and nobody knows when they're going to be here. But I need you to move your hand because if you're in the streets and you're trying to protect yourself with this left hand and you're leading with your PIP joints, not your MP joints, you're in trouble. Let me help you. And at that point, he just calmed down. We got the motion. Good. And then we went out in the hallway and Kent Burnett just broke out laughing, going, what on earth was that? And I said, I needed to help this man live his life. No judgment on my part. I need to protect his hand so he doesn't get an amputation. I already knew that piece of data. He didn't, and you don't, but you're going to help me figure out why I can figure out what's going on psychologically, and then how can I help him? And at that, this project was born that day. And of course, our gentleman went on to do fine. So it's learning how to help people and validating their life and what's going on. So did we ever go back once we define these? And this paper's been quoted all over the place now in trauma literature and The Hand, et cetera, as well as other places, because I did it with psychology and it was published in a psychological journal. But we need now to define what are the tools that we have to give these patients to help them. So that's our next avenue of research. And fortunately, being linked with FIU and psychology in a PsyD program, I'm hoping that's going to happen again. And so thank you very much. Here's all the intersections.
That was a fantastic talk with a lot of incredible information and stuff that we don't really hear very often, which is insightful. So one of the things that I think is missing in almost every single orthopedic practice around the country is a joint preservation specialist. It's a very sort of niche topic, but incredibly, incredibly valuable to have. And you really only find a couple of doctors here and there around the world, really around the country, in some of the biggest centers or some of the most specialized centers. And we're fortunate to have one. So I'm introducing to you Dr. James Ross.
Thank you. Okay, thank you much. Thank you very much for having me. Appreciate the opportunity to talk about this topic, which is very near and dear to me, that I have a passion for, and that's joint preservation surgery. So you heard earlier about joint replacements and how successful they can be, but how can we potentially avoid them? So I think to talk about this, it can be a very broad topic, but we'll focus on the knee. And most of the times when a patient comes into the office with knee pain, oftentimes they'll be diagnosed with arthritis, and the solution after failing non-operative treatment is a knee replacement. But what happens when a patient comes into the office with knee pain like this? So I think in order to really talk about this topic, it's important to really understand the anatomy of the knee. So I'll kind of breeze through this. So the knee has the femoral condyles, which you see above, the tibial plateau down below, and on the ends of these bones, there's articular cartilage, which is a hyaline cartilage. It's what you're born with, and it's the white shiny stuff you see on the ends of chicken bones, which is what I tell my patients. And that smooth surface on both sides of the joint allow for your knee or any joint in your body to move friction-free. When there's damage to that cartilage, that can cause pain and dysfunction. And then the other structure that's unique within the knee that can be problematic is the meniscus, which are those C-shaped fibrocartilage type structures in between the two, in between the femur and the tibia, and then finally the ligaments.
So if we have a 30-year-old patient who presents to the office with knee pain and they have normal joint space, well, what's in between those joint spaces? And that's what we talked about. So the blue would be represented by the articular cartilage of the femur, the green being the articular cartilage of the tibia, and then the pink structure being the meniscus in between. And that's why we have a joint space on X-ray, because those structures are not able to be seen on X-ray. So it's not until we are able to obtain an MRI until we can see what's going on in that space. And on the MRI image on the right, what you can see on those arrowheads is that there's loss of the articular cartilage. Pointer? No pointer. So there's a loss of the articular cartilage in that space. So if we take that patient to surgery, this is an arthroscopic image. The image on the left is a portion of the patient's femur where the articular cartilage is normal, but as we flex the patient's knee, what we can see is that there's a pothole in that cartilage, which is this patient's cartilage defect. So how can we treat this? You know, this is a very focal area. A knee replacement would be very extreme, and this patient's having pain, dysfunction, swelling. So treatment in the past consisted mostly of chondroplasty, which is essentially kind of cleaning up the borders of the cartilage that's unstable. Eventually that morphed to something called microfracture, where you can drill holes in the bone, hoping that the stem cells and growth factors that come out of the bone marrow can create a clot and eventually form some sort of a cartilage. But that cartilage is called fibrocartilage, which is not as durable as the articular cartilage that you're born with. So then fast forward, there's other things that you can do. De novo, which is a fetal type cartilage, biocartilage, which are other types of options that can produce more hyaline-like cartilage, but still is not perfect. And then finally, Oates and Carticel or ACI, those are more procedures that are trying to aim towards reestablishing real hyaline cartilage. So this is that patient's knee. So once we open up the knee, you can see where there's that focal defect on his medial femoral condyle. So how can we treat this? One option is something called Oates. Oates stands for osteochondral auto or allograft transfer system. So in this patient, because of the size, we're not able to move around native cartilage from within his knee, but rather we can use cadaver cartilage. So what we do is we actually take this patient's MRI scan and we send it off to a graft company. My preferred graft company I like to use is called Joint Restorations Foundation, which is based out of Colorado. And they take serial measurements on the patient's MRIs, looking at the condyle width, the tibial width, et cetera. And then when a patient who is a donor passes away, they harvest the patient's knee and they make respective measurements on that. And once there's a size that's within a certain percentage of a match, that knee is harvested and offered to the surgeon to proceed with a surgery. And you have a couple weeks to use it because the cartilage are living cells. So you want to get to implant that as soon as possible so that it is able to be placed back into a synovial fluid where it will continue to have its nourishment and proceed. So this is just an example of what we get. We actually get a picture of it. We get the measurements of the donor, and we decide if we want to proceed with surgery. So that's what I like. And in this patient, it's a 20-year-old male, so a nice, young, healthy cartilage. So what we do in surgery, this is that exact same patient. So we bore out a circular hole or a socket that encompasses the entire defect. We take the defect out, and then we create a recipient or a donor plug that matches that exact recipient socket and press fit it into place. And that is, again, living cells, usually 70 to 90% viability, and patients will go on with clinical success. Now, a lot of these patients have underlying mechanical reasons for why these cartilage defects have occurred. So in this patient, if we get long leg standing alignment films and we look at the weight-bearing axis from the center of their hip all the way down to the center of the ankle, what you can see is that their weight-bearing axis travels through that compartment where their cartilage defect is. And what we know from research is that if you don't change their alignment and take the weight-bearing axis out of that compartment, the longevity of that cartilage transplant is not going to be as good. So in all of these patients that have cartilage defects with weight-bearing mechanical access problems, I like to template a correction such as this, and then we can perform the tibial osteotomy and shift that patient's weight-bearing axis away from the compartment where the cartilage was transplanted. So how do these patients do? This is probably one of the best studies that's out there. This is a systematic review that encompasses 19 different studies, so over 1,000 patients. And if you look at the mean survival of these cartilage transplants, these are the allograft cartilage transplants. At 5 years, nearly 90% survival, 10 years, 80% survival, 15, 72%, and even 20 years, 67% of these patients continue to have their native knee and have not progressed to a total knee arthroplasty. So pretty good success. So what are other options that are out there? Treatment options are constantly evolving. New things are coming to the market. But in a patient such as this, where the bone is actually okay, is there anything that we can do to replace the cartilage alone? So going back to our treatment options, if we're looking towards restoration, we've already talked about the osteochondral auto and allografts, but what about autologous chondrocyte implantation? So what is that? So autologous chondrocyte implantation, or ACI, was primarily started in Europe before it made its way to the United States. And what that is patient's cartilage, a patient undergoes a biopsy of their cartilage. And those cartilage cells are broken down in a lab, and they're actually cultured up in order to multiply the numbers of chondrocytes, and then they can be reimplanted into the patient at a second surgery. So the first report of ACI that was done was in 1994. The FDA approved this in 1997 and started to gain popularity. The problem is that original surgery, the first generation surgery, was very tedious because at the initial time you had to take a small thin layer of the bone called the periosteum and sew it into the cartilage and then inject the solution of the cartilage cells underneath, making sure it was watertight and not able to leak. So it was potentially a 2 to 3 hour procedure depending on how many cartilage defects were needed to be treated. But it was very successful, but many surgeons just didn't want to go down the route of taking the time and really being invested in that surgery. So fast forward to what's available today is something called the matrix autologous chondrocyte implantation, which is a lot more technically easier. So looking at this, it really involves 3 steps. First is looking arthroscopically at the defect size and obtaining that cartilage biopsy. The cartilage is then sent off to the lab where those cartilage cells or chondrocytes are multiplied and eventually seeded onto a membrane. And then the step 3, which is the second surgery, is implantation of that membrane. So this is step 1, so defect assessment and cartilage biopsy. What do we do? So during the time of the arthroscopy, we examine the defect or defects, and we measure the size of the defects, whether or not they're contained or uncontained, meaning if there's a healthy border of cartilage around it, and determine if there's any underlying bone loss or softening of the bone. Once the cartilage defects are evaluated, sized, and recorded, then we go ahead and harvest the biopsy. So this is what it looks like. So I prefer to use a small ring curette, and what I'm doing here is on the intercondylar notch, which is typically not a weight-bearing portion of the joint, we're able to harvest 2 individual tic-tac size cartilage biopsies. And it's important that we really take a very thick area of the biopsy that includes the bone, because the cartilage cells that are the ones that are able to propagate and grow up are the ones that are deep and really adherent to the bone. So that's what they like to see. So that's the process. So after we looked at the defects and obtained the biopsies, those are sent off to a lab, which is in Boston. The cartilage is transported in that solution in the upper right, in that purple or that red or pink solution. We fill out the form and the documentation, and off it goes to Vericel. So in the lab, this is what they do. So they multiply the cells, and then they create this membrane, which you see in the lower left. And this membrane is a dual-sided membrane, which is why it works so well. So what you're seeing on the lower left is the rough side facing you and the shiny side, which they're flipping over. So the smooth surface, or the dual-sided membrane, that contains dense collagen fibers that stop the cells from moving in that direction. And that's the side that's eventually going to face the joint so that the cells don't go into the joint or the joint fluid. Whereas the rough surface are where there's all the collagen fibers, where the chondrocytes are actually adhered to that. And those chondrocytes or cartilage cells are attached via these cytoplasmic projections, which you can see on the lower right. That's an electron microscopic image of those cells adherent to all the cartilage fiber, or those the collagen fibers. So fast forward to the second surgery. So this is currently an open surgery, although there's now an arthroscopic technique that's was recently released. But the defect is prepared. So we removed all of the scar cartilage or fibrocartilage and really create a nice healthy border of the patient's articular cartilage. And then we use some sort of a template such as sterile aluminum foil to create a size match. And then that foil is used as a template to cut out the appropriate sized membrane in order to fill that defect. So this is just a schematic. Once that membrane is cut to your choice, you put down fibrin glue and then eventually place the membrane into the defect, hold it with digital pressure. I like to secure the membrane with some 6-0 vicryl sutures, some really small vicryl sutures, and really just let it sit there for about 8 minutes while the fibrin glue adheres it to the underlying subchondral bone. So this is a patient example of mine. This is on the backside of the patella. You can see the upper left. That's after I've removed all of the patient's unhealthy cartilage down to the subchondral bone. And you don't want to be too aggressive and get beyond that subchondral bone, because the way I think of it is the cartilage is the house and the bone is the foundation. You got to make sure you have a really good, stable foundation in order to build a house. If you don't have a foundation, eventually the house will break down. So that's the foil template. The foil template is eventually used on the membrane to cut out the appropriate sized membrane, which you see on my glove on the middle bottom, and then after that membrane is implanted into place. So what happens? What's the science? So the patient is held immobile for 48 hours because that's the amount of time that's needed for those cells to migrate off of those collagen fibers and adhere to the subchondral bone. And once they adhere to the subchondral bone, after several months, these cells and chondrocytes are programmed to eventually synthesize all of the matrix proteins that are normally found in hyaline cartilage. And by motion between the other side of the joint, for instance, like the patella on the femoral trochlea, it keeps the chondrocytes from creating too much cartilage where it overgrows. So the match of the two sides of the joint really helps to keep it in check so that you don't get overgrowing beyond the borders of the cartilage. So how do these patients do? The best evidence that we have is within Europe, because they've been doing this the longest. The FDA kind of takes a while to adopt things, but this was a randomized control trial, the SUMMIT trial, which is really what prompted the FDA to approve the use in the US. And they had 144 patients using the MACI implant, 72 per group. And they were randomized to the MACI procedure versus the microfracture, which is the older type of procedure, just drilling in the bones. And what they looked at was at 2 years, the KOOS score, which is a clinical outcome score. They did MRIs, second look arthroscopies, and even biopsies. And this is what they found as far as the clinical outcomes. So the baselines were essentially the same between the two groups, but at 2 years, the MACI, or the autologous chondrocyte implantation, superiorly outperformed the microfracture groups in both pain and function. And then they recently extended this study out to 5 years, and it shows that they maintain these outcomes to year 5. But again, it's important to understand the environment, because without correcting any underlying predisposing factors for why these cartilage defects are happening, patients won't have good outcomes unless you address those. So again, alignment. So this is a patient example that I had that had a very large mediofemoral condyle defect that was cartilage only, didn't involve the bone. So I performed the matrix autologous chondrocyte implantation and then did a tibial osteotomy in order to realign his knee. And actually now he's 7 years out and he came back to me to do the other side. And then finally, what about the meniscus? Meniscus integrity is key. Many patients who have had prior arthroscopy and perhaps a meniscus tear where the meniscus was removed, several years later down the road, they may start developing pain again due to the cartilage loss. And unless we treat the meniscus insufficiency, any sort of cartilage treatment won't be successful. So what could we do for a patient like this who has their anterior horn of their meniscus okay in the black triangle, but then they're missing their posterior horn, which is outlined in red, and there's nothing there? Well, we can do the same thing. We can do meniscus transplants. So we can actually get a cartilage transplant or a meniscus transplant from a cadaver that's, again, size matched. What I prefer to do in these patients is I trim down the bone so you get 2 individual bone plugs, which you saw in that image, and then we create recipient sockets on the tibia. So this can be done all arthroscopically. So this is the posterior horn or root of the medial meniscus. We drill a socket that's eventually going to receive that bony plug. And then this is the anterior root attachment for the medial meniscus as well. And again, we're creating another socket so that the meniscus is going to be able to be anchored in at these root attachments and get bone-to-bone healing at its root insertion, which has much more predictable healing than soft tissue to bone. So once those sutures and sockets are placed, here you can see I'm shuttling in this meniscus graft. So that's the posterior horn of the medial meniscus with that bony socket that's being pushed back in towards the recipient. And then we just kind of pull on the sutures and it eventually docks it right into the bone. And then same thing, here's the anterior socket, anterior root, again, pulled into the bone. And then once that those sutures are tied on the tibia, you're left with this meniscus that's in between the femoral condyle and the tibia. And then it's just a matter of putting sutures all the way across the entirety of the meniscus to seal it, to secure it to the capsule, which is where hopefully you're going to be getting the patient's blood supply into the periphery of this meniscus in order to heal it in place. And again, now you're restoring the meniscus function in a patient who has still well-preserved cartilage, which if left alone without a meniscus would eventually lead to complete compartment cartilage deterioration and perhaps an eventual partial or full knee replacement. So in conclusion, joint preservation surgery in the appropriate indicated patients has very reliable outcomes for pain and function. There's a rapid evolution of techniques and treatments, and fortunately, these are being followed by well-performed investigations. So lots to come in the future. Thank you for having me.
Okay, so I want to thank all of my colleagues who have come up and given amazing talks. I want to respect your guys' lunch break. So I have a talk to give. I think that I can kind of go through it with some expedience and with some efficiency so we can be able to still have some Q&A at the end of the session. So really, the concept that I'm going to present to you is really a simple one, but one that I think is often overlooked. And like I've mentioned a little bit earlier, some of us tend to have a patient population, especially in Miami, which may skew towards what people consider elderly kind of around the country and even around the world, but we have a really active elderly population, and I think that we need to rethink the paradigm of how to treat these patients. So starting off basically with just the concept of fragility fractures, it was estimated that there's 2 million osteoporosis-related fractures in the United States alone in 2005, and without belaboring the point, it's estimated that by as early as next year, this will have grown by 50% or more. The lifetime risk of fragility fracture, for those who are not aware how high it is, it can be as high as 50% in women and 25% in men. The most common when people think of fragility fractures and osteoporosis-related fractures, people think of hip fractures. And this is really where the majority of the literature has come out over the last 30, 40 years with regards to management of hip fractures. And this is kind of where our paradigm sits and where I think it should be extended further to other fragility fractures that I think can actually result in very similar lack of mobility and poor functional outcomes if not treated appropriately. So there's upwards of 300,000 hip fractures in the United States alone. It's estimated that there's going to be 500,000 by 2040. And these, as I'm sure most people in the audience know, result in significant decline in functional capacity, mobility, and independence. So Dr. Zuckerman up at NYU published was probably the seminal article on how we used to treat hip fractures, but there was no significant papers out there that would prove what was already suspected, which is patients who break their hip do very poorly. And they published that the one-year mortality, this was back in 1995, the one-year mortality was 80% without surgery. And even with surgery, it was upwards of 20%. And in some series since then, has been shown to be 30%. The most devastating complications were, no surprise, due to prolonged recumbency: pneumonias, venous thromboembolic events, cardiovascular events, decubiti, and complications associated with muscle weakness and atrophy. So basically from there, everyone kind of decided and agreed, listen, these patients need to move, and being in bed is the worst thing that you can possibly do to somebody, to anybody, much less somebody who is elderly. And in our patient population, the worst is the active elderly, because they're so used to having a point of balance in their lives where they're moving and they're active, but one hit can ruin all of it. So essentially, this is where the paradigm started of you must try to do as close as possible to 24 to 48 hours from presentation, the operation to fix these patients. And the whole point is to restore length, alignment, and rotation, restore anatomy, reduce and compress the fracture, and hold it in a stable fashion so that they can weight bear early. And the goal for all of these patients is immediate weight bearing and immediate rehabilitation. This data has been reproduced over and over and over. Even just as an example, this paper that came out almost 30 years after the Zuckerman article, again showing that surgery within 24 to 48 hours is preferable, because delayed surgery was associated with an increased risk of 30-day mortality and other complications. Again, pulmonary embolism, myocardial infarction, pneumonia, and all of these remain significant, not just at 90 days, but at even 1 year later. So this begged the question, we do this for hip fractures. We understand that when a patient has a broken femur or a broken hip, they need to go to the operating room as quickly as possible so that we can stabilize them and get them walking. But not only are hip fractures a common fracture, but we have a whole other litany of osteoporosis related, or what we call fragility fractures, that occur all over the body. And are we ignoring these patients? Are we not being aggressive enough in our treatment of the patients in order to be able to get them up and moving? So just a couple of very, very common fractures that we see in active elderly populations here in South Florida are intra-articular distal femur fractures, proximal humerus fractures, and proximal tibia fractures. So the standard of care, I think, or the community standard, has generally been for periarticular fractures of the ones that I was just presenting, is open reduction and internal fixation with plates and screws. These are load-bearing implants. What that means is that essentially when you're bridging a fracture, the plate and the screw bears the weight of the body as you weight bear, rather than a load-sharing implant, which is an implant that actually shares the load along with the bone, which I'll discuss in a second. And so because of that, traditionally this required non-weight bearing restrictions. We would put a plate and screws, a bridge plate along a distal femur, and then tell a 75-year-old lady, don't walk on that leg, but you can hop on the other leg and use your walker and kind of jump around. There's not a patient on earth of that type that's going to be able to do that. So that results in, I think, a lot of decreased functional outcomes where I think we can do better. So why don't we extend those strategies out to all these other fractures? And rather than this slide, which shows the standard sort of treatment for these fractures, which was open reduction and internal fixation with plates and screws, maybe we can do better. The treatment for these fracture patterns was plates and screws alone, simply because in the periarticular segment or around the joint, we would be able to have many more points of fixation close to the articular surface in order to be able to reduce and compress the fractures at the articular surface, where an intramedullary nail wouldn't be able to afford us enough points of fixation. However, this is a load-bearing device, like I mentioned before, so the weight is transferred from the bone to the plate, and therefore we can't have patients walking on it because of the fact that there would be a high failure rate of this fixation before any healing would take place. And now, so intramedullary nailing is very popular, but traditionally this was reserved for metadiaphyseal or diaphyseal fractures, fractures close to the joint but not too close to the joint, because we didn't have as many points of fixation to be able to hold the joint in place as patients would walk. So a lot of these patients would be able to weight bear early, but there was a whole other set of patients that we weren't able to do this for. So in 2019, this is probably the first big paper in a big journal that came out that really pushed for the thought behind a dual fixation strategy. This combines intramedullary nailing with locked bridge plating in one procedure, and you can take advantage of both plating and nailing. Improve fixation of the intra-articular fracture with increased points of fixation, but also taking advantage of the intramedullary fixation with stability and load sharing to be able to weight bear the person early. So Liparachi and Yoon basically concluded that combining intramedullary nailing and bridge plating can improve the stability of fixation, allowing for a more aggressive mobilization postoperatively. So for example, this is a 65-year-old male. He's a community ambulator. He's an active, healthy person who can very easily become a very inactive or a very sedentary person because of a major injury. He's got a distal femur fracture with significant metaphyseal comminution, intra-articular extension, and comminution. There's a little bit of a hiccup there in which he had a prior femoral shaft fracture in the past, but that was something that we were able to deal with in the operating room. In this sort of a situation, intramedullary nailing alone would have provided insufficient fixation because of the intra-articular comminution, the amount of fracture, let's say, at the articular surface. There's not enough fixation with an intramedullary nail alone. And then with a plate, if we were to use a plate, we'd be able to reconstruct the entire joint and then restore length, alignment, and rotation, but they can't start weight bearing early. So in this sort of a situation, the technique really involves using an extramedullary fixation, using a plate and screws in a submuscular fashion with a small incision close to the joint, placing the plate along the bone, underneath the muscle, above the periosteum, and temporarily fixing the bone with length, alignment, and rotation restored before inserting an intramedullary nail. Once the intramedullary nail is inserted and there's final fixation, you go back to the plate and finish the fixation proximal and distal to the fracture. So this is a combined nail plate technique. There's improved fixation over intramedullary nailing alone, but improved stability over plating alone. And this patient would start immediately weight bearing from day one and presumably had a much improved outcome compared to either technique by themselves. Here's another example, similar sort of situation. She's a 76-year-old female. She's a community ambulator, but uses a walker. She has severe osteoporosis. She's had prior fragility fractures in the past that have needed to be fixed surgically. And I think relegating this patient to a plate and screws and telling the patient, go ahead and walk on your other leg or don't walk at all is going to result in a very, very poor outcome. So again, submuscular plating after restoration of length, alignment, and rotation in order to be able to include intramedullary fixation and then go back and finish the fixation on the plate. There are technical challenges with dual fixation, most commonly because of the fact that you're using two different fixation techniques. So you have to be careful not to, for example, use too many screws on the plate in order to create too much of a stiff construct, because that could result in non-union. Additionally, being able to plan for the placement of your implants after placing one implant in order to be able to insert the second implant and back and forth. So the last thing that I'll mention as we move it along pretty quickly is reverse shoulder replacement. Now, one of the other things that we really need to think about is not just in the lower extremity. The reverse shoulder replacement is not new, but has become a much more modern implant as of late and is used much more in the treatment of fractures because after the initial Grammont designs where there was a 155-degree neck shaft angle and the use of medialization of the center of rotation in order to create a more effective lever arm of the deltoid, there was noted to be significant complications, including notching of the scapula and problems with tuberosity healing, problems with acromial stress fractures because of the increased tension, because having a 155-degree neck shaft angle would cause an overall lengthening of the construct. So in the about 10 years ago or so, papers were coming out showing a redesigned reverse shoulder replacement where we would take that entire medialized construct and have a medialized center of rotation, but lateralizing all of it together, right? So the relationships would all stay the same, but they were all lateralized in order to be able to have a more anatomic neck shaft angle. And that changed, I think, in my opinion, the entire concept of how to place these implants and how to be able to treat patients with things like fractures where there are significant other challenges like significant amounts of bone loss and significant tuberosity fractures, glenoid fractures, and more. So because we have much more stable implants with less complications, they became much more in vogue to be able to treat fractures with them. And as a result, there is no lack of data, no lack of papers that have been published showing that it is not only a viable treatment, reverse shoulder replacement for 3- and 4-part fractures, but in fact, actually probably a preferred treatment in many cases. In my practice, essentially with very, very few exceptions, it's completely replaced hemiarthroplasty. And the most important thing about this slide is the bottom. I use reverse shoulder replacement to treat fractures in patients who depend on their arm for mobilization. So for example, this is a patient which just looking at an x-ray is not enough. She's a 79-year-old female, but she's a household ambulator with a walker. She's able to help herself get out of a chair, walk to the bathroom, move. This is not a patient that needs to be hoisted by her family from bed to a chair, which is a very, very different patient. It's a patient that you want to preserve that mobility because the second that mobility goes away, not only is it a burden to the patient, it's a burden to the family, and it results in rapid deterioration of the patient. By x-ray alone or even by these CT cuts, you would think, this could be a fracture that could be treated non-operatively, right? You could treat a patient like this, let's say they're in their 50s non-surgically, and they'd probably do quite well. You may even think, you know, some limited internal fixation with a plate and screws in order to reduce the greater tuberosity to avoid impingement. But this isn't that kind of patient. This is a patient who needs to be treated practically like a hip fracture, in the sense that she's not going to move if she's not able to use her arms to be able to get herself out of a chair, get herself up on a walker, pull herself up and out of bed. And so I would challenge those who really use reverse shoulder replacement but haven't tried yet, use the technique of a well-seated press-fit reverse shoulder replacement with good tuberosity fixation, and do not limit the patient's mobility at all. Weight bearing is tolerated, immediate mobilization, use of their arm for all transfers, walker use, and anything else that they want to do, and they actually do great. So I know I went through it really quickly and I was talking real fast, but we're going to have a Q&A session. I really wanted to preserve that and then still be able to send you guys out for lunch. So I think this is something that needs to be thought of in a more holistic way for the entire body, not just hip fractures and not just femur fractures. And I think Liberace and Yoon, in that same paper that I quoted earlier, said it best when they said, with the early population staying healthier and more active and living longer, the low energy fragility fracture is increasing in incidence. With morbidity and mortality similar to that of the hip fracture population, the goals in operative treatment require urgent operative fixation to allow for early mobilization. And that's everything. Thank you. And with that, I'll invite anyone who's here who gave talks to come up and do some panel discussion and some Q&A. Okay, so thanks very much for your talks, guys. That was pretty fascinating, actually. Does anybody have any questions? Rather than doing any discussion, we should just get right to questions. And also, if there's any questions based on any of the other talks, we'd be happy to try to answer them for you or even get the information for you. One thing I didn't mention is I really like these sorts of symposia because I think that they really provide an opportunity to build bridges and continue communication. I hope that you guys have all of our contact information, and one thing I think that we all love to do is discuss cases and talk about technologies and resources that are available. And so I personally would always be happy to do that. Yes, sir.
Okay, so my question is for you, sir. Regarding vitamin D serum levels in elderly patients, does supplementing vitamin D and K2 reduce fragility fractures?
So there's a lot more that goes into the reduction of fragility fractures than vitamin D alone, but vitamin D is a very, very big part of the equation. It's a whole other talk to give to you guys, which I would love to do at some point, regarding the treatment of fragility fractures, the medical workup and treatment, which we do here actually at our osteoporosis, our bone health and osteoporosis clinic. One thing is being able to measure and be able to follow a patient's bone density over time. And in patients who have fragility fractures or who have evidence of prior fracture or who are at high risk, we actually get them annually rather than every 2 years, which is the standard for screening. But vitamin D is probably the most studied of all of the other elements, such as zinc, magnesium, NTX levels, and every other thing under the sun that we check. For the most part, what I began to notice when I first started my practice in Miami is that paradoxically, everyone has the sun accessible to them 350 days a year, and yet almost everybody that I checked was low in vitamin D. I definitely think that that's one of the big components. We supplement practically everybody who comes in with a fragility fracture, even before beginning a formal workup and treatment algorithm. So I think your point is very well taken in that we basically supplement vitamin D in almost everybody who has a fragility fracture from the get-go. Yeah, so I mean, it's I think that our lab says normal is like 30 to 90, but we try to keep it on absolute highest level possible. There are multiple papers out there over several decades that have shown that hypervitaminosis D may or may not even exist. And if it does, there don't really seem to be any known complications until you start getting into the many thousands, right? So I pretty much put everybody on 50,000 units of vitamin D weekly for the first 6 weeks or so, and then either 1,000 or 1,500 daily for the foreseeable future until they stop seeing me, and then God knows what they do. Any other questions? Anyone else have anything, or are the stomachs rumbling way too much? Yes, sir.
My team said I project well.
They're talking about your beautiful face.
Yeah.
It projects very
Or
well.
maybe I've grown. So I think the most difficult part, and anybody that's non-ortho, trying to get a patient over here and dealing with trying to get a patient over to us, what are in each one of your sides, what would be the minimum that you would need in order to try to evaluate a case and be able to look at it? Obviously, we're using Ambra Health. We used to be DICOM Grid, so if anybody is using Ambra Health too, that works with us. We share imaging. Everything has changed since I started in 2011, and we all have more gray hairs than before.
Yeah, we do.
But what would something you would like to see that makes your life easier? I mean, sometimes as a medical director, Dr. Hakim and I sometimes have to go to our doctors and say, this is what we have. This is all I can share. And then they try to do the best they can. But sometimes the more information, the better it is. So can you share with us, each one of you, what would you like to do before a patient comes here? Or sometimes we have patients that say, I want it all done here. So
Yeah, I was about to say that it's definitely going to be different, everyone that you ask in our group, because what we do is different and what we're trying to look forward to treat is different. For me, it tends to be pretty easy. I mean, just basic plain x-rays can tell a large portion of the story in a lot of situations. Basically, any fractures or any post-traumatic malalignment, post-traumatic deformity, post-traumatic non-unions and infections, a lot of a large percentage of what I need to know is happening can be seen on plain x-rays. A lot of times for me, when I'm getting advanced imaging, it's more confirmatory in nature, or for more preoperative planning sort of stuff, or maybe even more esoteric things that nobody else would be looking at other than the one who's going to be doing the treatment. You know, it's always a challenge to be able to share information, unfortunately, which seems crazy to say in, almost 2025, when people are sharing, everything from, emails and pictures on social media to like cryptocurrency, right? I mean, everyone can share a Bitcoin, but we can't share some x-rays and an MRI. But I think that that for me, it's really just almost even just a set of plain x-rays would be great.
I think, in sports medicine, we order a lot of MRIs.
He's very different.
Yeah, we order a lot of advanced imaging, but I mean, I try to make it as easy as possible. I order very specific weight-bearing x-rays for my knees or hips, so I just need a motivated patient. That's really about it, because I'll do my own x-ray imaging and then do my exam to really guide if advanced imaging is necessary. But there's really not much, what I tell most of the people in the community, primary care physicians, is just like, send it to me, let me kind of send it to Dr. Jordan or Dr. Ouellette, because I know where this patient really is going to get the best benefit. But a motivated patient is really all I'm looking for.
Also, I think one of the things that we need is communication of expectations, because I very frequently, what I'll need is a patient who has the flexibility to be able to stay to do certain things and certain studies that I may need based on what I see once I see them, right, and once I examine them. So I kind of need a patient that is willing to be able to stay for whatever duration of time that imaging or whatever studies may need to take. And then also a patient who is willing to accept the fact that this may be something that needs a workup, needs the studies done. And then even if we determine then and there that surgery is the best option, there's going to be a certain level of planning that needs to be done for some of these things. I mean, they need to be patient matched a lot of times, measured. We need to be able to bring in graphs, bring in 3D printed. I mean, I could do an entire talk on the 3D printed cutting blocks that we use for total knee replacement. And for shoulder replacement. So this may be something that you got to be able to come in to be able to have a certain amount of workup done, and then you might need to go and then come back, or unless they want to stay the whole time. But I think there's just certain expectations of how the process works that might need to be communicated as well as possible.
Dr. Ouellette?
For me, it ends up being the imaging and the MRIs coming from all of Latin America and the Caribbean, for the most part, are adequate. For what we have, so I can evaluate those things. Nerve conductions are also very good across the board, so that if I get that information ahead of time, I can then make an assessment, talking to the patient by telemedicine, what other things are we going to wish to have? Do we want a repeat nerve test with an ultrasound et cetera, whatever that's going to be. And so that the beauty for me would be to be able to set that up so the patient arrives, gets all those tests, then sees me, then we put the whole story together to figure out if there's anything else more that we need, because I really try and minimize them having to travel back and forth to their country. And we've done this particularly with Europe as well. Very good studies coming out of Europe, so no problem in evaluating those people and then putting the story together for them.
Great point.
Rehab component's so huge in everything you all do. Can we talk a little bit about how rehab has changed to what it was before and to what's going on now and everything your team does?
What do you guys think? Yeah, I think we're going to much faster rehab protocols, along with weight bearing is tolerated. For me, a lot of times, in the past, ACLs were put in casts for weeks and weeks. Now, we get them moving right away. We get them walking, post-op, in the PACU. So the therapists see our patients in the PACU. They give them exercise to do at home. The first post-op visit where we take out their stitches, we start them on a rehab protocol, and every patient gets, what the outlook is going to be for the next 6-8 months. So they know really what to expect and what goals they really need to meet. So, the patients can see themselves progressing. And I think there has been, every year we get closer, we get more and more towards outpatient or patient-centric rehabilitation and less towards inpatient long-term rehabilitation at facilities, because really that ends up, in my patient population, that ends up actually backfiring a lot of times. It ends up being very inefficient. I tell my patients, I'm going to want you to get up and walk and move. And being at a rehab facility where, yes, you may get a couple of hours of therapy as an inpatient, but all the other time you almost have too much help around. And we have to resist you not getting up to go to the bathroom, or not getting up to get your own food, and not getting up to, we have to resist the temptation of everyone around you to be doing that for you. And you have to be getting up and doing that. That's part of the therapy. That's part of the rehab. The rehab is 24 hours a day, because we don't just do therapy. We also have you must be involved in that. And I know for hand, there's no other place that is tougher to rehab and requires 24 hours a day worth of some kind of movement or strengthening than in the hand.
Well, fortunately, living in Florida, although I will tell you, Caribbeans do not like to get in the water, and Canadians you can't keep out of the water. And I use water as my way of getting your brain and your hand to be back in touch. And that's part of that psychology, but it's also part of the physiology of it. And so I started using water and getting in the pool in the late 80s, because you didn't have people that could go, come into therapy all the time. They didn't have the transportation, et cetera. So I said, do you have a pool you can get to? A friend, a family, the YMCA. LA Fitness will give you a 3-month membership at $40 a month. Most people can afford to do that, and it gets it closer to their home. And the key for me is, if you'll get in the water, I will get your brain and your hand to start working, because you'll automatically keep yourself up above the water to keep from drowning. So it's kind of a passive way, but active way of getting you to use your hands. The other problem with hand is it doesn't matter what you fix that tendon with, it still takes 3 months to heal. And you still have, so unfortunately, we're still constrained by Mother Nature and the organism itself and how things healed. We have not been able to speed it up in the way you can with bone, with a support and a strut, an internal fixation, which acts as a splint, an internal splint. We don't have that ability for everything. You do for distal radius, you do for some finger fractures and things like that, but you don't for a tendon repair, you don't for a nerve repair. These have their own timelines, and they haven't changed. There's nothing that we've found to speed it up. Now that may change with the biologics, but even then, there's only so fast you can make a cell grow. So we're still in where we were 50 years ago.
Good point.
Thank you, doctor.
All right, guys. Any other questions, comments about any of us or any of the other speakers? Yes.
This is a question for Dr. Ayarov. And for meniscal repairs, is there an age cutoff? Because I know back in the day, if you're a certain age, you're not, viable to have a meniscal repair.
No, definitely not. I mean, nowadays, especially we're seeing roots. I mean, Dr. Suarez may disagree, but we're seeing root tears in older patients, right? 50, 60, 70-year-olds who have the cartilage looks pretty good. You know, and you get weight-bearing x-rays and you have really good space. And so, you know, saving them from having to have a knee replacement, their normal kinematics in their knee. It really, and I tell every patient that I see, I don't know what I'm going to do until I get in there. But I'm going to try to repair every single one I can, because we know the long-term studies show that the patient's going to do better. Now, it may fail and we may have to go back and clean it out later, but I have to look at the quality of the tissue in every case to really decide. And so, yeah, I've done repairs in 50, 60, 70-year-old patients.
So save the meniscus as much as possible. And one last thing, and and Dr. Ouellette, I'm glad you mentioned about the psychological recovery, not just for hand patients, but for any patient recovering from injury. And for my years in working in rehab, I spent most of my time on working on that psychology, especially my high-level athletes when they're sidelined and they're looking at their team playing, their sideline. I spent more time recovering them, for that recovery psychologically and getting back out on the field. And that goes for all our patients. Getting them back moving, it is critical. When you're dealing with professional athletes, I know they're going to get back because they're phenomenal specimens. That's what get them to that high level. But the biggest hurdle is getting them mentally back on the field as quickly as possible.
Anyone else? Comments, concerns, complaints? Yes, sir. Complaints. I knew it.
So there's different options now. So there's most of them have the
The
braided.
question for everybody, sorry, the question for everyone in case someone didn't hear is what kind of sutures are we using for meniscal repair?
Yeah, so the majority of the implants now have a strong braided type suture, like a fiber wire and Ethibond type suture. But you can even use, I mean, a lot of the inside outs also use PDS because it resorbs over time. But, again, most of the time people are concerned about those knots, even with the big bulky knots you get with those fiber wire type sutures. I've seen them synovialize over time and they really don't irritate. As long as you place them in the back, right, not underneath the condyle, in the back of the knee, they'll synovialize over time.
Okay, guys, so now there's going to be lunch, but please keep an eye out because there's also going to be a group photo. So just kind of keep an eye out for that because it'd be nice. It's really nice when we get a really nice, good group photo for everybody. Okay, thank you very much, and thank you to all our panelists.
Welcome back. How was your meal? Was it okay? A little bit different than just having chicken a la day, okay? So we're now going to proceed with the the experts from the Baptist Health Miami Cancer Institute. The moderator for this module is Dr. Mehmet Alawalia. He's our Chief Scientific Officer, Deputy Director, and Chief of Medical Oncology, and the Fernandez Family Endowed Chair in Cancer Research. Dr. Alawalia will be joined by Dr. John Diaz, Chief of Gynecologic Oncology. By the way, I believe he's still the Chief of Robotic Surgery also. Chief of Robotic Surgery for the whole system of Baptist Health. Dr. Minesh Mehta, Deputy Director and Chief of Radiation Oncology, and the John and Mary Lou Dasberg Endowed Chair in Radiation Oncology. Dr. Murugazan Manoharan, Chief of Urologic Oncologic Surgery, and the Abbey Family Endowed Chair of Urologic Oncology. Dr. Gunther Kona, Deputy Director and Chief of Bone and Marrow Transplant Hematologic Oncology and Benign Hematology. And Dr. Jane Mendez, Chief of Breast Surgery. Dr. Mendez will be with us shortly. And with that, I will give the microphone to Dr. Alawalia. Thank you so much, doctors.
Hi, good afternoon, everyone, and welcome. I could not be more thrilled to join on stage with 5 of my esteemed colleagues who are going to talk to you about some of the latest advances in fields that they not only see patients in here, but some of the research they're driving here in South Florida, but throughout the world. And I'm the designated first speaker. So I'm Manmeet Alawalia, as introduced. And I'm being tasked today to talk about precision medicine in neuro-oncology, shaping the future of the brain tumor treatment. So I'm going to talk about brain metastases since it's 10 times more common than the gliomas that we see. And I know you in the morning probably had a treat listening to Dr. Evan Bender, who talked to you about the surgery of brain metastases. So brain metastases is a common clinical problem we see in the United States every year. Up to 200 to 250,000 patients will be diagnosed with brain metastases. So if it was a cancer by itself, it probably would be one of the most common cancer. Of the cancers that actually go to the brain, the most common cancer that goes to the brain is lung cancer, which is 50% of the cases. The second one is breast cancer, and third one is melanoma. So these are some of the tumors that I'll talk about today. But more important thing to keep in mind is until a decade back or so, the outcomes of patients with brain metastases was pretty dismal. These patients only lived 9 to 12 months. And most of the care was given by my colleagues in neurosurgery, like Dr. Bender or Dr. Minesh Mehta in radiation oncology. But I will showcase to you how some of the advances in novel therapies with targeted therapies and immunotherapies are really transforming the medical treatments of this thing. So first of all, I want to start off with lung cancer, which is really the most common cancer that goes to the brain, but more importantly, is the poster child of genomic drug development in cancer in general. So 20 years back, when I was in training, we thought all lung cancers were same, or lung cancer was non-small cell lung cancer or small cell lung cancer. But now we do know that based on genomic profiling, that the non-small cell lung cancer, that's the one I'm going to talk mostly about today, is 30 different varieties. And as a result, you will have to test for all these tumors, and you will see some of the common mutations listed here. And the ones which are common in our area is EGFR, for example, which is around 10 to 15% in the Caucasian population, but 40 to 50% in the Hispanic patient population. So we see a ton of these patients here. And this just gives you a snapshot of how genomic profiling and then targeted therapy to treat these patients have really changed outcomes. So here you'll see these three types, which are wild type or KRAS, where there has not been much change, but still the outcomes are around 12 months. But then you have the EGFR, which is very common in Hispanic patients, for example. The outcomes are 2 years. And then you have the ALK type, where before genomic testing was available, or rather before targeted therapy was available, these patients only lived 6 months. And now an average outcome of these patients with brain metastases is 5 years. And I'll show you a couple of slides to that. So this is just, again, too many drugs. I don't want you to memorize or try to read all of them, but crizotinib, sunitinib, alectinib, brigatinib. These are basically generations of drugs which actually showcase how drug development has happened. So crizotinib was the first generation drug, and it had limited entry into the brain, so limited blood-brain barrier penetration. And you see the response rate is 20 to 30%. So just put it in perspective. When we gave chemotherapy to our patients like 20 years back, the response rate was 5%. That means 1 out of 20 chances you gave chemotherapy to your patients and the tumor would shrink. Because what does a cancer patient want? They want the cancer to go away or at least shrink. But these new drugs, when they came up initially, had response rates of 20 to 30%. So that means they were 4 to 6 times better. But the newer generation drugs, as you can see, have response rates 50 to 70%. So they're not only keeping the tumor stable, they're actually shrinking the tumor. And so I just want to showcase that with this drug, which has really become the poster child of targeted therapy in brain metastases, and that's this drug called lorlatinib. And here you can see the response rates are 82%. But even more important is not only the response rate, but also you can see the progression in the brain. So the first drug that I talked about was crizotinib, response rate 20 to 30%, same thing seen in the study. But at 12 months, it fails in 30 to 40% of patients. But when you look at lorlatinib, it only fails in 3% of patients in the brain. And brain is one of the most difficult places in the body to treat any solid cancer. So this was a study presented at ASCO, and this is the 5-year outcomes of this study called CROWN. And you can see the blue curve. Even 5 years out, these patients are not failing in the brain if they don't have a brain metastases. But the lower curve is those patients who have brain metastases. So imagine 20 years back, these patients were living 6 months. And now if these patients get this drug, there's an over 80% chance that their tumor is not even progressing at 5 years. This is the transformative change. Genomic testing married with targeted drug therapy has the potential. Obviously, this is probably one of the best examples, and that's why I'm giving it to you. But this is what is now becoming the holy grail of genomic testing and treatment. So at Miami Cancer Institute, we actually use Caris Life Sciences in solid tumors, which is one of the most commonly used tests, but also very robust tests. They look at the whole exome and transcriptome. That means we look at the entire DNA and the RNA. And just giving you another example of this drug, the results came out in the last few years. It's a drug called sulpercatinib. And the reason I'm using this is because it's RET fusion. I'm giving you the story in lung cancer, but this is true for RET fusion, which can occur in other tumors like even thyroid cancer. And here again, you can see 80% response rate. All these bars going down means the tumors is shrinking. So you can see almost in every single patient, the tumor shrank. And in several cases, which are seen in the red bar graphs, is complete response. That means the tumor shrank or disappeared completely. So really exciting stuff for our patients as we see them. Next, you heard this morning from Dr. Justin Sporer about some of the groundbreaking work he and his colleagues are doing here with high-frequency ultrasound for tremor. I'm sure he showed you a beautiful video of a patient with a transformative change from tremors while the same day. Unbelievable stuff. It was on 60 Minutes, New York Times. We are driving the same work here in brain tumors because when you use the low-frequency ultrasound, you can actually non-invasively disrupt the blood-brain barrier. And one of the challenges in the brain is that the drugs don't reach the brain, right, because of the blood-brain barrier, the protective lining. So this modality can artificially, non-invasively disrupt the blood-brain barrier for 4 to 8 hours, and then it starts sealing within 24 hours. And we have shown through MRIs that after 24 hours, the blood-brain barrier is totally sealed. So that if a drug goes in, it won't come out unless the flux pumps put them out. But in short, this has really ushered a new era of potential transformative changes that we can make for our patients in brain tumors. And we have, along with our colleagues in University of Toronto, shown that to be true with a large molecule with trastuzumab, a drug commonly used for HER2-positive breast cancer patients, with the radio labeling tracking. But one of the other beauties of this thing is when you do this, you can actually also augment the immune response. You can actually do immune priming by improving the tumor infiltrating cytotoxic lymphocytes. And I'm sure Dr. Kuna will talk about some of the groundbreaking work he's been doing, looking at T cells and enhancing immunotherapy. So this is a global trial, actually, looking at lung cancer brain metastases along with pembrolizumab, along with Alemta and carboplatin, and using the blood-brain barrier disruption system. And actually, I serve as the global PI of this trial, and Dr. McDermott, one of my colleagues, is also driving this study from a neurosurgery standpoint. And we are seeing very intriguing results. And hopefully by next year, I'll be able to showcase to you some beautiful pictures of patients who are getting really nice responses. We are looking at this thing again in trying to increase the yield of cell-free DNA in the blood. So as you know, liquid biopsies have really transformed outcomes in, say, lung cancer. But in brain tumors, the problem is when we sample the blood for liquid biopsy, not enough DNA is released, again, because of the blood-brain barrier. So this is actually an FDA approval study where we are hoping that using this modality, we'll be able to double the yield of cell-free DNA. And we have enrolled around 44 of the 50 patients that need to be enrolled. But you can see marquee institutions which are partnering with us in this trial. And we are again leading this trial out of MCI. Moving on to breast cancer, I know Dr. Mendez will talk about all the work that she's doing in breast cancer surgery. But when breast cancer goes to the brain, again, the subtyping of your tumor matters. So patients who tend to have hormone-positive disease or HER2-positive disease tend to do better. And the ones which are in the gray, the worst outcomes are patients who have triple-negative disease, which tends to be very aggressive disease. So tucatinib is a novel therapy that was FDA approved, actually was the first drug that was FDA approved for brain metastases on the label. So it's a combination of trastuzumab, tucatinib, and capecitabine. Trastuzumab was the drug I had referenced before when I talked about some of the work we have done with the focused ultrasound. And here you can see in the blue curves, much better outcomes, in the blue curves, much better outcomes compared to the red curves, which is placebo. And you can see hazard ratios of 0.32, which is extremely impressive. So we are leading this trial out of, again, Miami Cancer Institute, combining that with radiosurgery. And Dr. Mehta will talk about some of the work that he and his colleagues are doing in radiation oncology. I would say actually right now, we're probably one of the best brain tumor programs in the country with some of the people we have working in neurosurgery, radiation oncology, medical oncology, as well as neuro-oncology. So this is one of the trials we are leading nationally and internationally. Actually, we got 3 different grants to lead this study called TUTOR trial. And this really established us to be the coordinating center of the International Radiosurgery Research Foundation of the world. And you can see it's 40 cancer centers around the world. And you can see some of the top names in the United States, including Cleveland Clinic, Mayo Clinic, NYU, Yale, UCSF, and the others. So we will coordinate the brain metastases trials for this foundation. And we got a foundation grant from International Radiosurgery. We got a grant from Pfizer, and we got a grant from V Foundation and Swim Across America to fund this study. Next, moving on, as you know, in the last few years, there has been a lot of excitement about antibody drug conjugates. And what those are basically Trojan horses, because previously we used to design these drugs which would go and attach to the receptor and then, or a protein, and then would act. But then what we found out is we can get the drug to get into the cancer cell using the same receptor. And this was a trial of TDXD, which is really a drug that has transformed outcomes of patients with HER2 breast cancer, either positive type or even low type. To just give an example, when they presented this study at ASCO, there actually was a standing ovation in the plenary session. ASCO is, as you know, the Super Bowl of oncology, 50,000 people, attendees. And it has happened like 2 times in 20 years. And this study was presented with breast cancer because it not only beat the previous drug, it beat it by 4 times. So typically when we get drugs approved in cancer, we get a benefit of like 3 months. This drug changed the benefit from like 7 months to 28 months. It was like 4 times better, which was highly impressive. So this was the trial they did in the brain. And as you can see, again, 70% response rates. Actually, we were quite baffled by this because we didn't expect a large molecule to work in the brain. But we are seeing the really good responses in a small study led out of Vienna with our good friend Matthias Prusser and his group. But at the same time, as I mentioned, a lot of times we use radiosurgery, which has been the traditional way to treat these patients. So when some of the early work was done with these antibody drug conjugates, along with radiation, there's a high degree of radiation necrosis. And so we got $1 million grant to actually lead this trial, again, out of Miami Cancer Institute. And we are coordinating with the 4 cancer programs in the state of Florida to look if it is safe to give this drug along with radiosurgery in prospective manner. Then just talking about some of the other groundbreaking work that is being done out of Miami Cancer Institute. This is a RAGE inhibitor called ezraligon, and it basically RAGE inhibition can act as a neuroprotectant. So a lot of times when we give radiation to the brain, although we've become very sophisticated, and Dr. Mehta will talk about proton therapy or radiosurgery, which we can use to mitigate some of the neurocognitive side effects of radiation, it's still a challenge. So RAGE inhibitor can actually serve as a neuroprotectant, but also can be a sensitizer. And there's preclinical evidence that the combination is really beneficial in brain tumors, triple-negative breast cancer, and pancreatic cancer. So this is work led by my colleague Rupesh Katocha here. And you can see this patient had 4 brain metastases, and 3 of them actually resolved, and the 4th one shrank. So some really exciting results, which is leading to a new path forward. And you can see several trials which are being led by physicians here at Miami Cancer Institute, Dr. Odia, Dr. Press, and several of us working very closely with the company, including Minash, who's got a great relationship with the company, to design some of those trials here and nationally. So what are some of the future directions and takeaway points from the brain metastases component is that we know that radiosurgery works great, and I'm sure Dr. Mehta will talk about that, but now we have drugs like targeted therapies and immunotherapies which can augment this, because we think the combination strategies are the best for our patients for long-term outcomes. And we know these therapies, targeted therapies and immunotherapies, work very well systemically. And Dr. Diaz will talk about some of these therapies, for example, in gynecological cancers. And we always believe that clinical trials is a way to advance care. So not only are we leading some of these trials locally here, but we are leading several of these trials nationally and internationally. Then in the last 5 minutes, I'm going to talk about just a snapshot of other tumors, because I was asked to talk about all brain tumors. So this is a lot of exciting work that has happened in IDH mutant gliomas, which are around 3,000 to 5,000 low-grade and grade 3 gliomas are diagnosed. And 12% of all gliomas tend to be IDH mutant. And then there's a beautiful mechanistic story of development of an oncoprotein which actually drives the cancer in these patients. And so they then designed a drug called vorasidenib. And this basically, because a lot of these patients are young, sometimes we don't feel the need to treat them, so they may be they may be put under observation. So this trial, which was presented last year at ASCO and a New England Journal of Medicine publication, showcased that this drug works well for these patients compared to placebo. Also, there are a lot of unanswered questions, and several of us are working to answer that unanswered questions. And this trial was actually led by a colleague, Ingo Malinghoff, from Memorial Sloan Kettering. And as you know, we have a Memorial Sloan Kettering Alliance. So again, something that we have great access to. Then this is another beautiful mechanistic story of a drug development focused on H3K27 mutant diffuse midline gliomas, because most of the kids who develop these midline gliomas have very poor outcomes when we use the traditional chemotherapies. And this work that was driven by Dr. Mehta, Dr. Ardia, Dr. Hall, several of our colleagues here, a very high-level publication in Cancer Discovery showcasing that we are almost doubling survival of our patients when we are using this drug compared to the traditional chemotherapy. Then, obviously, when you treat patients, you stumble upon interesting findings. So Dr. Rupesh Katocha, another colleague, was treating a patient with thyroid malignancy who happened to have meningioma, and the patient was getting cabozantinib, which is a drug that works against vascular endothelial growth factor receptor. And what he found was that the meningioma of the patient also shrank. So that led to a trial that he and Dr. Audi are leading here, and we are looking at national partners too, looking at this drug development in meningioma. Traditionally, meningioma is a tumor which has been treated either by, again, neurosurgeons or radiation oncologists. And medical therapy has not had a lot of advances, but some of the early results from this trial are extremely exciting, and we hope this may help us find another opportunity for our patients. Send just a story in the next minute or two about something that I have worked on for the last close to 18 years now, which is a vaccine which is targeted against cervivin. Cervivin is a protein that's expressed in around 95% patients with glioblastoma. So I worked in the labs of Dr. Robert Fenstermaker and Mike Krzyzewski at Roswell Park, and they basically designed a peptide-based vaccine which would mount a T-cell response as expected, but also intriguingly found an antibody response also occurring. And we ran a phase 2 trial in collaboration with Cleveland Clinic when I was there, along with Dana-Farber, as well as Roswell Park, and which resulted in a JCO publication, showed an improvement in outcomes of our patients by 1 year. Typically, patients with glioblastoma, as you know, have a very dismal outcomes. Sadly, these patients only live 15 to 16 months. And on this trial, what we found out was that average outcomes for around 63 patients that we treated, the outcomes was actually 26 months. But what I will tell you more importantly, as physicians, we have all treated patients. Sometimes these trials tell only part of the story. And I'll share a story of a young patient I saw who had just been married for 4 months when she saw me, and she had glioblastoma. And her parents were just, couldn't accept the fact that their daughter would have the outcome. And she came and saw us, she participated in the trial, and she had 6 years before her tumor even grew. Actually, she was on Good Morning America 2 times to talk about her story. She even had a kid out of surrogacy. So just a beautiful story. So I think that's what we all strive for in cancer. How can we work to give our patients second chances? Because when people are coming to see us at Miami Cancer Institute, they're putting their trust in us to give them a second chance. And I think that's the beauty of being a researcher or a physician scientist, that you can impact outcome of someone that you see, or maybe outcome of someone you never see. And that's the beauty of research. This is now a phase 2 study that we are participating, which will hopefully have an interim analysis soon, and if positive, will go towards an FDA approval story. So today I just gave you a glimpse of what we are doing, and if I would have given you a whole talk, it would have taken an hour and I would have been kicked out. But bottom line is, this is a snapshot of some of the things that we are driving here at Miami Cancer Institute in collaboration with leading cancer centers, not only in the United States, but around the world. And we look forward to further collaboration with you and your patients so that we can serve them in partnership with you guys. So with that, I will pass on the next talk to my dear colleague, Dr. John Diaz, who's the head or chief of our gynecology cancer program here. And he's going to talk to us about transforming gynecological cancer care, uterine transposition, and fertility preservation.
Thank you, Mamir. Thank you all for joining us in warm South Florida for our international symposium, and thanks to the international group for inviting me to share something pretty novel that we're doing here with uterine transposition and just fertility preservation in women who are battling gynecologic cancers. So this is our team. This is the Division of Gynecologic Oncology for Baptist Health Cancer Care. We have a group of gynecologic oncology surgeons, medical oncologists, radiation oncologists, and we're adding 2 members next year. So we're the largest group of gynecologic oncology in the state of Florida. I'm very proud of the program that we've built here today. And part of what we focused on is innovation. So women who suffer gynecologic cancers are often treated with a hysterectomy or pelvic radiation, which really eliminates the possibility of future fertility. And this may have been reasonable 10, 15 years ago, when in the 1970s, women had their first child at the age of 21. But women are delaying childbearing, right? And so now in 2024, the average age of women in the United States having their first child is 27 years of age. And so, as we all know, more and more we're diagnosing cancers earlier and earlier. And many of these women have not yet started or completed their childbearing. And in fact, 20% of first pregnancies occur in women who are 35 years or over in the United States. Look how that's changed over the last 20 years. And so we had to adapt. Women were the ones that challenged us and said, no, I don't accept a radical hysterectomy and losing my fertility. That's not acceptable to me. And so a radical hysterectomy, for those of you that are not gynecologic oncologists, is where we remove the uterus, remove the cervix, and remove the area around it to make sure that we have an adequate surgical margin. Daniel Dejean in France developed what's called a radical trachelectomy, and we did some of the first radical abdominal trachelectomy. It's the same concept. We're removing that cervix, but leaving the uterus behind for future fertility. When we first kind of came up with this, people said, you're crazy. How could you do this? This is going to impact, and women are going to have worse oncologic outcomes. And so this was the technique. So it kind of presents like a regular hysterectomy, okay? You can see you open up all the spaces. But then what you do here is you now remove the cervix with the cervical cancer, that surrounding parametria, but you leave the uterus behind. And here you can see the blue dye on that cervix, and that's because this is when we also began our sentinel lymph node experience. You then attach the vagina back to the uterus, and these women can then preserve their fertility for future pregnancies. And we put a permaciclage in, and this was done vaginally. And this is what it looks like when it's done. You can see the sutures there. And this is what it looks like about 6 to 8 weeks after the surgery. It looks kind of like a normal cervix, right? And so this was really a novel concept. And we published the first paper looking at oncologic outcomes, comparing women who underwent these fertility-sparing techniques to a traditional hysterectomy. And what we demonstrated was that there were similar oncologic outcomes between these two groups of women. And in fact, when you lose for disease-specific survival, in other words, those women who suffered a recurrence of their cervical cancer, there was no difference between radical trachelectomy or radical hysterectomy. This was a very novel idea. And in fact, this then became part of the NCCN guidelines. This is what we kind of go through to understand standards of care. This is what insurances use a lot of times to determine whether they're going to pay for these treatments. And it was our paper that was quoted in the NCCN guidelines for approval of this novel surgical technique that allowed women to preserve their fertility and also treat their cervical cancer. So this was a lymph node dissection. You can see how nicely we've cleared off all of the lymph nodes. This is a robotic radical trachelectomy you saw before, the open technique. In my right hand are the scissors. And I think we had a little bit of background audio. So here we're going through the round ligament. You can see now we're going to develop the bladder flap. This is just as we would do it for a radical hysterectomy. And so we're going to dissect that bladder away from the uterus. In my left hand is the bipolar energy source. We put a sponge and a stick in the vagina so that we can outline where the vagina ends, where's the cervix, and you really want to get that bladder away because we want a good 2-centimeter margin here. We're going to open up posteriorly to make that rectovaginal space. Again, you want to make sure you get adequate margins for this dissection, okay? So here we're making our anterior colpotomy. We're incising into the vagina, all right? Now we've released the cervix completely from the vagina. The uterus is still attached to its blood supply. We're now going to amputate the cervix with the surrounding parametria. And this is where the cancer is, and this is where it's going to be sent for pathology. And you can see once this is removed, what it looks like. So there's the uterus still attached. And here's the radical trachelectomy specimen. You can see there the cervical cancer. You can see the vaginal margin, all right? That's the parametria. That's that margin you saw before. Excuse me. So we're going to take that last section there, send that for a frozen section to make sure we have an adequate margin. This is a Foley catheter insert into the uterus just to help to avoid any kind of stenosis. This is a proline suture we're going to use for a cerclage. There is an increased risk of a preterm delivery. When it was first described by Dr. Dejean, when we modified a technique, we left about 10 millimeters of cervix behind to greatly decrease the risk of a preterm delivery. These women obviously are going to need a cesarean section, so that cerclage is going to be there throughout their pregnancies. You want to be careful because there's still blood supply running there. Those are the cardinal ligaments. We have the vaginal branches. And now we're going to attach the vagina back to that uterus. And so we do this in collaboration with our infertility doctors to make sure that these women are going to have a reasonable chance at a good fertility outcome. And these sutures will eventually dissolve. And you can see what it looks like. It looks like a normal uterus now. It's been reanastomosed to the vagina. The cervical cancer is gone. And these women can go on to have a pregnancy. And so this is my mentor, Nadim Abu Rustam. And this is a group at Sloan Kettering. And these are all the babies that were born following a radical trachelectomy. So these were all women who preserved their fertility and went on to have successful pregnancies. And every couple of years, we do an update of these videos. And so again, this having real world impact on these women and these families. So you saw before that we had that lymph node dissection, and we kind of cleaned all of the lymph nodes off the vessels. And while it's a great surgery, and I love doing it, we're probably over-treating most of these women. So we want to see, could we further tailor our sentinel lymph node evaluation? And so what we do here is we inject a green dye, and this goes now to that primary draining lymph node. And so we toggle between the white light to near infrared. You see that green picture, that's the dye that's going to these lymph nodes. And this is the first draining lymph node from the cervical cancer. And so that gets sent and it undergoes ultra staging. We're going to look here again, and it's not just enough you want to find that green lymph node. You really want to find that lymphatic channel that's draining and going to that first lymph node. We kind of borrowed this from breast cancer, right? Breast cancer has been doing this for a while, lymph node evaluation using sentinel. They use the blue dye. And so here you can see again in the optic space that green lymph node looks a little bit enlarged, okay? So this is going to be removed, all right? And so the benefit of this is, one, you're not doing a completion lymphadenectomy, which, you know, in the past, we treated patients with cancer and we thought of side effects and morbidity after the fact. We were so focused on the cancer. But if you have a complete lymph node dissection and then you require radiation therapy, you can have up to rates of 30% lymphedema. Again, patients don't really complain too much. They're happy to be cured of their cancer, but now you've left them pretty debilitating lymphedema. So they forced us to do better, and this is what we did. So we've tailored our approach. And in fact, when we've gone on to look at this, you have a higher detection rate using sentinel lymph nodes than you do with a completion lymphadenectomy. And so this was our paper. It's one of the first papers that were published looking at sentinel lymph node evaluation in gynecologic cancers. And this has now become, again, standard of care. But yet we're still doing research. We're proud members of the Memorial Sloan Kettering Alliance. And so we have the SELECT trial, which is looking, again, idea of a real world evaluation of sentinel lymph nodes in this collaboration with Sloan Kettering and the Mayo Clinic. And so we're happy to offer this to our patients. The surgery continues to evolve. And so for those of you that know cervical cancer, there was the LAC trial. And the LAC trial showed that if you did a minimally invasive surgery for cervical cancer, they had worse outcomes. But this didn't make any sense. You do minimally invasive surgery for urologic cancers and there's no difference in outcomes. Same thing with colon cancer. So something had to be different. And what was different, we thought, was exposing, as you saw in that radical trachelectomy video, that cavity to that cervical cancer. So I developed this technique where we use the robotic stapler, if you see there, and now staple across the vagina. And so at this time, you contain that cervical cancer. It's never exposed to the peritoneal cavity. So this is the robotic stapler you see here. When you fire this stapler, it does 1,000 readings per second of different data points to make sure that you have an appropriate seal on that. So it's the same idea as you saw before in that radical hysterectomy specimen. We've done all that dissection. The difference is now we're not cutting across our probe like you saw in the previous video. We're now coming across with a staple to make sure that we have tumor containment. So we're not exposing the peritoneal cavity to any of these cancerous cells. We'll take a stapler reload. We'll come in now. And so again, towards us is the radical hysterectomy specimen, and then down is the vagina. So we're coming across that so that we can staple across and make sure that we maintain integrity of the specimen so it's never exposed to that peritoneal cavity. So this was presented at the Society of Robotic Surgeons. And with this technique, once we release the specimen, we then deliver it through the vagina. Patients are still able to undergo a minimally invasive approach with all the benefits of that: less pain, less blood loss, quicker return to work, but making sure that we have good oncologic outcomes. And so the gynecologic oncology group is now doing a trial to look at this. And one of the requirements of this trial is to use some kind of tumor containment technique, like using the robotic stapler, or some of our colleagues will go down below and kind of suture the vagina before they go across. And so this is a trial that we have open here. My friend and colleague Marla Tail is one of the PIs for this trial nationally. So what else can we do? And I had a young patient, 32 years old, who was diagnosed with a vaginal cancer. The treatment for this is pelvic radiation. But again, that wasn't an option for her. And so what we decided was, could we do something else? What if we could move the uterus out of the pelvic cavity? She could receive her radiation therapy, and then we connected the uterus back. And this was first described by one of my colleagues in Brazil. Sloan Kettering has done 6 of these surgeries. And so I reached out to my friend, and thanks to our alliance, and discuss the case. And he thought that she would be a great candidate. And so you follow the same principles as you would with a hysterectomy. So we're opening up everything, but you want to be really careful you don't impact any of the blood supply. So we're going to dissect out the ureters. As you saw before, this is the round ligament, right? So we're going to come through this again with our electrocautery, all the while making sure that you're preserving the blood supply to the uterus. As you guys saw earlier, we had that probe in the vagina. You're going to take all this down. You're going to identify that uterine artery, which is the main blood supply. And this has been an evolution from what we did with the radical trachelectomies. We learned from our experience with the radical trachelectomy, you can actually take the uterine artery blood supply and still maintain enough blood to support the uterus and a pregnancy with the infundibulous pelvic ligament. So we kind of took what we learned from a radical trachelectomy and proceeded with this. So here we're going through the uterine artery. That's the main blood supply to the uterus. We're going to go to the other side, same thing, open up that retroperitoneum. And again, you'll notice minimal blood loss here, right? You can see the fine techniques that we can use with robotic surgery. Patients go home the same day after this, okay? As you saw earlier, we're going to develop that bladder flap, move that bladder away, okay? Again, taking that uterine artery on the other side, which is the main blood supply, but we know from our experience, you can still have collateral blood supply for that. So now we've made our anterior colpotomy, right? We're incising into the vagina. And we're going to completely release the cervix from the vagina. This has been most commonly described for patients who have like a rectal cancer, right? In my case, my patient was the first that was done for a vaginal cancer. So you see, we've now released the uterus completely. We're now going to move it now to the upper abdomen. So you undock the robot, you rotate, you're now working up to the abdomen. You want to make sure that there's no tension, no kinks in that main blood supply, because that's infundibulous pelvic ligament. That's what's giving all the blood supply to the uterus. You want to have this fastened about a little bit superior to the umbilicus to make sure you get it out of your radiation field. Okay. So when it was first described, they actually would bring out the cervix through the umbilicus, and the woman would continue to menstruate. That was kind of messy. So we gave our patient Depolupron, which shuts down the ovaries while they're getting their treatment. You can leave the cervix inside. It's going to stop their menstruation. All right. So we fasten this to the anterior abdominal wall. There's the cervix. So now we inject that green dye that you saw, and that green dye just follows the blood supply. And you're going to see this uterus is going to turn green in a moment, indicating that there's good perfusion to the uterus, right? That we haven't kinked anything, that this is still a viable organ. So you can see that green coming right from the infundibulous pelvic ligament along the ovaries and now to the uterine fundus. This is a good indication that we've, so far, haven't messed anything up. And now we're going to fasten the cervix to the anterior abdominal wall. And all this done minimally invasively. The patient went on to get her 6 weeks of radiation therapy. During one of her weeks of treatment, she came to the ER with some abdominal pain, did a CT scan, and they said, "We don't know how to tell you this, but you have a mass in your abdomen. This is probably a cancer." And she said, "No, that's my uterus." They said, "What?" I said, "Yeah, look at my operative report. They moved my uterus to my abdomen." So guys in the ER didn't do a good job getting a good history, but so completed her treatment. And then actually my friend and colleague, Mario Lateo, came down from Sloan Kettering. It's the first time we had a surgeon outside of Baptist Health that we got privileged for to operate here at Baptist. And we did the surgery together, robotically, a dual console. So this is afterwards. This is the second stage of the procedure. You can see you have some adhesions. You want to release all of these adhesions. Again, my scissors in the right hand. And that's that infundibulous pelvic ligament. That's the blood supply that's going back to that uterus, okay? And this is the first time this has been done in the southeastern United States. And this is the first one that was done for a GYN cancer. Sloan Kettering has done 6, but they were all for colorectal cancers. You want to release all of these adhesions. Obviously, we're taking our time. We don't do a lot of these. And there's no room for error here. But everything has gone great. So you want to release those adhesions, make sure you're identifying your blood supply. So now you've released the uterus. Okay, everything looks good. We're now going to move this back into the pelvis. Okay. And now we have to anastomose this back to the vagina. Now, the radiation oncologist will tell you that there are no side effects from radiation therapy, and they're right, but there is some scarring. So you want to do this about 6 to 8 weeks within then completing the radiation therapies. So that, again, as you guys know this by now, is the probe in the vagina. We're going to release that bladder away from our vagina, make our incision. My assistant's going to come in through the vagina. We're going to bring that cervix back into the vagina. You want to bring it a little bit into the vagina so as it heals, you have some space. And now we're going to suture the vagina to the top of the cervix there. Again, you want to be careful. There's still some vaginal branches, cervical branches. That's the only blood supply there. So you really don't want to injure any of that. That suture is the barb suture. So it has little barbs on it, holds in place. You don't have to tie knots, so it makes things a little bit faster in the operating room. And again, we're kind of not making this up as we go along, but no one's done this before. So really this is, you have to think this out before surgery and make sure you have a plan of what you're doing intraoperatively. We get that posterior bite, bring this together. Make sure that you close off all that area, but you don't want to do anything on the medial aspect where you might injure one of the arteries. Obviously, if she gets pregnant in the future, we need to have a cesarean section. She can't have a vaginal delivery. But again, we're preserving her ability to have future fertility, which wouldn't have been an option with the traditional way that we treat this cancer. There's the uterus. We're going to inject the green dye again. You're going to see a transverse of great blood supply to uterus again. The viable uterus that now has been transposed back into its normal anatomical position. This is the first one done in South Florida, or in Florida. And we're really proud of this. And this is my patient, Courtney. This was pre-op with my mentor, Marla Teo, who came down from Sloan Kettering. This was us and our team and our radiation oncologist, Yoni Weiss, who specializes in radiation therapy. It's a great asset for us to have. She rang the bell. I've never seen so many people there for a bell ringing in the 7 years that I've been here. And that's Courtney and me at our Panthers game. Yes, we have hockey down in South Florida. We're actually the Stanley Cup champions. And it was Hockey Fights Cancer Night. And she's been great throughout all this. And she shared her story and really trusted us. I told her, I've never done this before. And I don't know how this is going to turn out. But she believed in us, and we're really happy how everything has gone. So, you know, surgical innovation and fertility sparing, it's driven by patients. They're the ones that force us to think beyond what we know to do. We're moving towards less radical surgery, a more tailored approach, and it's really had a powerful impact. And you see that in those babies that wouldn't have been born otherwise, in Courtney, who has the ability to get pregnant in the future, and we're able to treat her cancer successfully. So thank you again for listening to this tale. I'm proud of the work that we've done.
What a fascinating case, and now you can understand why I said it's such a privilege to work with these luminary physicians and colleagues and do some of this groundbreaking stuff that we are so privileged to serve our patients. So on the same light, I'm my privilege or honor to invite Dr. Minesh Mida, who is the Deputy Director and Chief of Radiation Oncology. He's going to talk to us about advanced cancer care access, the importance of comprehensive radiation therapy modalities, and why it matters.
Thanks, Manmeet. Thank you. So you saw a common theme in the two prior presentations. The common theme is the patient. And I think as cancer doctors, we are especially attached to our patients because they're fighting some of the most devastating battles that you can see in all of medicine. And so for us, the patients indeed become a very significant focus. And although the title of my talk is very technologically oriented, what I'm going to do is bore you in the first half with technology, but in the second half, I'll come back to that theme, the patients and the stories they tell. So this is us. We are a world-leading facility, 13 radiation oncologists, 24 medical physicists. It's the most comprehensive radiotherapy technology platform anywhere on the planet. We have a deep clinical research trial portfolio with national and international leadership and very impressive academic productivity. And of course, we do research, but we do research with one and only one goal in mind, and that is to change the care and outcome of patients. We're scattered all over South Florida. This is the geographic map of where we extend and the future sites where we're going to go. But a lot of you are from the Caribbean and Latin America. And as you can see, we already have partners in the Caribbean. Some of them are in the audience here. And we continue to grow and develop this footprint because we truly believe that we owe our neighborhood a debt of gratitude and a debt of collaboration. These are our cancer physicians spread across South Florida. And this represents the pinnacle of what we collectively as a group can achieve. That is the creation and generation of knowledge and the dissemination of it. Since 2017, when we opened the doors of this center, we've now published over 1,000 manuscripts, posters, and abstracts. And it's a true testament to the fact that we learn from our patients every day, and we publish our experiences and deliver results. We do this through the context of conducting clinical trials, and we are very robust about our clinical trial operation that is led by Dr. Manmeet Ahluwalia. We accrue. Every patient deserves a chance at a clinical trial. We're the first across Baptist Health in terms of clinical trial accrual at MCI. We are the first in the MSKCC Alliance for accrual, and we're top in the nation in some of the major cooperative groups. As a consequence, the practice, the volumes, the procedures, the strategy continues to grow. It doesn't matter which metric we plot, you see an upward trend. This perhaps is the most significant slide for a technophile. This represents that comprehensive technology platform that I mentioned to you. This platform doesn't exist anywhere else on the planet. Anything that you can think of in terms of a tool in the toolbox for a patient with cancer exists in this center. And what that means is when I see a screwdriver, when I see a screw, I pull out a screwdriver, not a hammer. But in many places, a screw and a nail look identical. And a radiation oncologist that only has a hammer is going to pull out a hammer both for a nail and a screw. And I think that that distinction is often lost to those who are not sophisticated or knowledgeable about the variations and differences in technology platforms. What I hope to do is to tell you why this actually matters. To do that, I'm going to start off with a quote from a physician. This physician happened to be a patient of ours who had traveled the world and had been told that his cancer could no longer be taken care of because everything possible had been done. We did something that made a difference, and at the end of that, this is what the patient said. He said, "I wish to applaud the culture that you have developed with the focus on world-class technical care, combined with world-class genuine hospitality, kindness, and empathy for the patient. A winning combination, unique in my experience, and quite noble." So as I mentioned, that was the boring part of the talk. Now I really want to tell you what I believe in, which is my patients. And I'm going to tell you this from the perspective of telling stories. Our best stories are told by our patients, and this is a statement I use with homage to Salman Rushdie. Those of you who know Salman Rushdie will know he's probably one of the greatest storytellers of this century, for which he has almost paid a price of his life by telling stories, but has managed to survive. He's a Booker Award winner and writes some of the best books ever. He says that the distinction between civilization and lack thereof is the ability to tell stories, because only mankind can tell stories. There is no other beast, animal, life form that tells stories. And to expand that further, I believe that our best ideas for our research teams come from our patients. So I'm going to start off by sharing maybe 4 or 5 of these ideas. This young lady, 10 years of age, came to us with the picture at the bottom in panel A with a tumor in her brain circled in green above. This tumor, of course, was growing in her brain and caused her to not be able to smile. At 10, going to school with your peers, This is a major disaster, especially in the world of social platforms and instant gratification by getting your pictures online the moment you wake up. She came to us after completing her course of radiotherapy when she was still unable to smile and became the first pediatric patient ever to be put on an experimental drug, a slide of which Dr. Aluwalia showed you, ONC201, and became the first patient to be treated with this. And at the end of 10 months, her smile returned. We've never seen this with brainstem gliomas. To be able to reverse cranial neuropathies is a phenomenal outcome, and this is now the basis of an international global phase 3 randomized trial. We were able to do this because at that point in time, we had no idea what to do with this patient. We said, when we don't have an idea, and those of us who are up here in front of you telling you these stories, we are telling you stories on behalf of our teams, because what we have is a lot of smart people behind us. So what we do when we have a problem is I turn around and say, can you guys please help? Because that's the easiest way for me to solve the problem. And at the center of each team is always a woman. And as you can see, Dr. Odia is the center of this team, flanked by Drs. Hall and Dr. Dagestani. And they came up with this idea of using ONC201 in this patient and brought her to the point where you saw her smiling again. This is the paper that you saw earlier. In fact, Newsweek labeled this as scientists find a new weapon against brain tumors, a major crack in the armor, and the global phase 3 trial, as I mentioned, is underway. Cancer of the pancreas is a disease that gives cancer a bad name. This patient in red in the center, Lady in Red is one of my popular songs, came to us with unresectable, inoperable cancer of the pancreas, having been told at a major cancer institute, NCI designated, that she was at the end of the road, and perhaps the only thing she could do is go to Miami Cancer Institute to meet this strange guy whose picture I'll show you in a minute, who's doing this strange stuff with this strange machine that nobody has really heard of. And she defeated inoperable pancreatic cancer to spend time with her grandchildren. And in fact, this coat is her coat. There was no pain or discomfort. In fact, I felt nothing when the radiation was delivered. And that's that strange machine. It's a marriage of an MRI scanner and a linear accelerator. It's known as the MR-Linac. And again, when we are faced with tough problems, I turn around, look over my shoulder, and find 3 people smarter than me and say, go solve the problem. And at the center is always a woman. So Kate Mittauer, flanked by Michael Chong and Adil Kaiser, came up with the concept of using aggressively hypofractionated dose-intensified radiotherapy, which is a mouthful. And all that it means is we give a lot of radiation in a very precise manner only to the tumor, not to the normal tissue, continuously tracking it with an MRI scan of the patient so that normal tissues are protected. This is a very, very difficult thing to do because the pancreas lives in significantly important territory right next to the duodenum. And if you blow a hole in the duodenum, that kills the patient. So this is kind of risky business, and that's why I have people like Michael Chong take the risk while I watch. So what does this do for patients? If you go to Memorial Sloan Kettering Hospital with this advanced unresectable pancreatic cancer, and this is a joint publication that we now have, your chances of surviving 2 years are 20% with standard chemoradiotherapy. If you come to Miami Cancer Institute using the MR-Linac, your chances are 2.5-fold better at 50%. This has now led to this being described in the most recent NCCN guidelines version as an effective therapy for pancreatic cancer. And as of a week ago, this has now entered national guidelines. But the story gets better. The story gets better because 2 days ago, another therapy, electricity, and I'll tell you a little bit more about that in a bit, has been shown to have an impact in patients with cancer of the pancreas. This global trial run by a company known as the PANOVA trial showed a survival benefit in cancer of the pancreas. So we now have 2 things, electricity in this PANOVA trial, the MR-Linac approach. Guess what? This is the only center in the world where the PANOVA Plus trial of combining this electrical field therapy, tumor treating fields, with MR-Linac is currently active in recruiting patients. 2 days ago, news came out about the PANOVA trial. Yesterday, 4 patients walked out of their simulators in 4 different cancer centers and arrived at our center to be treated for cancer of the pancreas. And that's because we have the best reported results, as you can see here. This is a young attorney in her 30s. The MRI scan on the left shows you this ugly, bad-looking abnormality in white, which is an extremely large recurrent malignant glioma. If pancreatic cancer gives cancer a bad name, glioblastoma or malignant gliomas are not far behind. They follow suit. This patient's disease was at 5th recurrence. So it's not the first time she was diagnosed, but at 5th recurrence. There is no known therapy that is effective in this disease, at even 3rd recurrence for that matter. And at 5th recurrence, she came to us, and we told her there's only one thing that can be done logically, and that's hospice care. She looked at us and refused to take no for an answer, and insisted that we come up with something. And as always, I looked over my shoulder, found a team, I'll show you the team in a second, and we came up with an idea and decided she would be the first in the world to be treated with this idea. The scan you see on the right is her scan after that treatment. The disease was completely eradicated. This is the team. I have to pretend to be the woman in the middle this time. Okay. Flanked by Alonso Gutierrez and Rupesh Kotecha. And we came up with an idea where we tweak proton therapy using a technology where we pulse the radiation beam, because the biology of pulsing radiation beams is dramatically different than the biology of continuously delivering the radiation beam. And this has now led to a successful clinical trial called the Popcorn trial that we're about to launch. I mentioned to you electricity. Let me take you back to ASCO 2023, 2 years ago, where a positive clinical trial using this electrical field therapy apparatus, it is known as TT fields therapy, was deployed as an adjunct with chemotherapy. Patients were randomized to standard chemoimmunotherapy versus the same therapy plus tumor treating fields for advanced metastatic non-small cell lung cancer. This is one of the patients that enrolled on the trial. Our center enrolled the largest numbers of patients on this trial in the United States. Dr. Kotecha was the PI on this trial. This trial, known as EF24, takes patients and applies electrodes. You can see in that picture, electrodes being applied to the patient's chest, and the electricity is delivered in a continuous manner to these patients. Here are the results. A significant survival benefit to patients that get tumor treating fields plus standard of care. As you can see, the survival benefit continues past 3 years all the way out to 5 to 6 years. A month ago, this received FDA approval. 2 weeks ago, we became the first center in the United States post-FDA approval to be able to offer this as a routine standard of care to patients with lung cancer. This concept of delivering electrical field therapy is infectious. They say that imitation is the greatest form of flattery. So because my colleagues were so successful, and because they're all a lot smarter than I am, I figured why not simply copy them? So together with Dr. Ahluwalia, I and some of my other colleagues were involved in developing this international global trial in patients with non-small cell lung cancer with brain metastasis, using, once again, this approach of using electrical current that's applied to the patient's head. So patients with a limited number of brain metastases receive stereotactic radiosurgery to control their disease and then proceed to get this electrical field therapy. These results were presented at the ASCO 2024 meeting. Here's the design of the study. Patients are randomized after stereotactic radiosurgery to receiving best supportive care or best supportive care plus tumor treating fields. And as you can see, with best supportive care, the progression-free survival in the brain is significantly better it's much better with tumor treating fields combined with best supportive care compared to best supportive care alone. These data have just been presented at the ASCO meeting. They're in the process of being converted into a manuscript and presumably will be taken to the FDA for FDA approval. So this, if approved, could be another game changer in patients with brain metastasis. So with that, I'll stop here. We'll take questions in the panel session. And I believe it's back to you, Manmeet, for one more talk, I think. Thank you. Go ahead.
Thank you, Manesh, for sharing all the exceptional work you and your team are doing. And just continuing that theme of excellence, high touch, high tech, right? Because at the end of the day, we are living in the best era of mankind where we are having transformative changes in what we are doing in terms of artificial intelligence. And you're seeing that in technology. In fact, just to share a snippet, 2 decades back, the amount of knowledge we had in healthcare doubled every 2 decades. Do you know what time period it doubles now? Anyone has an idea? It's 72 days. Okay, every 72 days, we are doubling the knowledge or data that we have in healthcare. So imagine the unlimited potential we have to transform the outcomes of our patients. With that note, I want to welcome Dr. Murugasan Manoharan, who's the chief of our urologic oncology surgery program here. He's going to talk to you again, same theme, breakthroughs and innovations in prostate cancer surgery. Thank you.
Good afternoon, everyone. It's really a hard act to follow Dr. Manish Mehta and his stories. We'll try our best. And today, I'm just going to talk about, we do a lot of innovative things and wonderful cutting-edge options for the prostate cancer treatment to enhance the outcomes for most of our patients. And I think there's a disclosure thing. I have nothing to disclose. Today, over the next 15 to 20 minutes, I want to cover only a few options we provide at Miami Cancer Institute, and particularly the focal therapy for prostate cancer using the irreversible electroporation, otherwise popularly called as nano knife, and also high-intensity focused ultrasound ablation therapy for prostate cancer. I also want to cover a little bit about the improvements in the robotic surgery for prostate cancer and how we can also combine the theranostics in the treatment of prostate cancer to enhance and improve the outcomes. First of all, as all of us know, prostate cancer is the most common solid visceral cancer among men, and we have about 250,000 new patients are diagnosed every year, and we'll have about almost 30,000 people dying from the disease every year. We have several alternate options. We have surgery, like a robotic surgery. We have radiation, such as proton beam and a cyber knife. We have ablative therapy. We have active surveillance. We have hormone therapy. We have multimodal therapy. So when you have so many options, what are the issues? Why are we even very concerned about the treatment options? The problem is the prostate itself. The prostate is the most user-unfriendly organ for the surgeons and the medical oncologists, radiation oncologists, because it's located very deep in the pelvis. And when you look at the top of the prostate, the apex of the prostate, we have the sphincter. If you damage the sphincter, you get incontinence. At the base is the bladder and the urethral orifices. Anteriorly, you have the bones which you cannot retract. Behind the prostate is the rectum where we don't want to hurt it. But more importantly, on either side of the prostate at 5 o'clock and 7 o'clock position, we have the nerves which are important for the sexual function, erections. And if you hurt the nerves with any treatment, it leads to erectile dysfunction. So this is the main reason. And even though I've said all these things, what are the main concerns about the treatment complications, particularly among the American men? This is the most common concerns for the men, and erectile dysfunction. However, we have other concerns, particularly urinary incontinence can be stress incontinence due to surgery or urgent incontinence due to radiation, erectile dysfunction or bleeding due to the surgery or radiation, cystitis, bowel complications, secondary malignancies. So we have so many other complications, but when the patient is willing to go for the treatment for prostate cancer, the most important thing he wants is a durable cancer control. But that is not enough for the patient. They do look for further beyond the cancer control, the early return to activity, urinary control, and erectile function. As I mentioned earlier, multiple surveys in the US have shown that among all the treatments, they really look for a sexual function recovery as well. And we know that not all cancers need radical treatment. There are simple solutions for big problems. And on one hand, we have certain patients needing active surveillance. They may not be suitable for active surveillance, and they might be anxious, and there are some issues with active surveillance, including progression of the disease. On the other hand, the radical treatments such as surgery and radiation may not be acceptable to the patient and may not be needed. That's when the focal therapy comes into play. The focal therapy tries to address the cancer cure while you are able to maintain the quality of life. And ablation, I just want to introduce the topic to some of the people who are not familiar with it. Ablation means in situ destruction of the tissue. You can either destroy the entire or ablate the entire prostate, but that leads to destruction of the nerve bundles as well. Or you can do a partial or subtotal gland ablation where you at least preserve one neurovascular bundle for sexual function. Whereas the topic today we're going to talk about is a focal therapy where you want to select the cancer tissue with a rim of normal tissue around it, thereby protecting the nerve bundles and the sphincter on both sides. The salvage ablation means that somebody had a previous treatment such as radiation or another ablation procedure, you want to offer it once again, it's a salvage ablation. To make it simple, well, if you have a hemiablation, you destroy one half of the prostate and you preserve one neurovascular bundle, which is sufficient for sexual function. Or you can do a 3/4, like a hockey stick, a subtotal ablation, you still preserve one bundle. But in the focal ablation, you only destroy the tissue, the cancerous tissue, the rim of tissue around it, thereby protecting both the neurovascular bundle. We can use any energy source or a thermal or non-thermal to destroy the prostate tissue, which can include ice, cryoablation, or you can use heat with a HIFU, or you can use a radiofrequency ablation, interstitial laser, and microwave. And in non-thermal thing, one of the most important things which you're going to talk about is the irreversible electroporation or nanoknife. We also have a photodynamic therapy, and we have a radiation therapy such as stereotactic ablation and focal brachytherapy. Ablation, as I mentioned earlier, offers the potential benefits of the cure of the cancer while minimizing the side effects. So what is a nanoknife, which is like it's a commercial name, and the real thing is a irreversible electroporation, where this is a focal non-thermal ablation therapy where we use a high voltage but low energy direct current. And when you do that, it produces permanent nanopores in the cell membrane, which leads to leakage of the cell and death of the cell immediately. So when you put the tissue in the electric field, what happens is that because of the electricity passing through, the cell membrane permeability and surface tension changes, and it produces the selective pores in the membrane. And as you can see in this slide, on the left side is a normal liver, which is a 20,000 magnification. After the nanoknife procedure or an IRE procedure, you see the multiple nanopores. But in the prostate tissue and other things, these nanopore formations are very rapid. Within few milliseconds, if you look at the second picture, the micropores, the nanopores start forming. By 10 seconds into 40 seconds, multiple pores forms. And very soon, within few seconds, the cell starts leaking, and by 10 seconds, the cell actually dies and collapses. This is quite a wonderful technology to use in selected patients. Another important thing is that the IRE is a non-thermal. Usually, it protects the collagenous tissues and vascular tissue. Even if I have a big lymph node on top of the IVC, I can selectively ablate the lymph node without destroying the wall of the IVC. Usually you get a regeneration of smooth muscles, endothelial cells within few days to few weeks. That is the biggest advantage. For example, if I do a nanoknife or IRE on the prostate, if I want to do a radiation or I want to do a radical surgery, you can still do it because the architecture and scaffolding is maintained. That is one of the best advantages of the IRE. So the machine we use it at Baptist, we are one of the early people who did the clinical trials for the nanoknife for the IRE at the Baptist Health System, and we are in the phase 1, 2, phase 3 trials as well. And this is a generator, is a very simple device which can be easily transported in the back of the SUV and other things. The main thing we need as a surgeon is the electrode, which is a needle we put in the prostate, which is similar to any biopsy needle. So you don't need any other bigger gadgets. You can do it in an outpatient setting or in the hospital setting as well. The key thing is very simple. You have it right in the middle, the yellow thing is a tumor. You want to capture the tumor by putting the needles around it and electrocute it. That is the main thing. If you put the tissue correctly, between the, the needles, the cell will die. It's very, very reliable ablation we can achieve. So for example, if the tumor is right in the middle, I place 4 needles all around it, and we pass the current between different needles, 1 to 4, 4 to 5, 2 to 4, things like that. And that leads to the death of the cell and death of the tissue as well. So one of the things which is happening is that we have the advances in technology. We are using artificial intelligence. We have the MRI findings. We all fuse them together to make the procedure easier and more specific, more precise, so that you can destroy the tissue without causing any side effects. In this particular things, we use a grid, and we have an ultrasound machine with MRI fusion, which guides the surgeon to place the needle correctly. This is exactly you see in the operating room as well. You see the tumor incorporated in the image with the MRI technology and segmentation, and using the grid system and other advantages, you can place the needle exactly. For example, you can, looking at the picture, I can place the needle at C4, and it exactly goes to that. I did a case last week, and this is the procedure we did that. You can see the red thing there, which is the tumor on the left side. And I can predict where to place the needles by looking at the grid, and with the AI things, you will be able to see in real time where the needle will go and whether I'm putting the needle exactly around the tumor or not. So it makes the procedure easy and more precise. Making a mistake by the surgeon becomes less and less. And once I've done this, I think there's one more video. So I'm placing the needles right now. It's quite a straightforward thing. It's a real time. I can see it on the video, and the AI and other things guides me as well. And you place the needle precisely around the tumor, and it confirms the position. And then all that you need to do is that, ablate it with passing the electricity. And it's a very quick procedure. To ablate a 1 to 2 centimeter tumor, it takes only 9 minutes. And remember, the patient has got only the 3 or 4 needles placed, and they will be able to go home the same day. And this has got one of the best results with regards to patient recovery, getting back to work, and also like a urinary continence as well, and the sexual function. And the placement of the needle is reasonably straightforward as well. But the key thing is that not every patient is suitable for electroporation or focal ablation. The key thing is that selecting the appropriate and the right patient. Once you choose the patient, you need to ablate the tumor completely. After ablating, remember, you've done only focal ablation, the rest of the prostate is still normal. You need to closely monitor them to make sure that the tumor does not appear, new tumors appear on the other side, or recurrence happens. So when you look at the results, I'll have a quick 2 slides. First thing is that the failure-free survival is at 5 years is almost 90%. The beauty is that even if the 10% occurs outside the field of treatment inside, we can still offer the definitive treatment such as radical prostatectomy or radiation treatment and various other things, or even you can reoffer the same IRE. Even for a group 3 one, the survival, disease-free survival is 80% and above. But more importantly, the functional outcomes. If you follow these patients at 6 months, more than 99% of the patients are pad-free, incontinent, and dry, and more than 90% of the patients have maintained the potency. And the 10% of the people who have erectile dysfunction can still be treated with other options as well. So these are the advantages of the irreversible electroporation. Moving on to the high-intensity focused ultrasound. In IRE, we use the needle, whereas in the high-intensity focused ultrasound, the only thing we do is that we place the rectal probe to send the ultrasound waves. And this is, again, aided by the computer and the various other technologies. Once the patient is asleep, you put the rectal probe, scan the prostate. As a surgeon, I identify the tumor, I mark the tumor on the computer, and give the information to the machine. And this machine sends high-frequency ultrasound. It does a couple of things. First of all, it heats up the tissue where you're marked. It's very precise. And the temperature increases and leads to death of the cell at that area alone. Secondly, the high-intensity focused ultrasound causes oscillation and cavitation of the cells, leads to cell death. Within about 14 days or so, you will see the fibrosis taking place. But while you're doing the procedure itself, you will see that the tissue undergoing like a collapsing in size and shrinking in size as well, and you'll see it live as you're doing the procedure. Again, there is no needle, nothing else is involved. So the patients go home the same day, and they get back to work very quickly. And this is a position the patient are in, and that's a rectal probe. That's all the patient will have. And once we have marked it, you will slice by slice, the area where you're marked will be destroyed by the high-intensity focus ultrasound. Again, these technologies are very good, but as a surgeon, you need to choose the right patient, and you need to choose the right technology to treat the patient. And the high-intensity focus ultrasound, if you choose the patients wisely, again, the survival, everything is about 90% in 5 years and 7 years as well. And again, the continence and other things, the potency is very good, about 95%, 100%. So again, the technology is good, but you need to select the patient correctly and do the procedure well to achieve the best outcomes. And moving on to, like, I have another 6 more minutes, robotic surgery. Last year I spoke about robotic surgery. So this time I just want to spend 2 minutes. At Baptist, we have almost every single platform available to perform a very good robotic surgery. We have a Da Vinci 5, which is the latest one we have. We have a single port robot, and we have a multi-port versatile Da Vinci Xi robot as well. All the technology is available, but it's up to the surgeon to use the technology wisely to get the best outcome possible. So in the robotic prostatectomy, there are 2 things that are very important other than the cancer control. One is the sexual function protection, which comes from the nerve sparing. You need to do the nerve sparing only for the appropriate patient. You cannot randomly do for every single patient. If the patient is suitable for the nerve sparing, as a surgeon using the robot, you can do very well. As you can see that the sexual function nerve comes from the sacral routes, and these nerve bundles are very thin, like your hair fiber, and they are draped on the prostate on either side at 5 o'clock and 7 o'clock. And using the robot, which has got 12-fold magnification, and you don't have tremors, 4 hands with a precision accuracy, these nerve bundles can be identified and treated. Here you can see that the prostate, I'm very close to the prostate. You don't even see the nerve bundle right now. These instruments are very small. The tip of the instrument is only 1 millimeter. Very fine and gentle moves. You will be able to separate the nerve bundle from the prostate. It takes a minute or so to do this, but you keep the left hand steady. But if you do a very, very gentle moves, you will be able to separate the nerve bundle. Now you can see the nerve bundle separated, and we are still doing that. And at the proximal end will be the blood vessels to the prostate, which will clip and divide. You'll see it. But the entire bundle, by very gentle moves, this is very deep in the pelvis. So you can't see very well if you're doing an open procedure. So I'm clipping the neurovascular pedicle for the prostate and dividing it. But whereas I'm separated the bundle and kept it separate, you can see the bundle on the left side very clearly seen and separated, and you're maintaining this whole bundle completely, and you remove the prostate and the bundle is preserved very well. So that is one of the biggest advantages of the robotic prostatectomy. The second thing is that you want to do is the maintenance of the continence. The main thing with the continence is that puboprostatic ligament complex, which is you're seeing right thing, the white thing. Normally we tie the whole thing and divide it, but at the Baptist at MCI, we have a new technique where we preserve the puboprostatic ligament, which you see in the white in front. We put the stitch behind it completely, and so that the puboprostatic ligament is preserved, just like Dr. John Diaz preserved the uterus, we preserve this ligament. And after dividing it, removing the prostate, we actually put it back and sew them back together. So that way, the puboprostatic ligament is preserved and reanastomosed. So this single-handedly just changed the continence in the patients. And in our centers, like many other centers, at 6 months, the urinary continence level is almost 98%. Not almost, it is 98% at this moment. So you can see that I'm dividing the puboprostatic ligament, preserving it, only removing the prostate completely. And the prostate is the one where it's going to come out. And once you have done that, you're going to resew the whole, the puboprostatic ligament back to the bladder neck so that you restore the anatomy and you restore the continence for the patient. And just because I have only 2 more minutes, like now you can see that I'm doing the anastomosis. And then once the anastomosis is done, we sew it back to the puboprostatic ligament, which you'll be seeing it in a second. And again, this is very deep in the pelvis and the needles are so small. And we have done the anastomosis. And after this, anteriorly, you're having the puboprostatic ligament, which has been preserved. Now we are sewing it back. So you're restoring the anatomy as before. Lastly, I just want to bring a quick thing about theranostics. Many of you will be familiar with the theranostics. Briefly, when you offer the patient systemic therapy, such as chemotherapy or immunotherapy, it works for the entire body. It affects the cancer cells, it affects the normal cells, and you might get side effects. But if you combine the therapeutics and diagnostic agents together, that's what is called as theranostics. For example, In prostate cancer, we have a PSMA, the antigen and other agents, which are diagnostic agents, which specifically goes only to the prostate cancer cells, such as this. So like a PSMA, we use gallium pylori 5. These agents are diagnostic agents, which specifically goes and attaches only to the prostate cancer cells. And then we have a therapeutic agents. For example, you have lutetium-177, etc. And when you give it to the thing, normally they go to the whole body, all the cells. But when you combine the therapeutic agent with a diagnostic agent in prostate cancer, they specifically go attached to the prostate cancer cells only, and then destroy the peripheral cancer cells, thereby minimizing the side effects at the same time increasing the efficacy. So how can we can use any number of agents. You can use CAR T cells. Many other things can be used by attaching these therapeutic agents to the nanoparticles in the diagnostic agents. So in our center, we have a number of multidisciplinary collaborative approaches. And I just want to share one because of the time. And we have a very, very intelligent person from the radiation oncology by name Dr. Adil Kaiser. And he has got a wonderful thought. I'll give an example and I'll finish with that. For example, this patient is a 55-year-old gentleman. He has got a prostate cancer along the anterior aspect, which is very localized, but it is a very aggressive, high-risk localized cancer. But it is Gleason 9. Because of that, there are high chances of systemic disease, micrometastasis there, and you might have a multifocal other cancer in the rest of the prostate as well, which we are not diagnosed yet. This patient does not want to have the prostate removed. At the same time, you want to be treated well, both for local disease as well as systemic disease, and at the same time wants to have his continence, wants to have things. What can we do? This is what Dr. Kaiser is proposing. So what we would like to do is that because the disease is localized anteriorly, I can use irreversible electroporation nanoknife to destroy that cell within the prostate. Then we can use theranostic approach to kill any microscopic micrometastasis. And then we can also give, instead of giving a full dose radiation therapy, we can use a low dose therapy for the prostate to affect the multifocal disease which might exist. So we are addressing all these three things together at the same time preserving the sexual function as well as the urinary continence. So we have a number of other options available for future, but stay tuned. Thank you very much for your attention.
Thank you, Dr. Manoharan, for all the exceptional work you and your team doing. Continuing on this theme of excellence for our patients through breakthroughs, we are going to invite next Dr. Gantha Kuna, who serves as the Chief of Bone Marrow and Transplant and Deputy Director of the Miami Cancer Institute, to talk to us today about revolutionizing cancer care, stem cell transplants, and immunotherapy breakthroughs.
Thank you. My pleasure to be here and happy to have you all back or be here in Miami. Before I get into my field, I listened to Dr. Mano and Dr. Diaz and saw the video clips. I thought, thank your God that you didn't ask me to become a surgeon because you don't want me to cut your turkey. And so I ended up in the bone marrow transplant and stem cell transplant field. But my task for today is broader than just focusing on one disease, and that is hematologic malignancies. And that's a very broad spectrum of different diseases. They are all different, from lymphoma to multiple myeloma, leukemia, myelodysplastic syndrome, myeloproliferative disorders, and so forth. And even in between the diseases, they're not all the same anymore. Years ago, we had multiple myeloma. We did one treatment, and then we had a second one, and that was it. Leukemia were all the same, and today, with the rapidly changing landscape, it's very detailed and oriented towards high risk versus intermediate risk versus not so high risk diseases among all the entities. And I thought to just give you an update on where we are with some examples and indicate also that the time of more chemotherapy is completely over in our field. It's all immunotherapy directed. And I was happy and lucky enough, and we heard about MSKCC, to be there for 23 years before I came here and developed a lot of immunotherapies in the transplant field and post-transplantation approaches. That has all been published. I don't have to convince you about this one, but the platform was generated, and today it's really where we are. And I'd like to give you one example for multiple myeloma, if you can remember, so first question we ask, induction chemotherapy, then consolidation, then autologous stem cell transplantation, and then maintenance treatment. And that is still the case, but the drugs that we are using are very different now. It's not chemotherapy. Every patient that comes for myeloma treatment talks about chemotherapy, but there's not a single chemotherapeutic involved because we're doing Revlimid, we're doing Velcade, we're doing daratumumab. Those are all immunotherapies if you want. And so that is a big change. Autologous stem cell transplantation is continuously under debate, but it will not go away. And autologous transplant for multiple myeloma and the complexity or morbidity that is less than 1%. So why are we really asking whether or not we should do autologous transplants or not? And lots of my patients are more than 5, 6, 7 years out following autologous transplant and have never been readmitted or any complications post afterwards. So for me, it's a no-brainer. We will continue. But on the next slide, that is the novelty here. So when patients relapsed after autologous transplantation just 3, 4 years ago, we were kind of in trouble, said, what's next? And we didn't really have that much. But today, you can see here we have treatment for a first relapse. We have a third relapse treatment option. We have a fourth relapse treatment option. They're all immunotherapeutic directed. And the question that we are really asking today is, what should we do first and what is best? And that is under an international assessment right now. And again, the field is developing so fast, it basically changes within a few weeks. But so to just show you the difference, I thought I'll give you a case which is pretty much standard. As you know, a 60-year-old male patient comes, gets diagnosed with multiple myeloma, cytogenetic translocations 414, 1416. That makes it high-risk multiple myeloma based on there. On top of it, TP53 mutation and gain of 1q. That's basically all of them are high-risk markers that prompt us to say, okay, you're not going to get double treatment or triple treatment. You get quadruple treatment in the beginning for induction. That is daratumumab, Velcade, Revlimid, dexamethasone. This patient got exactly that, 4 cycles, then got autologous stem cell transplantation, was still minimal residual MRD positive afterwards. And for that reason, the patient got on daratumumab maintenance in combination with Revlimid and promptly relapsed a year later. So what do you do there? So, okay, you'll say Dara is one, isatuximab is another, CD33-directed antibody, but different binding sites. So we'll switch to a different regimen. Did this, and patient promptly relapsed 6 months later. So what now? Well, what would we have done 5 years ago or 6 years ago? We would have said, well, let's keep you comfortable for as long as possible. We can keep you on steroids and maybe if and here and there, but that's really all we can do. So what do we do today? We're asking, or I ask you, what would you do? Repeat autologous transplant? Not in relapse disease. Allogeneic transplant? Well, maybe. I led a clinical trial at Memorial Sloan Kettering Cancer Center for multiple myeloma with allotransplants. Transplanted quite some, the only place in the country. And I still get Christmas cards from patients that are 15 years later in complete remission. But it is complicated, so not every center would do it. But now we have bispecific therapies, BiTEs, so to speak, or we have CAR T-cell therapy. So, well, I just had a patient a few years ago, put her on bispecific BCMA, B-cell maturation antigen-directed treatment called elranatamab. You may have heard about it. Teclistamab is another one that is BCMA-directed. But you have choices. We have antibodies. Well, we use them. Daratumumab is a naked antibody, not necessarily indicated anymore. Antibody-drug conjugate, we heard about it a little bit. We have a toxin conjugated to the antibody. The antibody binds to the cell. The toxin gets absorbed and kills the tumor cell. Or we have what my expertise more or my specialty is we have a T cell that we direct to the tumor cell, and that is through the bispecific antibody. So we have an BCMA monoclonal antibody, on the other hand, a T cell, and with that, the T cell gets to the site and recruits other T cells to the side of the plasma cells. Now, the CAR T cells or bispecific antibodies here, as mentioned, is the principle. You not only get the T cell with the antibody to the myeloma cell, but once you release the cytokines at the site, other endogenous T cells will be recruited to the site, and with that, you get a complete remission, hopefully. The fact is, yes, we did. And one aunt of one of the staff members in the room was one of the patients that I treated with relapse disease after autologous transplantation, and that is unbelievably 3.5 years incomplete remission on elranatamab, not complete remission, stringent complete remission, which means it's minimal residual disease negative. That is something that we would have not seen 4 or 5 years ago, I would say. That raises question which we haven't answered and may not be able to answer or may not be gutsy enough to answer. That is, okay, 3.5 years, should I stop the treatment? Or do I have to continue? We don't know. I don't really want to stop it because it's well tolerated. Quality of life is 115%. So why should I stop the treatment and keep her, or take the risk not to keep her in remission? So changing landscape significantly, and now we are assessing combination therapies of BiTEs with other drugs that we have. Another example, switching to lymphoma real quick, 66-year-old diffuse large B-cell lymphoma, diagnosed stage 4, standard of care R-CHOP times 6 cycles. That's what we used to do and still doing it. And then the patient gets a PET scan and has relapse disease. And here we ask then the question, what do we do? Well, chemotherapy with R-GemOx, autologous transplant, allotransplant, CAR T-cell therapies. What would we have done 5 years ago? Well, we would have likely given chemotherapy and then an autologous transplant. Not 5 years, 3 years ago, we would have given chemotherapy with rice, which was a standard, and then a beam or R-beam conditioning, autologous stem cell transplantation, or a allogeneic stem cell transplant. We don't do that anymore because now we give CAR T cells. And the principle is shown here. As you may know, CAR T cells are gene transduced cells to bind to the tumor site. Here it's an antibody that's get introduced into the CAR T cells by gene transfer, and with that the antibody binds to the lymphoma cell, which is CD19 expressing or CD20 expressing or CD22 expressing, and the CAR T cell goes to the tumor and induces a complete remission. Well, that is a completely new approach that is also under evaluation. We have a clinical trial now here at the site where we don't do one CAR T cell binding site, CD19. We have a dual specific CAR T cell, which is CD19 and CD20 at the same time, because we know if you relapse after CD19 CAR T cell, most of the tumor cells don't regulate CD19, and with that, there is a very limited chance to get them back into remission. We call this tumor escape. So with dual specificity, that may be reduced, and the clinical trial is in full swing, and you will hear about publications coming up pretty soon. Now, not to confuse you even more, but over the last 5 years, there were 6 CAR T cells approved, shown here for multiple myeloma and lymphoma. And the question here is one better than the other, or is the one less toxic than the other? And talking about toxicity, it's a problem, different, and I have to say, myself and everybody else has completely underestimated the toxicity of the CAR T cells and the bispecifics. So don't do this in your clinic, or don't do it in your practice. You need to really have an experienced hospital or affiliate that can do this. The patients can be sent back to you afterwards. If they send them to us, we don't steal the patients. We'll treat them, get them in the remission. You do the follow-up, and we can by Zoom or whatever have discussion on what to do next. But it's known that the cytokine release syndrome is one of the complexities, and the neurotoxicity is another one, which you all heard of. Cytokine release syndrome starts with a fever, and within short time period, 24 hours, the patients get respiratory distress, get intubated, and end up in the ICU. If you don't know that it's CRS and you think it's an infection, and you start on antibiotics and hope for the best, that patient is dead. And so the neurotoxicity here also is another complication that they don't recognize when you come in the room, and some patients are happy not to know who the wife is anymore, but it's a neurotoxicity that is reversible with the appropriate treatment. We learned about this. But CRS and ICANS, as just summarized, can be treated. Tocilizumab for CRS, corticosteroids for the neurotoxicity, but not shown here. And I'm personally really surprised by the complexity in terms of infectious complications. We have all the viral reactivations seen, including adenoviral encephalitis, CMV infection, CMV encephalitis, EBV lymphoma. Every stuff that we know from allogeneic stem cell transplants can develop as a consequence following the CAR T-cell therapy or the bispecifics. So you need to know about it. Our infectious prophylaxis is equivalent to patients that underwent allogeneic stem cell transplantation because of the reactivation rates and the complications to be expected. Now here's my other one, just to jump into acute myeloid leukemia and the rapid changes that we have seen. And you may remember for 30 plus years, 7+3 was the only chemotherapy combination that was Downo and RRC, the only combination that was administered to patients with AML. And then at some point, before I came to Memorial Sloan Kettering Cancer Center, they started this allogeneic stem cell transplant program that was then accepted as a standard of consolidation therapy. But if you look forward, then now over the last 5 years on the right, all hell broke loose. And here we have alternatives that we have never dreamt of. And they are, again, not chemotherapeutics. They are, with the exception of CPX-351, which is liposomal 7+3, if you want. But gemtuzumab is an antibody against CD33, midostaurin, gilteritinib, anti-FLT3 antibody. And then we heard about already in the solid tumor field, the IDH inhibitors and IDH1 and IDH2 for patients with acute myeloid leukemia. Now, having said that, I mentioned that before, not every AML is created equal. We have completely different strategies for patients that get different forms of mutations or gene fusions in their disease. You can see there are some good risk markers like CEBP alpha, IDH2 inhibitor or IDH2 mutation is a relatively good prognostic marker, but you can, in contrast, also see that, for example, TP53 mutated AML is really bad. And no matter what you do, TP53 related AML or mutated AMLs relapse even after allogeneic stem cell transplantation within a very short time period, which then prompted us to say, why don't we do something like immunotherapy in the field of acute myeloid leukemia, maybe after transplant? And that induced the question, what can we do? Well, we can target leukemia cells specifically based on a marker that is expressed on leukemia cells, which is called CD33. But CD33 is also expressed on the normal hematopoietic stem cell. So that induces a real problem unless there is a way to downregulate the expression of CD33 on the hematopoietic stem cell and then transplant patients with CD33 negative stem cells. And we know now, and I'll show you some evidence, that all blood products derived, or all cells derived from the CD33 negative stem cell is also CD33 negative. So that leaves cells in the bone marrow that are CD33 positive are only leukemic cell populations. That was the theory. Now the question is, can we do that? Yeah, we can, because we have CRISPR technology. So we can downregulate the CD33 expression in the hematopoietic stem cell with gene editing by silencing the expression. Before we can do that, we select the stem cells by CD34, have a purified stem cell product, not the whole bag. We just have, all the million cells, and then we can do the gene editing. That principle of CD34 selection was established by Dr. Kona at the Memorial Sloan Kettering Cancer Center before he came to Miami, and now it's the principle of this of this clinical trial where we select the stem cells, gene edit, and then try to target CD33 specifically overexpressed and remaining on AML population. So the first question is, do patients survive without the CD33 expression, or do the hematopoietic stem cells survive? Does this guarantee a normal immune reconstitution or a normal count recovery? The answer is yes. I'll show you in a moment, but here we have then the principles of the CRISPR-Cas9 editing, silencing, purify the stem cells, as you can see, do the gene editing, and then we have the stem cell product that is CD33 negative. And here we now did 25 patients transplanted with the stem cell edit around the country, not by yourself only, but around the USA. I will present this in a week from now at ASH in a real updated presentation. Very exciting stuff. I just picked the first 3 to show that it got all confirmed that here the immune reconstitution and the count recovery was absolutely the same than after non-CD33 edited transplant products. But more importantly, here we also added gemtuzumab after the treatment, which is an anti-CD33 directed monoclonal antibody, and could show that it did not affect the platelets or the neutrophil recovery in any form or shape. The patients did also not get any liver abnormalities, which was a problem at high doses of gemtuzumab administration in earlier trials. But interestingly, I show you this one. You see here the percentage of the CD33 positive cells, negative cells after the transplant. You see that it's ranged at an early time point from 90% to 35%, and when we administered the gemtuzumab, it went up to 100%. So that means that the residual CD33 positive cells were eliminated through gemtuzumab, and therefore we increased this outcome to 100% of CD33 negative cells in the blood and in the bone marrow. Now the final subsequent clinical trial is then that we do this transplant. If they relapse after transplantation while on gemtuzumab or even before they started it, we now can generate CAR T cells from the same donor targeting CD33. And that is the whole principle that we now have 2 clinical trials. And long and behold, I can honestly and proudly tell you the first patient in the world that got CAR T cells that are CD33 directed against relapsed AML after a CD33 depleted transplant is in the hospital right here, right now, 6 days or 7 days after the CAR T cell infusion, is doing good, but obviously too early to conclude whether or not this disease remains whether or not he remains in remission and whether or not we get him back into remission. But he knows, and we know, that without this alternative, we would have had a real discussion and say, what can we do and how can we keep you comfortable? Here we have another chance, and I'm very optimistic we get this man back into a complete remission. So finalizing this, 28 seconds left. BMT immunotherapy program at Miami Cancer Institute, not here. We are growing fast. We are changing fast. You need to all stay on top of it, and maybe you can't. But the reason why I have this Wall Street Journal article just came out 3 weeks ago, maybe 4 weeks ago. There was a patient who lived in Utah and sought a second opinion at an academic center, and the complete strategy of this treatment approach was changed rapidly, immediately, and for that reason he survived. Then it came out that Memorial Sloan Kettering Cancer Center, MD Anderson, they get lots of second opinions, and they found out that about 25% in all cases, they have to change the treatment approach completely. You don't want to lose out to be in that field. So that is what I'm urging. If you have to stay on top, and the best way for you to stay on top is join my symposium that I have every year in March here in Miami with the top, physicians around the world. I don't have to read you all the names, but Michelle Sadelane I like to point out is the father of the CAR T cells. His laboratory was next to mine at MSKCC when he walked in over and said, I have this funny idea to put an antibody into a T cell. What do you think? That sounds great. Well, great for him because he will likely get the Nobel Prize pretty soon. But all the other ones here are friends of mine and colleagues from leading institutions that present update on all the heme malignancies. And I encourage you, if you can, come. It's a day and a half, and you will come home and you are up to date with everything. Thank you very much for your attention.
Thank you, Dr. Runa, for that riveting overview of heme malignancies. And with that, I would like to invite Dr. Jane Mendez, who's the Chief of Breast Surgery here at Baptist Health Miami Cancer Institute, to talk about Beyond Biology, shaping the future of breast cancer diagnosis and treatment.
Good afternoon, everyone. Time to wake up. Buenas tardes. Thank you, Dr. Ribas and the whole Baptist Health International for having me this afternoon. I'm going to, in the next few minutes, tell you a little bit about breast cancer we have to offer here at Miami Cancer Institute. So here's the building. In October, we always dress it up in pink in awareness of breast cancer. And some of you got to tour the building, but we house our services on the second floor. And what's most important for me is not the elegance and the beauty of the building, what happens within the building. From the minute I started 7.5 years ago here at Miami Cancer Institute, I was struck by the aesthetics of the architecture, but I knew what was most important was what we were going to be doing within that building and how we were going to grow. So in the next few minutes, I'd like to tell about the burden of breast cancer worldwide, what's the importance of the multidisciplinary approach, and then explore existing as well as future challenges that we still have despite all the advantages. So every 2 minutes, the time it takes to boil an egg, a woman gets diagnosed with breast cancer in the United States. If you take that number worldwide, it's even faster. 1 in 8 women will be diagnosed with breast cancer during their lifetime. We know that African American women have 42% higher risk of dying from breast cancer as associated with Caucasian women. And we know that it's the most common cancer in Latin American women and the #1 cause of cancer death in Latin women. We know that the likelihood of developing breast cancer increases as we age. As you can see here, and when you're 50s, we expect 1 of every 50 women. When you get to 70s, 1 of every 14. And by the time you get to 80, it's 1 of every 10. And that's without any other risk factors. So the 2 main risk factors for breast cancer are being a woman and getting older. And unfortunately, we cannot change either. And I like to also, this is a very educated audience, but to stress again, most breast cancers are not familial or genetic. 85% are sporadic. They happen out of the blue. So certainly it's very important. A lot of women come to my clinic. I don't know what I have breast cancer. I don't have it in my family. So it's a moment when I educate the patients that 85% you don't have it in your family. You're the first case. And also lately, we've had an increase in male breast cancer. I don't know what are the factors attributing to this, but I had a 53-year-old triathlon athlete who thought he had a pimple in her breast, turned out to be stage 4 breast cancer. So certainly men, if you feel something, say something, because we have been seeing an increase in male breast cancer. And it does not matter where you are around the world, breast cancer accounts from anywhere between 19 to 28% of cancers around the world. It doesn't matter where you are around the globe. And unfortunately, we know that in our countries, South America, Central America, Caribbean, and others, we still see a lot of late-stage presentations of breast cancer. I travel to a lot of these countries, and I always like to learn about the local numbers. And it's sad to see that in a lot of our countries, we see 60, 70% advanced stages of breast cancer at presentation. And we know there's no doubt that the likelihood of your outcome and your survival is linked to your stage at presentation. And in developed countries, we can see up to 80% survival rates in high-income countries, whereas in low-income countries, that can be 40% or less. So certainly, This can be attributed to a lot of factors, certainly access to care, technology, education, prevention strategies. We certainly, in some countries, we don't have the resources, but it's really important to continue to disseminate. Early detection is key in order to continue to improve these outcomes. So nobody will argue with me in this room. Number one, everybody has probably seen somebody who has breast cancer. And when a woman feels a lump, it's urgency, it's anxiety. They want the lump out, okay? But we have to do our job. As a clinician, I have to make sure if this is a benign lump or is this a malignant lump. So we have to do the appropriate workup. Gold standard is mammogram. And here at Miami Cancer Institute and Baptist, we have 3D mammography. Sometimes we need to complement the mammogram also with an ultrasound. We know that breast sensitivity lowers the sensitivity of the mammogram. So in women with dense breasts, we have to complement that with an ultrasound, which gives us a lot more information. And then we can perform minimally invasive techniques like core biopsies so we can establish the diagnosis. We have 3D mammography in all our facilities. So certainly has really helped even find the cancers earlier. And in some instances, we might use breast MRI. That is not a screening technique because it's too expensive. There's 24% of false positives, but certainly has a role to play in certain segments of the population. And there's the million-dollar question. Women don't like to be squeezed, okay? Are there any other modalities that we can use to help us detect breast cancer? And actually now we're going to introduce what's called contrast-enhanced mammography. We're actually having conversation with our breast imagers to see what's going to be the criteria, but we're introducing this in our armamentarium for breast imaging. It's kind of a cross between a mammogram and an MRI. As the patient will get injected with contrast, we can see better vascularity and more details than just the standard 3D mammography. So stay tuned, but that will be added to our armamentarium. But for the meantime, ladies in the audience, the mammography will remain the gold standard up until we have better technique. So it's a necessary evil. So I'd like to change gears a little bit and to talk about the importance of the multidisciplinary approach. Certainly, this has been an evolution of care from the very radical procedures of the Holstidian era to the more tailored approaches, a multidisciplinary approach that we've seen in the modern era and that we practice now. The gentlemen in the center are Umberto Veronesi as well as Bernard Fisher, who were the ones who started challenging the dogmas at the time and questioning, is there a role for chemotherapy? Is there a role for radiation, rather systemic approaches and more local control rather than these massive operations? And then the gentleman on the other side, Dr. Armando Giuliano, he's the one who introduced the sentinel lymph node biopsy, who certainly changed women's life and not exposing axillary dissection to all our patients unnecessarily. And they conducted really pivotal clinical trials that have changed the face of the practice of breast surgery. And it's all about the multidisciplinary approach. I cannot do my job without the medical oncologists, the radiation oncologists, the plastic surgeons, the pathologists who are busy, the breast imagers who are the ones who first place the diagnosis. So it really takes a village in order to provide our patients with the optimal care. And certainly how we treat the patients also varies. Sometimes we give chemotherapy first. Sometimes we might perform surgery first. For those patients who are ER positive, the hormonal therapy. So there's so many options that we have. And it's all about personalizing the patient, not only to the type of cancer that they have, but also any other medical problems that they might be dealing with, so we can really optimize their cure. And we've learned a lot about the past decade, about the different types of breast cancer. Before, all the patients got treated the same. Certainly now we know there's 3 major types of breast cancer. We have the ones that respond to estrogen, the ones that don't respond to anything, that is called the triple negative, and the HER2, and those only account for about 15% of breast cancers. So understanding the biology heterogeneity Dr. Cohn was talking about understanding the hematologic malignancies, gives us an opportunity to further tailor the care to minimize side effects at the same time that we're maximizing outcomes. So one size does not fit all. You see it again. So it's about finding those specific targets. So for the ER-positive tumors, those that respond to estrogen, we have the endocrine therapy, the aromatase inhibitors, the tamoxifen, And obviously for the HER2, we have the Herceptin, trastuzumab, and other factors that really help us target the treatment. And the goal is the following: we maximize the breast cancer cure while we maintain the quality of life. Because we know with everything, there's a price to pay. With every treatment, there's some side effects, and it is our job to be critical about where we begin our patients where we can maintain this balance. So I want to give you a couple of examples of what we do. Every Friday, we have a multidisciplinary tumor meeting where we discuss difficult cases so that we can decide as a group what is the optimal care for that particular patient. So I'll give you a couple of examples. So the elderly, we know every woman 70 and older need for me to check their lymph nodes. We know that if I do a sentinel lymph node biopsy, I will increase their likelihood of lymphedema, which will be in the order of about 5%. So will that really change the patient's management? So one of the recommendations we're choosing wisely is for women 70 and older, really be critical. Do we really need to be doing a sentinel lymph node biopsy in that patient if they have a small tumor, if they respond to estrogen? Is that going to change their management? Another example, ductal carcinoma in situ is stage 0 breast cancer. And there's a lot of ongoing clinical trials right now to see if there's a subgroup of patients who have ductal carcinoma in situ stage 0 that has a great prognosis, in which they have such good characteristics that we might be able to avoid any surgery. Might it be that if they respond to estrogen, it will do just with the endocrine therapy? Can we keep them at bay? So that's ongoing. We're looking forward to finish the accrual, and we're waiting for those studies results to be published to see, is there the fact that we don't need to do anything, just give them a pill and keep them afloat. Age. So my oldest cancer patient here has been 99 years old. The youngest one, 21. Okay, and we need to tailor the therapy to that patient also based on age. So the 99-year-old, she had a lump. She had been delinquent for a grand total of 99 years. That was her first mammogram ever. And the reason why she decided to have the mammogram done, because it was hurting her. I'm not joking. Her lump was the size of a grapefruit. And I was hoping she would have an estrogen receptor positive tumor. So I could just keep it at bay with the endocrine therapy, alleviate some of her pain, and avoid any surgery. But to her dismay, it came back at triple negative. So then this was during the pandemic, and I presented the tumor board. I said, I have this 90-year-old, she only takes an aspirin a day. Her brother lived to 104, her sister lived to 105. She's a triple negative, and she has pain, she's symptomatic. So the tumor board's decision was, yes, let's offer her an operation. Then I said, I'm not operating on you unless all your family is on board. Okay, this was October, and she was going to be 100 in 6 months, March 10. And I said, well, provided your whole family is on board, then I'll be happy to operate on you. So she had an operation, and she went home the same day. Mastectomy, went home the same day, and when she came for her post-op appointment, said to me, doctor, I made a decision. I said, what is that? If I win the lottery, I want you to reconstruct my breast. And I'm like, okay, that's the spirit. 99, but nobody was stopping her. Now, this 21-year-old is a slightly different story, but she had a mass, and they had told her that it was a fibroadenoma. And I was seeing her for a second opinion. And she had a family history of breast cancer. And her mother had the BRCA gene and had been treated already prophylactically for her genetic mutation, but she had never had cancer. So I said to her, you know what? They're recommending 6 months, but why don't we do a biopsy? It's so easy to do a biopsy. You've had the mass for a long time. You tell me it's enlarging, and we need to get to the bottom line. She was actually studying to take her MPAS to attend medical school. Make a long story short, she listened, she followed my recommendation. It was not a fibroadenoma, it was a breast cancer. So in that group, we need to really focus on the patient because there are many different issues, different from somebody who's already menopausal. We need to talk about having children, so fertility becomes really important, about her body image, about reconstructing her whole, about the sequela, because she has many more years ahead of her to live. So certainly we're actually creating a new program that's going to be geared for the young women with breast cancer defined as 45 and younger. We can really hone in the specific needs of the women who are young and have all these other issues to address. So with that, we need to reduce the collateral damage. I think I made the point. Also from the chemotherapy standpoint, we really utilize some platforms that are genomic profiling, where we can send the patient's own tumor tissue for analysis to help decide whether the patient is going to really benefit from chemotherapy or not. Again, there's side effects associated with the chemo. So we can avoid it because the patient is not going to derive a benefit. Why expose them to the added side effects of chemotherapy? So we utilize that technology. When it comes to radiation, we have the proton therapy. Of course, for those patients who have left-sided lesions that might cause cardiotoxicity, if necessary, we have the ability to provide with the proton therapy so we can minimize any cardiac side effects. So this is all part of the conversation. And Angelina Jolie cannot be ignored in this arena. And after she went public with her story, it's going to be almost 10 years ago now, we really have seen an increase in the women asking for a bilateral mastectomy. Certainly when you have a genetic mutation, that is going to be the recommendation. But when you're not, certainly we know it doesn't really confer a survival advantage. So certainly when I ask patients, what is the number one reason when they don't have a mutation, but they request to have a mastectomy, the number one answer is peace of mind. And it's my job to remind them that even after they have a mastectomy, no zero possibility of the cancer coming back. It's still 2 to 5%. But as close as we can get to that zero. And we can do great work. I work with an incredible group of plastic surgeons. This is a lady who had a skin sparing mastectomy, which is an operation that we can selectively perform in certain patients. We can save the whole skin as well as the nipple alveolar complex. And we can, obviously, you cannot tell the difference in this patient. You can see the results are really incredible. But it's about, again, patient selection, as some of my other colleagues were talking about. It's not the right operation for every patient, but those who are, it's a great option that we have from the cosmetic and oncologic standpoint. A lot of women now, they don't want any reconstruction. They want to be flat. And this is a movement that has become really popular. It started in New York and has taken, the United States by storm. And if they want to be flat, we certainly can provide that as well. So the flat movement has become very important in the United States and is definitely a very personal choice, but it's good to be able to provide the patients with what they think is best for them. So needless to say, the breast cancer journey is a road. Certainly the patient is at the center of it, but for us, between family, friends, quality of life issues, we have an incredible team of patient navigators who are oncology nurses who escort the patient throughout the whole journey. Once they finish with surgery, they go to medical oncology, radiation oncology, they're a whole continuum of care. They're a factor and a constant for the patients as an added resource besides their immediate team. In addition to that, we have an incredible team of support, survivorship. Over 3 million survivors in these states just because of the quality of the care that we can provide. And we need to provide for what happens after the completion of the treatment. Is as important as during treatment, from the psychological, exercise, rehabilitation, nutrition, exercise, yoga. So it's the holistic approach that we have a very strong program for our patients. And certainly this is the model that we have, anything from stress, psychiatry, rehab, nutrition, as I mentioned, and it's all trying to keep them healthy as they go through survivorship as well. And this is all a compilation of all the research, the technology, as well as all the new information that we have. A lot of you've heard from my other colleagues this morning. As we continue to learn more about the biology, we can continue to shape that future. And AI has a role. We think that it's going to have a very important role in imaging, trying to see features that we can identify even before they completely manifest by pattern recognition, as well as from pathology, high-risk conditions that we might be able to identify patterns even before they develop into cancers as part of the utilization of AI. But ladies and gentlemen, despite all these advances, I still have a little black box. And would everyone want to venture what's in my black box? Huh? The future. In my black box, I have the following. Despite all these advances, we still see that there's a higher likelihood of developing, breast cancer in higher mortality in African American women, even though they have a lower likelihood of developing breast cancer. We know that Black women get diagnosed with breast cancer at younger ages. Same applies for Latin women. We know that both Latin women and African American women tend to be diagnosed at later stages of disease. And I already mentioned how the breast cancer is the #1 cause of cancer death in Hispanic women. So it is the leading cause of death in Latino women. And we know that there's a very complex interaction between socioeconomic, social factors that impact these outcomes. However, we know that there's also biology behind it. Both African American women as well as Hispanic women tend to be diagnosed with the more aggressive, the triple negative type. So it's very important to continue to understand these biologic subtleties as we continue to understand this continuum from prevention to survival as we continue to care for our patients. And we know that every single time a patient walks through the doors at Miami Cancer Institute, they bring a story. Everybody's different. Not only do I have to focus on the type of breast cancer that they have, I will be able to help them with our team, but also their fears, their concerns. They might be coming from far away. So everybody has their own issues. But it's all about the centered approach care that we provide. And I think that's one of the main differentiators between us. Patients are not numbers. Patients are treated as people and not as their disease. And that's extremely important to us. As actually Dr. Zinner, our CEO, from the beginning, he was always about high tech, high touch. And that's something that we take very, very seriously. We still have some challenges ahead. Certainly, we're still recovering tremendously from the pandemic. I cannot tell you how many women with late stages of disease have been coming to our clinic. Already spread to the lymph nodes. I had a lady, 42 years old, who I just saw 2 weeks ago, already stage 4 breast cancer. Despite all the education and awareness, we still see this. And I think a lot has to do with still the COVID-19 sequela of people really not taking care of themselves and not following the screening guidelines. We've gone from what's maximally tolerable from the Holstedian era to what we need to do to cure patients, from what's anatomical to that's biologically appropriate as we continue to learn the subtleties of the biology of different types of cancer, to additional medicine, to evidence-based. Clinical trials are key to keep learning about the different types of subtleties in breast cancer and continue to move the pendulum forward. And from science to treatment planning, because we have to continue to learn. I've been doing this for 30 years, and to see women in the hospital not knowing if they were going to have a mastectomy or lumpectomy because the core biopsies didn't exist and they had to go to operating room just for diagnosis, to see what we can do now that we spend hours talking to our patients about their options. Is really great to see the evolution as we're trying to maintain quality of life. Certainly, we need to keep changing dogma and challenging the dogma as we continue to decrease that collateral damage. I'm excited that we're going to have a new house across the street. We had the groundbreaking for the Women's Cancer Center on September 18th, and we're very excited that we'll be able to hone in and really focus on women's care in that building, which is going to be a beautiful building. But again, what's most important is going to happen within that building. So all under one roof, it takes a village, as I said earlier. I'm very privileged to work with an incredible group of colleagues. These are my fellow breast surgeons, certainly medical oncologists, all who only do breast, radiation oncology experts, my breast imaging interventionalists, the list goes on and on. We have also a benign breast clinic, as well as breast cancer prevention clinic, where we want to keep patients in the pre-viral stage before they develop their breast cancer. My colleagues in plastic surgery, rehabilitation, as well as the genetics that really has become a foundation for what we do in cancer. So ultimately, it's this continued marriage between technology and human touch that has taken us where we are today. And I'd like to thank you for your attention. And again, thank you for invitation for having me this afternoon, and enjoy the rest of the meeting. Thank you all.
You want to take a seat? At this time point, I'll invite the speakers to come back to the stage so we can have a Q&A session. So I would thank all the speakers for a number of exceptional talks about what we are doing. And as Dr. Mendez said, it takes a village. I hope you got the message that luckily at Miami Cancer Institute, we are very fortunate to have had the investment that was made by Baptist Health to really create a world-class facility here, whether we have showcased that hopefully to you in terms of technology, genomics, multidisciplinary management, tumor boards, and as was outlined, we actually have tumor boards for all of our cancer patients. We at least meet once a week where multidisciplinary team of surgeons, medical oncologists, radiation oncologists, and a number of support services group are there to discuss every care. Because a lot of times we have evidence-based care for our patients, sometimes we don't. And as Dr. Mehta alluded to some examples, sometimes these discussions actually generate ideas that then lead to clinical trials that we run with collaborations all over the world and create evidence to treat those patients. So if anyone has a question, I would request you to find a microphone. And if not, I'm going to start with a few myself. So Manesh, I know you are, as you proclaimed, we are lucky that we have all the radiation modalities under one roof. So sometimes we have more than one. So if someone comes to you, what are some of the questions you look at, to pick the right modality? That's number one. And second, obviously, a lot of patients who come to see us from international or away from distance, we have capabilities of doing hypofractionated radiation. Can you talk to us a little bit about that, so that we can inform our friends when they give us the care of their patients?
That's a great question, Manmeet. So in radiation therapy, we focus on two things. The first is a therapeutic window. How can we maximize our ability to control the tumor and minimize harm to the patient by treating the least amount of normal tissue? And we have mathematical metrics, and Dr. Mendez talked to you about AI. These metrics are now AI powered. We can actually do this without the patient. We can actually do this all based on a CT scan or an MRI scan of the patient. We can predict the risk of toxicity. We can predict the risk of local control. So using these metrics, we can actually triage different therapies in terms of what's going to be the best for the patient. But layered on top of that is the second element that Manmeet brought up, and that is time. Radiotherapy is a commitment of time. Cancer care is a commitment of time on the part of the patient. And time is money, time is effort. So we also want to introduce time savings. And so that's the second component that goes in. Can we shorten the courses of treatment? We heard about what COVID did to us in terms of negative issues. One of the things COVID did to us was force us to rethink. And one of the things we have done is a series of clinical trials that carry the acronym SMART. And one of them is called SMART 1. What that means is we do all the radiation in one treatment for certain patients. So there are actually a number of clinical trials that we have run. And for a number of patients, maybe just one treatment, sometimes it's 3, sometimes it's 5, but ultra short courses of radiotherapy can be quite effective. So that's another development that has come out that we are pursuing. So thank you.
Thank you, Manesh. Next, moving on to Dr. Manohar, and you talked about, obviously, prostate cancer, a number of modalities, nanoknife, high-frequency ultrasound, or, prostatectomy, again, using robotics and things like that. So when a patient comes to you, what are some of the questions they may be asking, or how do you pick one modality versus the other?
Thank you. That's a very important question. Most important thing is that the dialogue between the patient and the physician. And most of us will have some bias. If you're a surgeon, you're biased for surgery and you have radiation oncology bias. But it's nicer to become unbiased and give a full explanation to the patients and give them all the resources to look at it. And unlike other cancers, prostate cancer, those patients are suitable for more than one treatment option. Somebody may be very scared of surgery and they might go for the radiation treatment. But there are certain conditions where you offer, one over another. But important thing is that be open with the patient and honest and offer them all the treatment possibilities and then make a discussion together. And I normally have more than one discussion with the patient and also make them go see the radiation oncologist, or they've seen them and coming back to us and make a decision. But there are certain points like which will make it happen. For example, if the patient is younger, they're going to live for many years to come, some of them might not have an aggressive disease. They might be more suitable for active surveillance. They can have a good quality of life for next 10 years. And then you make a decision, like if needed, at the time they can, progressors can have surgery or radiation. Similarly, the radiation oncologists have a discussion with them. Some of their family members might have a bad experience with radiation. They may not want it, but it's our job to tell them, hey, this is not due to the radiation, due to the individual patient. So at the end of the day, to make it simple, it's a clear, unbiased discussion with the patient, and the physician makes the difference.
Thank you so much. Next question for Dr. Jane Mendez. Jane, again, great talk, highlighting all the aspects of breast cancer. One of the things I wanted, if you would share with the audience, obviously, as you had outlined very eloquently in your talk, we've gone from an era, and we saw that with other surgeries too, from larger incisions to smaller incisions, quicker recovery times, preservation. Can you talk about the concept of neoadjuvant chemotherapy and surgery, especially in light with some of the data that is coming up with immunotherapy for triple-negative breast cancer?
Thank you. So actually, just before I came here this afternoon, I had one such patient. She came, 61 years old, triple-negative breast cancer. She's had symptoms since August, and she hasn't done anything. Clinically, the mass is already inverting her nipple. I felt nodes in the clinical examination. So right off the bat, I told her that she would most likely require neoadjuvant chemotherapy. So we can not only try to shrink the tumor to improve her surgical options, but also to try to downstage the lymph node. And I clearly stated, if I were to offer an operation right now, I would need to perform a mastectomy, plus I would have to remove all her lymph nodes. That alone would increase her likelihood of lymphedema from 5% to 20%. And she's a young lady. I don't want her to have 20% likelihood of lymphedema in her future, because that can really incapacitate her quality of life. So I immediately called one of our medical oncologists. They're going to see her. I also got all the appropriate studies, but that is part of that personalized care that we need to provide, and certainly she would benefit. And when we did chemo upfront in this setting, we expect at least 50% downstaging of that lymph node. So at least a half of the patients I'll be able to avoid having to complete the axillary dissection and save her the 20% likelihood of lymphedema. So is that the personalized approach that we need to have with every single patient? The other new patient, other story, 37, triple positive, just today. So also 37, she's had symptoms since May. She hadn't done anything. She was attributing to her menstrual cycle. So being triple positive, and also felt a node clinically. So she's going to need to also have HER2 targeted treatment, continue the therapy, immunotherapy for about a year, but it's just what we do every day.
Thank you so much. I think what Dr. Mendez shared really highlights the need for reaching out if you have doubt to us early, because we are obviously very happy to take care of patients if you think we can serve them. But I think reaching out earlier to us, I think would help the patients, because sometimes that can modulate how you will plan for the patient. And I think a lot of this is collaboration, us working with you, just like we do with a number of patients around the country who come to seek care. I thought I saw a raised hand. Please go ahead. Can we have a microphone there? Okay.
All right. I have it. This question is for Dr. Mendez. Thank you for your excellent talk. You had mentioned the innovations, especially with AI. Do you offer AI reading for mammographies, like as a second or third read? And the second question is, do you offer lympho procedure for axillary dissections?
The first question pertaining to AI is already integrated in our technology for mammogram screening. So our breast imagers are using it already, and already exploring other more advanced platforms that we might be able to benefit from. So it's already part of their readings. When it comes to lympha, pertaining to trying to avoid lymphedema, we are not currently performing lympha procedures here. I know it's been a research modality. It really hasn't been proven, as well as sentinel, as node transferring that can be used to try to avoid lymphedema. We are not currently offering here at Miami Cancer Institute.
Thank you. There's another question behind you. Yeah.
The proton treatment could be the new gold standard in breast cancer?
Well, I didn't hear the question. No,
The proton treatment could be the new gold standard in breast cancer?
No, not, we only consider it for left-sided breast cancers, where we know that the cardiotoxicity might be an issue. Over here, since Dr. Mehta and his team have all the toys in the world for radiation, what we do is they will do all the planning, taking all the techniques into consideration, and if it is a proton that provides the best plan for the patient, then they will proceed with proton therapy. But it will not be the standard for the time being. Dr. Mehta, you can add, as he's the expert.
There are 3 groups of women where we think proton therapy will potentially excel. One is women who need radiation to the internal memory lymph nodes, which puts the cardiac vasculature at high risk for getting radiation dose. Proton therapy excels at lowering the dose to the cardiac structures. The second is very young women, where even if we're treating a very small volume of the breast, the fact that these women are going to survive for a very long time and have considerable longevity ahead of them, the risk of a secondary malignancy, even from low doses of scatter radiation to the contralateral breast, can be diminished with proton therapy. And the third group of patients are women with unusual anatomy, where the standard photon radiation makes it very difficult to get around the curvature or the flatness of the chest to avoid radiation to the lungs or the heart. So these are the 3 groups that benefit from proton therapy.
And also, most of our patients are treated in the prone position, also with the idea to try to minimize any side effects to the underlying structures. So most of our patients are trained prone.
That's correct.
I see another hand.
My question is to Dr. Manoharan about the prostatic artery embolization. What's the role of that in the prostate cancer? And as a cardiology, I'm very oncology naive, and my second question to all 3 of you is, how big of a role is genetics playing in the cancer? So when you see a patient with the cancer, do you routinely do a genetic testing for particular cancer? If, let's say, if you're seeing a patient with a prostate cancer, breast cancer, we already know, but there is specific gene testing that you do for each cancer patient?
Sure. Thank you for the question. The question is about the role of prostatic arterial embolization. Mostly, it is meant for benign condition to reduce the size of the prostate through the, the catheterization through the femoral artery or radial artery. It's a very, very effective treatment. For prostate cancer, it's got 2 roles. For example, I have a very large prostate and I need to do a radical prostatectomy. The way I've done that is that I bring the patient to the interventional radiology, they do the embolization and then bring the patient down and do the procedure immediately, which shrinks the size of the prostate and reduce the bleeding. However, if you do the embolization first and try to do the radical prostatectomy, say a few weeks later, and there'll be a lot of fibrosis and the planes are not well developed, so it's better not to do it that way. So the main role is to reduce the size of the prostate to do the surgery better. I've spoken to the radiation oncologists. They feel that if I use the embolization, it causes ischemia, and in ischemic tissue, the radiation does not work very well. That's what I was told, and that's why we don't use it in the radiation oncology thing. With regards to the genetic testing and the things, right now, we are offering genetic testing to almost every patient at this point of time. However, in prostate cancer, if you have a high-risk prostate cancer, we send them for a genetic testing, particularly BRCA1 and 2. And in the kidney, we do also do it. But the bladder cancer, the role is very limited in the beginning.
So with that, I really want to thank all the speakers. I know we're a few minutes behind time, but the speakers will be around. And I would pass it on back to Dr. Ribas to conclude this session.
Do you want to take the genetic testing question as a global strategy?
So, I mean, I would just add, while Dr. Ribas is coming on stage, that, some of the talks previously also alluded to it. I think we think genomics is really the basis. We are understanding more and more. I did not talk about it today, but there are now drugs which are approved for genetic alterations across all cancers. So just to give you an example, larotrectinib, is a drug that is approved for people with NTRK gene fusions. So no matter what cancer you may have, you can actually get that drug. So just to give you an example, since I'm a brain tumor expert, glioblastoma, 1% of them have it. Now, it would have never been approved in GBM alone, but it got a pan approval. And similarly, a number of drugs are approved, red gene fusion drugs. We've got an approval for pembrolizumab for MSI high tumors, patients who are likely to have these genomic alterations that may respond beautifully to immunotherapy. So I think genomics is increasingly becoming an important part and parcel of how we treat our patients. And that also, I think family history is a big part. And so we have a genetics program where we refer our patients if they have either an alteration, a germline that we think would need a counseling with a dedicated person, and then discuss with them what would be needed in terms of their family screening as well. As we are learning more, I think we are advancing more and more. And one more theme I'll just say in a quick is that, as Dr. Diaz had alluded to, that beautiful case where he salvaged the patient's vagina for radiation, we are also seeing an increasing burden of cancer in young patients. And I think that is going to bring into even more importance this multidisciplinary management or getting your care at more comprehensive cancer programs, because you want not only to take care of these patients well, you expect these patients to beat the disease and live for a long term. So survivorship comes into the picture, as Dr. Mendez had talked about. So there's a lot more we can do for our patients now than we were able to do a couple of decades back. And with technology, I think this will just usher us a new era where we can serve our patients longer and with better quality of life.
Thank you, Dr. Aluwalia, and thank you for moderating an incredible session. Dr. Manoharan, Dr. Mehta, Dr. Mendez. Thank you. Round of applause for our Miami Cancer Institute team. And it's been an incredible day to learn from our multidisciplinary experts and cutting edge treatments. But on behalf of Baptist Health International, I would like to thank you and thank all our physicians and moderators today, even though they weren't here. After I couldn't see them, but I will in person. As we conclude today's program, I also like to express my gratitude to all those who traveled during this busy time of the year. And thank you for participating today. We're incredibly proud of the hard work and dedication of our doctors and staff, whose efforts have positioned Baptist Health as a global leader in healthcare and the premier provider of compassionate, high-quality care in this region. We hope your time has been productive and insightful, and we hope that this is going to foster the relationship to be able to share information and continue to grow. I think you've seen across so far the three divisions the same communication, and I think we are truly different. As a reminder, we're going to be taking a picture outside, so if I can bother you for one quick minute when we go outside, everybody, to take a picture. You're invited to join us tomorrow morning for breakfast, 7 a.m. At 8 a.m. before our final session, which will be the Miami Cardiac and Vascular Institute. And so we hope to see you. It's going to be a very informative day, and we're going to have our heart and vascular experts available. So after tomorrow's session, we will tour the Baptist Health Miami Cardiac and Vascular Institute. Shuttles will be available to transport all guests to the institute starting at 10:45. After the tour, the shuttles will return you here for lunch and adjournment of the symposium. Finally, I encourage you to stay for the next hour and continue networking with your colleagues. For those traveling home today or tonight, safe travels. Thank you once again, and enjoy the rest of the evening.